Good morning, everyone. Welcome to the National Institute for Occupational Health's COVID-19 Centenary webinar. It is a particularly interesting and very important and unique webinar in that it is the 100th webinar that the NIOH has convened online on the Zoom platform since March 2020. And it is quite a significant and long program. However, I would need to share with you some changes that had to be brought about with regard to the program, and that is mainly given the issues of time zones and challenges that our speakers have faced. One such change is that Professor Salim Abdul Karim finds himself physically at the moment in the northern part of the Americas and in the United States. That's particularly in New York. And the time difference between South African Standard Time and the time in New York is 6 hours. And we moved the slot to a later one. And I will share with you in a moment the revised program. His slot is now at 5 minutes past 2, which means it'll be 5 minutes past 8 in the morning in New York. Secondly, some of you might have heard a little informal chat on the Zoom platform earlier between myself and Dr. Ivanov. He also has some challenges he's facing, and we've had to shift his slot as well to a later time. And that means we are going to ask the stakeholder speakers from NEPAD, SASOM, SASON, SIO, NEDLAC, the business and labor representatives, and the WIGO representative just to start their sessions approximately 30 minutes earlier in order to accommodate Dr. Ivanov of the World Health Organization. And in terms of the original program that we had circulated, there were approximately, I think, 3 changes where, and you will discover that along the way. I'm not going to go into the details now, where we've had to change the name of the person representing the organization. And we will make that, make you aware of that change. And so soon I will be sharing with you the revised program. But in the meantime, I am going to ask Professor Eric Buch to the chairperson of the National Health Laboratory Services, the NHLS Board of Directors, to open his microphone, share his screen, and to do the welcome to today's NIOH COVID-19 Centenary webinar. And by way of introduction, as you all know, the NIOH is a specialized division of the National Health Laboratory Services, the larger mother body, and a sister entity and division of the National Institute for Communicable Diseases. And so with that, I'm going to ask Professor Eric Buch to just take over. I've not prepared my slide to introduce you in a more formal way, Prof, but please proceed. Thank you.
Great, thanks very much. And I wasn't able to test my mic, and we do have load shedding. So Ashraf, if I'm not audible, please let me know, and then I'll switch off my camera to reduce the bandwidth requirements.
On my side, Prof, your yes, audio is perfect. Please proceed. Thank you.
Great. Thank you very much. And thank you very much to the NIOH for affording me the privilege as the chairperson of the board of the NHLS to open this centenary webinar today on COVID-19, and an opportunity for all those in the field to reflect on the lessons and the learning that have come from this astonishing achievement of 100 webinars in the field. And I bring greetings from the entire board of the NHLS, and we have been following the work of our institutes, the NICD, the NIOH, as well as the broad laboratory services. And we're really very, very proud of what we've achieved and how we've stood up to the challenges and the demands to fulfill our role during the COVID-19 pandemic. I'm going to greet a number of our dignitaries by name and just to indicate where they come from, just so that I think everyone can get a sense of the extraordinary support that the NIOH has globally and in the country. And I've been watching on the chat as different people have been introducing themselves to one another as well. And so I'd like to start by welcoming and thanking for his participation today, Dr. Ivan Ivanov, the head of occupational and workplace health at the World Health Organization. In his absence, Prof. Slim Abdul Karim, the director of CAPRISA, and of course, the professor of global health at Columbia, and I suspect that's where he is at the moment. My old colleague and many old colleagues that I've seen both on the chat and here today as speakers. Many of us go back to the 1980s and the work we did there, around about when I did my diploma in occupational health at the NIOH, but we were all very active in many other areas of trying to bring an end to apartheid in our country. And a special welcome to Dr. Barry Kisnasamy from the National Department of the National Department of Health on the COVID-19 OHS workstream. But of course, Barry's had a much deeper involvement in occupational health in the country as well. Ms. Aggie Moila, the Inspector General from the Department of Employment and Labor, Dr. David Msiza, the Chief Inspector from the Department of Mineral Resources. And I think that again shows the intersectoral nature of the work of the NIOH. Ms. Chimwemwe Chamdimba from NEPAD. I always have a special affinity for NEPAD, having been the health advisor there from 2002 to 2010. And my colleague, Professor Koleka Mlisana, who we all know, she's here as the NHLS Executive Manager for Academic Affairs, Research and Quality Assurance. But of course, she chairs the Ministerial Advisory Committee on COVID-19. An old colleague, Professor Don Cox from the South African Society of Occupational Medicine, Ms. Denise Minnie from the South African Society of Occupational Health Nursing Practitioners, Professor Cass Badenhorst from the South African Institute of Occupational Hygiene, Ms. Lisa Seftel from NEDLAC, Mr. Cass Kavadia representing business, and I think everyone knows Cass's role in banking as well, Mr. Matthew Parks, a representative from Labour, Dr. Christy Braham from Women in Informal Employment, Global and Organizing, another good colleague, and many of them, I didn't say that all of them were good colleagues along the way, but Professor Mohammed Jibai, who's the head of the Division of Occupational Medicine in the School of Public Health at UCT, and Prof. Roger Naidu, who's also the head of Occupational Environmental Health at the School of Nursing and Public Health at UKZN. And I think there are many others, but I just wanted to take the opportunity to just pay particular greetings and appreciation to all of you for your participation today, but especially to all the dignitaries that I've listed here. And I think it just shows that we're sitting, when I looked earlier, we were sitting at 493 participants in this webinar. And that's just astonishing that a webinar, you know, on a day like today, at a time like this, still draws in around about 500 participants. And I think that's a tribute to the NIOH and the role it's played in the COVID-19 pandemic, and more broadly, the esteem it holds in the occupational health community. So, of course, it gives me great pleasure to welcome you to the Centenary webinar. I think many of you will know the NIOH well, but for those who joining, it's one of the institutes of the National Health Laboratory Service, together with the NICD, and plays an extraordinary role in providing occupational health and safety services to workplaces across a wide range of different kinds of services, from medical and clinical right through to workplace visits to look at hazards and give advice, and has played an important role both in the formal and informal sectors of the economy, and has developed a number of globally recognized initiatives in its fields. Of course ties in as well with another subsidiary of the NHLS, the National Cancer Registry, and we look forward now to developing its work in conjunction with the forensic chemistry laboratories, which we've just taken over, and we look forward to bringing the forensic chemistry laboratories performance and standards up to that of the rest of the NHLS. So today we celebrate this milestone of a centenary of webinars around COVID-19, and today's webinar is entitled Strengthening Occupational Health Resilience for the National Emergency Epidemic Response for South African Workplaces. And I think as we reach 100 webinars, I think it's important that we just look back and acknowledge the suffering, the grief, the hardship, the deaths, the livelihoods, and the impact on the economy and workplaces, on workers themselves as well, that we felt over the country over the past 2 years. But hopefully now we're rebuilding our way back, but there are many lessons to learn and much still to be done. And of course, we're tracking the positivity rate, but we're also tracking the pleasingly low numbers of hospitalizations and deaths as the next wave seems to be kicking in. The NHLS, of course, we are a public entity, which Section 3A public entity. We are there to serve in the national interest, not to secure profit. If we do make a surplus at the end of the year, it's a product of efficiency and performance in the NHLS, and those funds either go back to Treasury, but we usually try to negotiate that we keep them in the NHLS to continue to invest in the NHLS and in our institutes that we're so proud of. And we continue to support the NICD and the NIOH fully, in spite of some of the cutbacks in the conditional grants received for their functions. And so we started off, of course, in the NICD doing the COV-2 tests. Initially, we were the only people in the country doing it, but of course, we rapidly expanded that and decentralized it to our laboratories around the country and scaled up our capability for COVID-19 testing. We had pleasingly built up over the last 5 years with very tight fiscal management and strong governance and executive leadership. We had built up reserves and in the NHLS, from a situation where we weren't even sure whether we'd managed to pay the next month's salaries over the next 3 or 4 years, we built up substantial reserves. And so when COVID hit, we were able to invest towards 2 billion rand into all the requirements of additional equipment, additional reagents and tests, and additional staff required to meet our responsibilities without having to go cap in hand to Treasury to ask for an extra handout or an extra grant in order to allow us to fulfill our national responsibility. So we're very pleased that we were able to respond so strongly and positively within the NHLS, and we continue to play a pivotal role in our responsibilities, including around research and around service. And I think that the NHLS, the NICD, and the NIOH have really become household names for what we've been able to provide. Now, the pandemic, of course, has impacted very severely on workplaces around the globe and in our country. And the NIOH, of course, has been right at the forefront of that response. It's provided substantial advice and guidance to the NHLS board and to the executive management in drafting mitigating strategies and updating health and safety policies, both within the NHLS and, of course, way beyond that. It took the lead in creating awareness and advising workplaces in both the public and private sector in assuaging and preventing the spread of the pandemic. And I can say in my actual job, where I'm not being the chairperson of the board, I was one of the beneficiaries of some exceptionally good advice. So I'm a specialist in public health medicine. I have a DOH, but there were things that I really wasn't sure about. and I was able to go to the NIOH, and I was able to get advice beyond what I could know and understand, that was very, very beneficial in my own organization and responsibilities. So I think the excellence is there. When you're providing excellence to your colleagues who are themselves specialists in the field, then you know that you're really at the top of your game. And we've recognized that from the NIOH. And so the NIOH contributed to COVID-19 regulations, directions, guidelines related to workers and workplaces, ran webinars and other training events, and which we used to equip the industry with the tools required to protect and promote workers' health and safety, including the safe return to work during the pandemic. And I remember, as the chair of the board, you tend to get contacted by people looking for advice, including from the mining industry, for example, and I referred them on to the NIOH and got exceptional feedback on the response of the NIOH and the excellence of their work. And so therefore it really is a personal pleasure to celebrate with you this milestone today, the 100th webinar with more than 50,000 participants. I think the number at last call was 53,481 participants in the 99 webinars to date, and joining for training on different COVID-related topics. And so our collective action, responsiveness, and relevance as an organization have in the NHLS and in particular in the NIOH has demonstrated how we can contribute during a national pandemic and fulfill the national responsibilities that we've been given in terms of the NHLS Act. And I hope that today, where its purpose is just to really have a reflection day. So let's learn the lessons. And I think when I spoke to Dr. Spoor Khalamono, the CEO, the executive director of the NIOH, we were saying that what we don't want so much today is all the accolades and pats on the back. Yes, those are very nice, and we really appreciate them. But this webinar was not set up so that everyone could give us a pat on the back as the NHLS, and in particular the NIOH and Spoor's team, but rather to allow us to reflect on what we've learned from this experience, what we've gained, and how we can learn lessons that take us forward, how we can build partnerships, how we can establish new partnerships, and how we can even improve on what we believe has been, as a board, we believe has been an excellent response by the NIOH to the challenges. It really exceeded our expectations as a board, but we are still very keen to learn, and Spoor and her team are, as to how we can even take it further and beyond what we've already done, and how we can build on the foundations of unity and cooperation across the globe with colleagues in the field and with business and workers across the country, as well as the public sector. And I saw many participants joining from different public sector departments as well. So allow me to just take this opportunity to thank the NHLS CEO, Dr. Cami Chetty, who's tied up with other responsibilities with the NHLS board today, for her leadership, and as well Dr. Spoor Khalamono for her leadership of our efforts in the face of the COVID-19 pandemic. And I don't get an opportunity often enough as the chair of the board to really acknowledge the effort of all the staff of the NHLS, and in particular the staff of the NIOH, for the exceptional work that they've done. They really stood up and made us really exceptionally proud. They worked very long hours, and I really want to thank them for their steadfast commitment and dedication to their responsibilities, and to the work, acknowledge the work they've done, but at the same time just end off by thanking all our partners here today who provided support to us as the NIOH during this period, and we look forward to continuing to build our relationships and to continue to deliver for our country and beyond into the continent and make a contribution globally. Thank you very much for the honor of inviting me to open today's Centenary webinar. Thank you.
Thank you very much. And that was Professor Buch, the chairperson of the NHLS's board of directors. And there is quite a significant bio sketch I have here of him, but I will share that with you as part of the overall slides that we will distribute after the webinar. Our next speaker, pardon, is Dr. Spo Galamono, and she is the Executive Director of the National Institute for Occupational Health. It is my pleasure to hand over to her to do the opening and purpose of the Centenary webinar. Over to you, Dr. Spo.
Thank you, Ashraf, and thank you, everyone. Good morning, colleagues, partners, and friends of the NIOH and of the Occupational Health Fraternity. Thank you, Prof. Buch, the chairperson of the board, for such a great welcome, and also for addressing the special introductions of dignitaries. Thank you so much. So I'm not going to repeat the acknowledgements because you've done an excellent job. Thank you so much. So to that, I will just say all protocol observed. Prof, the last count, the number of attendees had gone up, and I think it was over 650 when I checked. And we know that it might even reach over 1,000, where people will have to go to YouTube. So thank you so much to everybody for the loyal support. So this year marks 2 years since the 5th of March 2022, when we had South Africa had their first case of COVID-19. Over this period, many lessons were learned and partnerships were strengthened as the Institute responded to the pandemic and the emerging needs of workplaces across South Africa and across the region, African region. On behalf of the NIOH, I really wish to acknowledge the leadership, guidance, and continuous support of our mother body, the NHLS. Its board, as it's chaired by Professor Eric Buch, the executive management under the leadership of Dr. Chetty, and also to our sister institute, the NICD, in the realization of the Institute's objectives and resulting outbreak response, without which, Prof, the NIOH would not have been able to pivot itself to be recognized as a leading organization in occupational health during those very trying times and confusing times of the COVID-19 pandemic. I would also wish to acknowledge our partners in government, and I'm not going to mention them by name because I think Prof has done a great job in doing so, but in particular, the National Department of Health, CSIR, and Department of Employment and Labor, and DMR, academia, and I think it's important for me to highlight the specific support we received from UCT, UKZN, UP, and WITS. Our professional societies, occupational health professional societies, SAYO, SASOM, SASHON, and SAYOSH, organized labor, civil society, and business, who contributed immensely in raising the Institute's profile substantially to position itself as a recognized and leading organization in occupational health during the trying times of COVID-19 pandemic. Some partners contributed financially and some businesses towards the systems and training events, while others contributed legal resources, admin support when we were trying to put systems in place to see how we can do the screening for the country. We are immensely grateful to all of you. As we may all know that the NIOH has been, and it endeavors to continue fostering a participatory and inclusive approach in terms of the broad scope of speakers and contributors on our training program. A special honor, I think, has to go to the multidisciplinary speakers that have delivered presentations to all our 100 COVID-19 webinars. You showed up, you delivered quality presentations, without asking to be paid a cent. I thank you. Thank you so much for your sacrifices and for your ongoing support. Amidst the backdrop of the global pandemic and our lockdown, remember the days of with immediate effect. We began to receive calls from practitioners and employers seeking guidance on what to do to remain in operation without endangering workers' health. I remember advising one of the supermarkets to conduct a risk assessment, to which they responded by asking me, what is a risk assessment? And we realized that, we need to develop some training or awareness through our webinars, and we quickly did so. We established an outbreak response team, which I asked Dr. Singh, elected her to chair the OHOT, we call it OHOT, Occupational Health Outbreak Response Team, to coordinate all efforts, starting with conducting the webinars. And I must say this was done very well. The team, it's a huge team, the NIOH team that was led by Dr. Singh has done very well. We actually stepped up and did much better than we thought we would have done. We conducted our first virtual webinar on the 9th of March. This is only 4 days after our first case in South Africa. And the webinar was done on contract tracers, and it was mainly around donning and doffing of PPE. These are the days where many people were told we need to use PPE, but they didn't know what PPE was, and they didn't even know how to use it. And we started that way. And since then, our webinars have been used to respond promptly to the need for equipping workplaces with appropriate tools and resources for COVID-19 prevention, and also for pandemic preparedness in South Africa and the region. I'm a proud mother today, as we reach our 100th online training event, that we have received overwhelming positive feedback from all over, from participants, from governmental departments, even from the Chief Justice Office, from private and public hospitals, businesses, professional societies, and our loyal attendees. Thank you so much. Our governmental departments and some of the organizations have since then utilized our training platform to host their launches and other important occupational health relevant milestones. And this just shows the immense collaboration and partnership and the opportunity that the NIOH affords to everyone for the benefit of the worker, whether the worker is in the informal sector or in the mining industry. We became the glue to the occupational health fraternity and the civil society. I really wish to thank the NIOH staff, the OHOT team, the training team, Mr. Ashraf Rightliff, Mrs. Jeanette Mangani, and Mrs. Tlengiwe Mzoneli for making all this possible, and everyone else who contributed to all the endeavors. The pandemic affected some of our specialized services. You know that you used to run to the NIOH for specialized services that we provide. But however, the pandemic also provided us with numerous opportunities for the Institute to emphasize its value well beyond the occupational health space. We raised our profile and digital footprint, placing emphasis on the value and importance of occupational health and safety provision within workplaces and beyond. Throughout our 2-year journey, many colleagues and friends unfortunately succumbed to COVID-19 along the way, but we soldiered on to fulfill our mandate to promote healthy, safe, and sustainable workplaces. As employers, we're legally obligated to conduct risk assessments through our direction from the Department of Employment and Labor. Our OHOT team played a significant role in designing tools to assist workplaces to conduct these assessments, and even adapted some of the tools for specific sectors and unique workplaces. These workplace risk assessments highlighted, amongst others, the importance of neglected hazards, namely psychosocial and economic hazards. The majority of stakeholders were capacitated to identify these risks, implement requisite control measures to prevent and curb COVID-19 in workplaces. We offered ongoing much needed support to workplaces amidst rapidly changing legislation. It was indeed a very, very confusing time where legislation would change and we had to respond rapidly. As the number of calls for advice mounted, the NIOH saw a need to establish a dedicated workplace advisory hotline, specifically for occupational health professionals, employees, and employers. The hotline has since been expanded to address general workplace queries beyond COVID-19. Queries emanating from this hotline are being used to form the basis or to inform the content of our webinars, and the caters for various occupational groups across different sectors. The training webinars conducted over the 2 years were underpinned by the NIOH's mandate to protect and promote workers' health and safety, and also provided guidance on the safe return to work. I am pleased to announce that the NIOH has also been accredited by QCTO, Quality Council for Trades and Occupations, as a skills development provider to offer 2 qualifications or programs on workplace preparedness and risk control for a period of 5 years. This is from March 2021. We also have since enhanced our training platform. At the end of this seminar, you will be appraised of the latest development and launch of our the NIOH Education and Training e-learning platform. Yes, we have made great strides. As Prof. Brooks said, this is not an event to pat our backs. Did we make mistakes? Of course, yes, certainly we did. We were not perfect at all, but we learned from our mistakes and we continue to do so. Hence the making of this Centenary webinar to reflect on the South African collective outbreak response, to identify challenges, lessons learned on this journey, and to provide a way forward on how to strengthen occupational health resilience for national epidemics, and also to enhance capacity for COVID-19 prevention and outbreak preparedness in South African workplaces. And we know that we cannot do this alone. Hence, we have asked so many of our esteemed speakers and experts to come to the party with us and carve this way forward for the betterment of occupational health in South Africa. In closing, we are grateful to all gathered here for your collaboration, your collegiality and support in ensuring workplaces were best equipped to handle the various waves of the pandemic as it evolved. With your support, the NIOH was able to contribute to COVID-19 regulations, directions, and guidelines. May we build upon these collaborations made and learn from one another for us to continue to grow from strength to strength as the occupational health and public health community. This is your NIOH. This is our public resource. So please feel at home, participate, and engage freely. Please, we do have a compendium on our website, which summarizes our journey, and there are also some very useful resources on our website. Please indulge yourself and make use of this useful resource for the public called the NIOH. I thank you. Thank you, Ashraf.
Thank you very much, Dr. Spoor. And on behalf of the overall team at the NIOH and all of the speakers that have contributed, approximately 158 speakers that have contributed since March 2020 till now, April 2022. On behalf of all of them, thank you very much to you, Dr. Spoor Garamono, the Executive Director of the National Institute for Occupational Health, providing leadership and ensuring that the teams here within the NIOH family can achieve despite the resource constraints and other challenges we face. So now I have the pleasure of introducing to you the next speaker, and that's Professor Koleka Mlisana. And I just want to do a proper introduction of Professor Mlisana, and just to quickly find my slides, which is not cooperating all that well this morning. So I found my slide, and I'm going to quickly share that slide for just a few seconds, Professor, if you can just bear with me. So I think I can just pause it there and then do the share. There we go. So by way of introduction, the slide will be on screens now. I have the pleasure of introducing to you Professor Koleka Mlisana. Professor, you can see the slide, right?
Yes, I can. Thanks, Ashraf.
Thank you very much. Professor Mlisana is the Executive Manager, Academic Affairs, Research and Quality Assurance at the National Health Laboratory Services, the mother body that the NIOH is part of. She was previously the head of Department of Medical Microbiology at the University of KwaZulu-Natal and at the AILCH. She served a term as a member of the NHLS board and used to be a member of the Ministerial Advisory Committee on Antimicrobial Resistance, a different advisory committee. Previously been an active HIV/AIDS researcher for over a decade, focusing on HIV prevention and pathogenesis, working at the Center for the AIDS Program of Research in South Africa, CAPRISA, and you will be meeting the director of CAPRISA later today around 2 o'clock. Undertaken seminal research which has revealed how the body responds during acute HIV infection. Current research interests include TB diagnostics, antimicrobial resistance, as well as sexually transmitted infections. Co-authored more than 190 peer-reviewed journal articles. And currently the co-chair of the COVID-19 Ministerial Advisory Committee. She's previously chaired the Pathology Laboratory Subcommittee of the first established MAC for COVID-19, as a member of the Board of Trustees for the South African National AIDS Council, SANEC, a member of the Medical and Dental Board of the Health Professional Council of South Africa and the Medical Scientists Committee, and finally a member of the Academy of Sciences of South Africa, the ASSF. With those few words, and I have to abridge that as well to put it onto the slide, I hand over to Professor Koleka Mlisana, who will be speaking to you on the topic, the National Health Laboratory Services and the National Emergency Response to COVID-19 epidemic outbreak in South Africa. You have had a little bit of insight when Prof. Buch gave a little bit of a taste of what the NHL has done. Now you're going to get the full chapter. Over to you, Professor.
Thank you very much, Ashraf, and thank you to the NIOH for extending this invitation to me. It truly is an honor, and I appreciate it very much. Thank you, Dr. Kalamono. And I really would just like to greet all the colleagues, esteemed colleagues that are on this webinar. And as our chair of the NHLS board, Professor Buch has already said, it really truly is a milestone, and we really want to clap our hands and appreciate the hard work that has been done by NIOH. And it really makes us as the NHLS employees very proud. Thank you for that. And I also really just want to quickly look at the topic that I've been given. I've been asked to look at the National Health Laboratory Service, NHLS, and the National Emergency Response to COVID-19 epidemic outbreak in the country. So I will share my slides, and please just tell me if you're seeing the correct version. And let me do that. Is that the correct version that's showing, or do I need to swap my screens?
It's showing well.
Showing well. Okay, thanks. Sometimes you see, okay, no, that's fine. Thank you very much. So I thought what I will do this morning very briefly, as requested, is just to look at where we have come from and what the NHLS has contributed in the response to the pandemic. Obviously, there's no way I can cover everything else. And knowing that this is an NIOH webinar, I'm sure that there's a lot that is still going to be presented around the great work that has been done by NIOH, as already mentioned. But also, I thought I'll just take a few, examples. And sometimes it's amazing how we quickly forget where we have come from. But if we look broadly at, when we first diagnosed, we had a positive case of COVID-19 in the country, one of the critical aims and main aims really was to look at how do we respond, how do we therefore stop the chain of transmission and therefore reduce morbidity and mortality. And I'm sure a lot of people that are in this webinar will remember this great slide, the presentation that my predecessor as chair of the MEC, Professor Abdul Karim, actually presented this notion that really at the beginning of the pandemic, what was critical, it was to identify the infections and make sure that we control those infections so as to stop the chain of transmission. And I mean, he would say you need to identify these small fires before they became big flames that would be very difficult to control. So that was the initial, response, and every effort was therefore made in identifying the infections and seeing how we can monitor and manage those infections. And this takes me to the next slide. I mean, I remember this was around April 2020. We were all reeling around, how are we going to face this? How do we manage this? And Slim actually put out this slide where we were looking at the different stages that we needed to take in managing and in responding to the pandemic, where we all know that actually during the first phases, we went through this complete shutdown. And what that complete shutdown did for us as the country, it actually gave us a preparatory phase as to how do we then increase, whether it's going to be testing, capacity, whether it's going to be clinical and medical capacity, whatever resources that were required by our hospitals, and generally prepare the communities. And I think also this is where even the training that we have seen highlighted already by Spo had to come in preparation. But I'm sure that neither of us knew that we were actually going to be looking at, more than 2 years, living with the pandemic. When it originally started, probably everybody thought this is just going to be a short phase and we'll conquer and we will be fine. But lo and behold, here we are 2 years down the line. Much as a lot has settled down, there's been a lot of immunity that we have actually managed to achieve. But they still, we cannot just rest and say we're over. But really, we have learned so many lessons. So we looked at primary prevention. How do we manage, a transmission? And then we went through the different stages of lockdown. It was important to find cases so that we could trace the contacts thereof and be able to actually control the transmission. And we're able to also move into a stage where we're identifying where the hotspots were, what was available for medical care of patients, and as already highlighted, I mean, the devastating, deaths and, that we have gone through and the loss that we have gone through as a country. So these were all some of the stages that we have gone through. We saw the preparation, we saw the primary intervention, we saw active case finding, where we engaged in large-scale community screening and testing programs. We saw provision of medical care to infected individuals, provision of oxygen across the country, and the challenges that we're facing as that provision was being made. And also, over and above all these stages, what we also had to go through was, as we were looking at case finding, it became quite apparent that, as we all know, that this is what viruses do, they mutate. It was important to establish a genomic surveillance, and I'll talk briefly about that. And also important, as the different waves were coming in with the different variants of concern were coming in, we needed to therefore monitor the immunity that was developed, by populations and anybody else who got infected, or when there was introduction of the vaccine vaccination, those that became, that actually were vaccinated. So we still need to continue doing this, and we will highlight towards the end how important it is to ensure that this continues into the future. We have seen the rollout of the vaccination program with all its challenges, which I will highlight now, and we really do need to find out some solutions as to how do we increase the uptake of vaccination. And I think we're now at a stage where everybody is looking to say, yes, we've had 24 months of a pandemic, but now we are really reaching a sort of a steady state where we understand well enough, the nature of COVID-19. But it becomes important to ask ourselves, how do we then integrate the COVID-19, programs into routine healthcare programs? Everybody has seen this, and this is really has been the history of the pandemic in our country, highlighted by these different and various waves that we have gone through. And as we now are all anticipating that there's probably likely going to be a fifth resurgence of cases, and we therefore have learned a lot of lessons throughout this, and a lot of action has actually happened, whether it's at lockdown levels, the various levels of lockdown with the national state of disaster, as well as some of the lessons we have learned as we saw wave one, which was the original virus, and then we were able as a country to identify the beta variant that swept across the country and actually was responsible for wave two, and we saw wave three, which was really due to Delta, and the recent, the wave four, which was mainly due to, which was due to Omicron, which was another variant of concern that was originally identified in the country. I won't bore you with the various levels of restrictions that we have lived through, but really we have seen the impact of some of these levels, and how, even though maybe originally at the beginning it was necessary to have such restrictions just in preparation for the pandemic, but we have seen how these levels have actually also negatively affected business and economy in the country. So how did the government respond? I think this was one of the key, areas, in that there was definite leadership, political leadership, and everybody now knows and talks about, the family meetings that are held by the head of the state, our president. And when you look at the actual structures that were set up by government, specifically the Department of Health, where then very earlier on in the pandemic, the Ministerial Advisory Committee on COVID-19 was set up. And later there was a committee, another Ministerial Advisory Committee on social behavioral issues, as well as the vaccine MEC. So really we have seen how the department, how the politicians have actually allowed scientists to assist them in making these decisions. And I think as a country, this is probably one of the key, positives that we have seen, in that the reliance on facts and reliance on data and evidence, and the fact that a lot of decisions that were taken in response to the pandemic were scientifically driven has really been a great plus for us as a country. Not without challenges and not without complaints, in other areas as well. But generally, these were these bodies that then were looking at all the data that was coming in and looking at everything else and who else would be affected, because we're looking at politicians who don't just look at science, but they would look at other departments as well and be able to make those decisions. And this is how we have managed to respond to the pandemic. But then just coming closer to the topic is that, what about then the support that NHLS had to provide in response to the epidemic? As we all know, that National Health Laboratory Service provide, laboratory services to all public entities, and actually covers almost 80% of the population of the country in providing, laboratory diagnostics, as opposed to the private sector. Even though we have seen a shift in the, in the testing as such, and I will come to this just now, but we were therefore primarily responsible for COVID-19 testing. Initially, this was, I think somebody did mention this already. This was initially performed, by one of our institutes, which is the NICD, which is responsible for surveillance, and they actually were responsible for initially, ensuring that there were containment steps that were put in place. But it became pretty obvious very soon that this was beyond, and there was no way that the NICD would actually be able to manage and do the testing that was required for the country. As a result, the advantage of the fact that the NHLS has actually got a full, country footprint with laboratories across the country in every public health center, we're able, therefore, to shift the testing then and decentralize it across the various NHLS labs in the country. But I mean, even then, when we started, we thought, the testing could be managed by the academic labs, but it became apparent pretty quickly that there's no way that would, even those academic labs would manage and cope with the need for testing that was required. So as a result, all the labs, within the country, they were quickly and speedily trained, to do the testing. And as a result, we're able to provide testing across the country. The other thing that also became very clear, because of the established technologies that we had in the country, during this time, we were able to utilize what was already available in the different labs, because we continue as a country to have a very strong TB and HIV program with, a first-class diagnostic platforms. And these same platforms were actually, because these are PCR tests, they were therefore utilized to actually do the, COVID-19 testing. So there was a lot of rollout, for COVID testing that was preceded by training that needed to happen very quickly. And over and above that, realizing the landscape that we live in, it became apparent that actually it's not just going to be enough to have, structurally, resident laboratories, but we need to actually provide mobile labs that could reach the areas that would not be easily reached, and we're able to take testing to the people rather than expecting the South Africans to come for testing where we know that some of them would not be able to. So when we look at the testing strategy that we had, firstly, identify the cases so that we can prevent the spread of COVID-19, identify hotspot areas for targeted interventions, because once you realize that there's a hotspot in a particular time, you can then hone in and ensure that the interventions that are targeted are actually focused in those areas. Obviously, it was important to do screening and test those who screened positive. And once those that were positive were identified, then it became important to trace, contacts so that we could contain the transmission. And so really all of this could not have happened without proper communication. And I'll be the first one to say, maybe that's a lesson that we could say we could have done better insofar as communication is concerned, as we now begin to see some of the negative impacts and also the influence of, misinformation and disinformation that we have seen during the pandemic. And then what was key, as we're preparing, as NHLS for testing, was to actually look at what are the needs, what's the diagnostic capacity that can be provided by the platform. And it became very clear that we really needed to increase the human resources, and that we just didn't have enough people that would do the testing and that would actually be, adequate to serve the country as more testing was required. I've already mentioned that we were able to use the viral load, HIV viral load and TB diagnostic platforms to improve and increase, the testing platform. I don't know how many of you still remember how, early in the pandemic, we had this challenge in that there was just no access to reagents and kits, even though we had the platforms. And we realized that because this was a global pandemic, there was a lot of competition and it became very difficult to actually access, some of the reagents that were required for testing. And there was also the availability and access to PPE, and how do you then transport and transfer the capacity that was available available in the country. So these were some of the challenges that we faced. I've already mentioned communication, and it became clear that we needed to look at the country as a whole and see how we can maximize capacity and upscale the services, wherein we had to identify additional resources that are available. Because it was just inadequate, there was inadequate in-country capacity, the local and global supply demand, the large-scale community screening, which really just overwhelmed the public labs, and we ended up with a lot of backlogs, in our results. And as a result, we then had to identify how do we then deal with the supply constraints, and that is where I think the introduction of multiple testing platforms came in, and there was this continuous engagement of suppliers where we needed to negotiate, test kits allocation. There was a lot of collaboration with the private sectors, because we realized this was a public, a pandemic, and it really has been very, exciting to see how we worked, so closely with the private labs, and the private labs were able to assist at times with reducing the backlogs. And so really there was a lot of working together. And another area that we did, within the NHLS was when we realized that actually we do have the academic institutions in the country who are familiar, and they, in their research, they really have been doing PCR for other, research tests, and they all came on board. And with the, funding from the Solidarity Fund, we're able to establish, various, universities that were available. They went through the assessments, capacity assessment, quality assurance, and they were able to then, take over, whatever, testing that that the labs were not able to cope with. So really we saw a lot of working together, whether it's the private sector, it's the academic institutions, and NHS as a whole. And in this process, we're also able to actually equip some of the previously disadvantaged institutions, in that they were able to get funding and were able to establish the testing platforms for COVID-19. Now, if we look at where we are today, we really have done more than 24 million tests, and there have been more than 4 million positive tests out of that. And what I was just highlighting, if you look at where this testing was done, there were more tests that were done by the private sector, and really one does want to put, one's head off to the private sector that they really just came into, and there were lots of labs that came out and said, we want to, to assist in testing, and we've seen a great collaborative, effort, and these are the results that then get published by the NICD, each and every day, looking at the number of tests that are done daily. What about the capacity for this testing? We have seen, I remember when we started, where, the Minister of Health would want to know, what's the maximum that you can do? What's your capacity? And we're talking 10,000 tests a day, 15,000 tests a day. If we expand the testing platform, maybe we can reach 50,000. But it really has been amazing how over the pandemic, as a country now, this looks at both the private and the public sector. I mean, if you look at the previous, a fourth wave, there's a day where we're actually able to do more than 100,000 tests in one day. And it really just talks to how everybody came on board, how capacity was upscaled, and how we have managed to respond to the pandemic. And some of this was made possible because we already leveraged on the existing molecular footprint that we have across the platform. This is now looking specifically at the NHLS, where we know we've been doing more than 6 million HIV viral loads. We've been doing, early infant diagnosis, and the molecular gene expert for TB diagnostics. We had those platforms, and it was therefore much easier to channel, COVID-19 testing through those platforms. And one other great advantage as the NHLS is that because we're a national, service, we have got a single, lab information system. And this system feeds onto a central data warehouse, which then from the, NHLS central data warehouse, this then gets downloaded onto the NICD warehouse, as well as the NICD then links all private testing. As a result, when we actually publish testing results each day, these are tests that are done across the country, whether it be private or the public sector. And this has really been a huge plus as we responded to the pandemic. These are just some of the assays that we have used, various assays that we have used across the country. And I mentioned earlier on that because of the national footprint and the various academic institutions that we had, when it was time to do genomic surveillance, it was very easy for all those academic NHLS labs coupling and in collaboration with CRISP, which is based in Durban. And I'm sure everybody knows about Professor Tulio de Oliveira, who really has been leading this genomic surveillance in the country. So as a result, because the testing comes to NHLS, we're able to identify, those cases, and then the samples that are positive, we're able to then move those for genomics surveillance. And a lot of work has been done, sterling work by South African scientists, in that we're able to be the first ones to identify the beta variant of concern and even the Omicron variant. So really, it has been the existing infrastructure that was there that allowed us to be able to achieve all of this. The NICD, as everybody knows, has done a sterling job as the surveillance body of the NHLS, where they've really played a pivotal role in surveillance and providing daily and weekly epidemiological reports. There's also been technical support to the district and sub-districts. One other, a great plus, what we also achieved during the pandemic was the establishment of this hospital surveillance system, which then was able to link the clinical data with the laboratory data that we had from the NHLS and the private sector. And this is one other system that we really are thinking is critical, and we need to ensure that it is maintained, into the future. And apart from really just everything else and this help that has been shown by the NICD, it really is to identify what are some of the systems that were established that we need to make sure that we keep them, in place. We have seen the rollout of the vaccination program. We are not happy with this at all because, if we're looking at, last week, we're still sitting at only 49% of the adult population that has received, vaccination. And we really need to increase this. And you can see the various percentages across the country. And if you're looking at the fully vaccinated, only 44% of the adult population of South Africans. And so for me, this is one area that we need to see how do we improve on it. We have seen a great challenge with vaccine hesitancy, and we need to find ways and means of actually improving vaccination. The impact of COVID-19 on healthcare services is something that we are all very much aware of. And, for instance, if one looks at, the changes in the number of patient visits came down, was definitely decreased, as well as contraceptive access to contraceptive methods across. So you realize that the other programs that had been going very well, they were negatively affected by the pandemic. And that is why now it becomes important to look to see how do we then bring back and integrate what has been focused on COVID-19 response into the general health system. And so really, as my last slide, I just want to highlight a few lessons that we have learned. The importance of working together, as I've already highlighted, the collaboration that we have seen, within South African researchers and scientists, the private-public partnerships, which really have yielded excellent, public health outcomes. And also how the government actually brought scientists closer, and as a result we're able to have informed and evidence-based policies in how to manage the pandemic. And also, I think the last thing for me, which is quite important, is that we really just need to ensure that we do not neglect, which we may have done, other health problems. So even when we get, other, pandemics into the future, it's going to be very critical to see how do we, from the onset, integrate whatever response we want to, to implement for that particular, pandemic. How do we integrate that into general, and mainstream health services so that we don't end up with the negative impact we have seen with, with COVID-19? It just really takes me, only a great pleasure to acknowledge Manda, who really was very instrumental in helping me put this presentation together. And I think I will end there. Thank you very much.
Thank you very much for that, Professor Kuleka Manisana. On behalf of the NHLS as the Executive Manager, Academic Affairs, Research and Quality Assurance, I'm going to ask immediately for Dr. Tanusha Singh to join us and to prepare to share her slides. I see it's being shared, and maximize it, please, and to check on her microphone. And by brief introduction, Dr. Tanusha Singh is being the chairperson and convener of the COVID-19 OHOT team, the Occupational Health Outbreak Response Team of the NIH, since March 2020. And she's just recently handed over the baton to Dr. Graham Chin. And she's also the head of the Immunology and Microbiology section here at the NIH. I hand over to you. If you could just change your display setting, Dr. Singh. At the top at display settings, there is the little drop-down menu. And if you choose the other option there, then we will see, we won't see your notes. So if you swap there we go. So I'm handing over to you. If you could just check your microphone. You have 20 minutes, and then we will have a bit of questions and a short break. Thank you.
Thank you very much, Ashraf. Am I audible?
Yes, you are. Clear. Thank you.
Okay. I've just turned off my video so that I am more audible. Thank you very much, Ashraf, and greetings to all. All protocols observed. It is indeed an honor to be sharing this platform with such distinguished and prominent speakers. The previous presentations has been very enriching and has provided context for today. And I have no doubt that the recommendations that will emerge from the rest of the presentations will be equally beneficial and crucial for the emergence of a more resilient occupational health system that we so desperately need so that history doesn't repeat itself. In this presentation, I will reflect on the NIOH's experience in response to the pandemic and the lessons that we have learned, and touch on some of the recommendations to complement others with the anticipation of future outbreaks. So if you will indulge me, this illustration is a powerful visual of the impact of COVID-19 and the price that many had to pay with their lives. And of course, not all of this is occupational, but many workers were indeed infected or affected due to a lack of occupational health systems or a poor occupational health response. It is a vivid reminder of the disruption to many spheres of working life and social well-being as the virus straddles both public and occupational health. South Africa is still the highest in terms of the number of cases on the African continent, and it is further impacted or compounded by TB, HIV, and the mental health, in inverted commas, pandemic facing many. The pandemic has starkly demonstrated that an aggressive proactive response is required to achieve occupational health and economic resilience. And whilst it is unprecedented, we have the benefit of hindsight and an opportunity to rethink our collective approach to preventing and controlling workplace risks. So let us rewind to 2020. We had anticipated that COVID would reach our shores, but we have never imagined the extent it would have, the significant losses of skilled workforces, if not in lives, then in rights, opportunities, and dignity. Inequities became very apparent with subsequent waves, with those at the bottom of the earning ladder being hit the hardest in both health and non-health care. The NIOH convened its first occupational health outbreak response team meeting coincidentally on the day South Africa announced its first imported COVID case. The Institute did not have an outbreak response team prior and had only contributed ad hocly to outbreak response in collaboration with other entities. Although treading on uncharted territory at the time, the team was committed to flattening the curve. When government declared the state of disaster, NIOH took its cue and direction from government to deliver on its mandate to contribute to strengthening the occupational health community's capacity to improve prevention and emergency preparedness in the workplace, and continues to invest in efforts to reconceptualize the occupational health response with a prevention and worker-centric approach, as what happens in the workplace affects communities and vice versa. It was evident in the early days that many employers were not prepared and did not have a well thought through and coordinated prevention plan to respond adequately, as many did not, and some still do not have the capacity and capabilities to manage such plans or programs. One of our key priorities was to advocate for employers to incorporate occupational health and safety principles in their business continuity planning as their actions predict their sustainability. We were acutely aware of our strengths and vulnerabilities, which impacted our level of response, but nonetheless, we endeavored to provide leadership in occupational health and make available relevant resources. To contribute to, we aim to contribute to and support policy development, procedures, and processes, developing occupation-specific material, provide or facilitate training to cadres of workers across various industries, encourage research to generate new knowledge, provide an advisory service, establish or support COVID surveillance. And our response could only be effectively achieved through a multidisciplinary team using comprehensive occupational health programs, robust coordination platforms, and across and harnessing on innovations across multiple fields. And through this process, we had learned many, many lessons, which I will touch on in the presentation. So COVID-19 has shown us just how highly unpredictable biological agents are and can emerge and re-emerge given their distinct evolutionary advantage. There are a number of factors that either fuel or compound the pandemic, which have different impacts and weights in different parts of our country and even the world. They result in new problems that emerge, as we've seen with chemical exposures from sanitizers and fogging booths in the early days, factors that result from new types of work, new types of workers, new technology, as we all had to adapt and adjust. So the NIOH had to keep its finger on the pulse as these factors emerge and had to respond accordingly in collaboration with the broader occupational health community and try to address it in the best way we possibly could, given our capacity and resource constraints. Our first lesson was to activate a participatory and inclusive multidisciplinary team to fully understand the risks and barriers to control and to identify the most effective multi-tiered approach. The Institute was fortunate in that it had many disciplines that meaningfully contributed to several facets of the pandemic, as earlier mentioned, including, for example, ergonomics, as a result of the force majeure where bedrooms were transforming into offices, alcohol levels in hand sanitizers were analyzed, and advice on microbial risk assessments were done, etc. The Institute also led the COVID vaccination rollout plan for workplaces in collaboration with the National Department of Health, Business, Labor, and other occupational health professionals. There was also a strong interdependence on our transversal functionaries, for example, IT expertise with the emergence of online webinars and conferencing and the need for IT developers for surveillance platforms, etc. And this was no mean feat, as we were learning by doing in the early days, and even our trainers had to be taught. So this pandemic clearly demonstrated the need for a multidisciplinary approach. We also learned the importance of collaboration and stakeholder engagement, as the outbreak was beyond any one entity, and thus we drew on the knowledge, skills, and expertise from within the occupational health network, partner beneficiaries, and allied professionals for a collective response to research, technical guidelines, training, etc. NIOH participated in and played a significant advisory role to several committees. Some of them are highlighted here in the subcommittees to effectively muster and enhance capacity to respond to the emerging needs of workplaces and to inject new ideas. This included our partner organization, the NHLS, who generously supported us and is led by Dr. Kami Chetty, Professor Kaleka, and as Professor Buch, the chairman of the board, has indicated earlier. We also work very closely with our sister institute, the NICD, and many government departments, in particular the National Department of Health and its structures, the Occupational Health and Safety Workstream Committee, in which many of our colleagues were members under the leadership of Dr. Barry Kisnasamy, who really championed the occupational health response at a national level and had opened many doors for us. We work well with many public health institutions, professional bodies, and many other entities. We also worked very closely with the World Health Organization, the International Labour Organization, and we are very grateful for the funding that we receive from many entities, including the BITS Health Consortium, through the Health and Welfare CETA. And thank you to Mr. Sagi Pillay for coordinating and leading that process. The collaboration and engagement has been very stimulating and productive, but it is unfortunate that it took a pandemic to realize our collective potential, but nonetheless must be maintained and strengthened. So thank you to the program director who will do the official recognition and honoring of all our stakeholders, and forgiveness if we have missed anyone in the process. There was a definitive need to raise awareness and competence on risk control for all actors across all sectors. So our aim was to provide credible information and promote workplace preparedness and prevention before, during, and after the various stages of lockdown. To capacitate participants, and in the early days, it was mostly the frontline and essential workers, but that expanded to all work sectors, in the hope that workplaces will take initiative to effect change subsequent to their participation in training. This was the genesis of the free NIOH COVID webinars, which became the Institute's digital footprint and was strengthened over time. Our face-to-face training rapidly transitioned to the digital platforms using Zoom and MST and YouTube to cater for an overflow. And this has greatly assisted us in reaching many, many more individuals. The training sessions covered a wide range of topics related to various aspects of COVID pandemic, and has recently been dominated by, for example, vaccines in the workplace. The training is also augmented with various occupational health resources, such as the videos, regulations, directives, posters, fact sheets, etc. And this is coupled with panelist activities to address questions raised during the webinars. We also do post-training feedback surveys, which helps us to improve. And it was also supported by CPD accreditation to address the professional development needs of our participants. We conduct the online MCQs as a form of assessment before issuing our attendance certificates to the delegates. So since March, as Ashraf and Dr. Spoor has indicated, we've conducted 99 online webinars, and these were reached over 53,000 attendees from both the public and the private sector. And this included many different groups, occupational medicine practitioners, occupational health nurses, occupational hygiene practitioners, environmental health practitioners, trade union representatives, HR representatives, etc. We had over 18,000 workplaces with an average of about 348 workplaces per webinar attending. And given the 99 webinars, we could estimate that we have possibly reached about 34,000 workplaces. The majority of our attendees were female, and the webinars drew mainly on the internal NIOH staff expertise, but was increasingly augmented with external specialists and expertise. The 150 speakers from various sectors contributed several hours of free expert time, which we couldn't quantify as the time for presentations doesn't include the preparation time and the Q&A time. Based on the available data, the majority of participants, that is the individuals and their workplaces, were mostly from Gauteng, Western Cape, and KZN. The data set is incomplete as we had not collected certain information at the beginning. These data variables were subsequently incorporated into the registration process and surveys. Nonetheless, I don't think the picture would have changed significantly. But the data does show us that there is a need to strengthen awareness efforts, marketing and networks within the other provinces. And again, we are grateful to the Occupational Health Workstream Committee, where there was provincial representation and did assist in raising the training profile. From the surveys that we had conducted, attendees responded that they had been empowered to take action within their workplaces, that the webinars have improved awareness, their awareness and knowledge, and that it has also address some of their concerns and interest, which was a positive thing for us. So through deliberations at NADLAC regarding workplace preparedness came the development of 2 skills programs, which was alluded to earlier, which NIOH was very instrumental in and developed. And the Quality Council for Trades and Occupations, the QCTO, has accredited the NIOH as a service provider for these 2 programs. And noting that the challenges that many face juggling work activities during the time the webinars applied to the NIOH, also had seen the need for an e-learning portal, and the Institute has been working very hard in terms of launching its e-learning training platform to provide training on demand, which a colleague of mine will present later in the program. We wish to grow this platform from strength to strength with the hope of it being a premier occupational health and safety training gateway as we strive to make training more accessible and continue to transform workplaces through knowledge. And these 2 qualifications will be the first to be delivered from this platform in the coming months. And if workplaces could invest in the qualification, it would certainly improve their readiness, as we found that many workplaces struggle with even conducting basic risk assessments. However, with all the training, knowing more doesn't solve problems. So we certainly need more leadership and political will and personal responsibility with leaders who can shape behavior at ground level. There's also a need to reinforce virus management narrative at school level and business world curricular level. Another profound challenge during the pandemic was the infodemic, which shaped how people understand and respond to the pandemic, and sometimes it undermines the public and occupational health responses. So the fight against COVID was also the fight against dis and misinformation. And over the 2 years, the NIOH has positioned its website portal as a critical touch point for quality occupational health and safety guidance and information dissemination. Through our educational content, we were effective at reaching stakeholders and workers from across the world. And in 2021, the top 10 visitors of countries that visited the website is listed on the table towards the right. However, only a few African countries we visited the website, which does indicate a need to expand our coverage on the continent. And some of these may be masked and the unknown, but certainly we need to broaden the scope. Effective communication is perhaps the most essential element amongst the lessons that we have learned, as it can either hamper or facilitate a good response. And given the perception of risk as a result of misconceptions, complacency, and a lack of knowledge, advocacy and awareness became mainstream for the team, and we prioritized enhancing access to reliable information to curb the mis and disinformation through the dissemination on our various platforms, including email, YouTube, and Twitter. This initiative resulted in the creation and dissemination of over 44 products relating to various aspects of the pandemic that impacted workplaces. Many are sector specific and are periodically revised and updated as new information becomes available or due to the easing of some lockdown restrictions and the lifting of the Disaster Management Act recently. The team has compiled a Centenary compendium, and I saw Ashraf have copied that into the chat. So I do encourage you to go through it at your leisure and disseminate it widely within your networks. We have recognized that despite our efforts, the information may not be reaching those that it was intended for due to access, literacy, and language barriers. Thus, the team is working on improving this through new initiatives and also investigating different means of communication. The general business fact sheet is available in English, isiZulu, Sesotho, Tshivenda, and Xitsonga, and the fact sheet on the informal markets and waste speakers were also translated into isiZulu and Sesotho. The process of translation is ongoing, and revised versions will be communicated accordingly. In addition, the NIOH has partnered with Braille's Essay, and we have printed a general business poster in Braille and disseminated to the blind community. This brochure was also translated into the South African Sign Language. We have also done several opinion editorials, and these are highlighted on the screen, but in the interest of time, I won't go through them. Apart from the website, the Institute continues to expand its digital footprint across the formal and informal economy. And we have definitely come a long way and have learned many lessons in the process, including adapting to the ever-changing landscape of modern communication. These communication channels provide the opportunity for networking on a global scale through strategically identified opportunities and targeting specific stakeholders through tailored communication. Aside from making information accessible, it was evident to us that we needed to be more accessible for quick responses. Thus, the Institute was successful in getting a toll-free number within 2 months from establishing the OHAD committee compared to requests more than 2 decades ago. So it did demonstrate to us that things can happen if there is a will to make it happen. The graph shows the patterns of calls received and the many queries that we have received on our info@ email address. And we found that the calls and the emails peaked during the waves and also when regulations and directives were amended due to the uncertainty regarding implementation of compliance at a workplace level. So this did prove to be a very useful tool. Vigilance is very important as an early warning signal to prevent further cases and alert the appropriate authorities to activate appropriate responses, as Prof. Koleka had pointed out. At the beginning of the pandemic, there was no entity or organization that was collecting occupational health data, which could provide valuable information to inform directives or decisions on planning, implementing, and evaluating workplace interventions. So data from multiple surveillance systems in both the public and the private sectors were used to monitor trends in disease, identify workplace risk factors, and design effective intervention strategies. The Institute was instrumental in the establishment of the occupational health surveillance system. We have about 5,600 business registrations to date, and we have also contributed to generating the reports of the healthcare worker admission surveillance. And our SHE department also interrogates our internal data from the OHASA system in terms of looking at case trends, risk assessments, and vaccinations. We also contributed to the Success Network, which contributes to wastewater-based epidemiology for SARS-CoV-2 surveillance. And I will just touch on some of the highlights from these reports to show you the richness of surveillance data. This is an excerpt from the OHSS 2022 report, and it really gives us a visual indication of the number of COVID cases that were reported on the system by job category. So this can inform workplaces on where to target their interventions. We also, from the healthcare worker surveillance data, we could see the patterns in terms of the number of cases, healthcare worker admissions and deaths by province, again, to give us an indication on where to direct efforts. And it also shows the timelines and trends and when vaccinations started and when the boosters also started. And again, it really helps for us to see whether interventions are working. This is another excerpt from the wastewater-based epidemiology, and this really shows us, where there are peaks in the RNA or the genetic fragments in the wastewater, and if there are peaks, it could give us an indication that there may be circulating cases within those communities, which then can activate responses accordingly. So in terms of research, as the pandemic was new to everyone, a lot of research had to be undertaken to find answers that could inform our response and even information that we were sharing. So just to contextualize, this is just a list of research that was undertaken by the NIOH departments, and there are many, many more research done by other entities that NIOH may or may not have been directly involved in, but are all equally important in generating new knowledge that can assist in accelerating our efforts and ensuring safer workplaces. And these were just some of the publications that came from the research that we had done, and some are still will be coming out soon. So just to end, given the rapidly evolving nature of the pandemic, all our efforts took a reactive approach, but the lessons that we have learned from the pandemic must not be forgotten, and we need to reinforce the need to strengthen occupational health systems to be more proactive. And I'm looking forward to the presentation by Prof. Chiba and Prof. Naidu on what can be done. But from our side as the Institute, we think that the success is underpinned by our resilience as a collective in occupational health, the implementation of comprehensive occupational health principles for all hazards, the review of existing policies, procedures, and risk assessments, stimulating research with identified priorities, finding funding for a holistic approach to risk management in the context of outbreaks, enhancing our multidisciplinary collaboration, enthusing an ethical and conscious behavior, and strengthening the enforcement systems. I don't think I will do justice if I did not thank the OHOT team for the sterling execution of NIOH outbreak response. The OHOT team was the vehicle that spearheaded the Institute's efforts. So to all the members of the team, thank you for your understanding and perseverance during very tough times, and for believing and entrusting the team with the mammoth responsibility of ensuring workplace preparedness during this prolonged pandemic. I would also like to wish the incoming chair of the OHOT team, Dr. Gehamshan, all the very best in his term as he directs us on this journey of building a more resilient outbreak response. On behalf of the Institute, the committee is extremely grateful for the tremendous and overwhelming support it received and continues to receive from the occupational health community and SANDRI in its outbreak response. The success highlighted here today is testament to the many enduring hours of selfless commitment by the many occupational health professionals and colleagues, for which I am humbled and truly appreciative of. Given that the fifth COVID wave is projected, we as a collective have a lot more work to do. So on behalf of NIOH OHOT Committee and the executive team, we thank you sincerely and look forward to your continued support during and beyond the pandemic. I thank you, and over to you, Ashraf.
Thank you very much. That was Dr. Tanusha Singh on behalf of the NIH's COVID-19 OHOT team, OHORT, the Occupational Outbreak Response Team, which she headed for the first 2 years of its existence. And now Dr. Graham Chin has taken over the baton from her. She's also the head of our immunology and microbiology section in the NIH. We are running behind, and I'm going to go immediately to Dr. Barry Kisnasamy. I'm going to ask Bruce Crespo just to type his question in the question and answer box. We're unable to take an open microphone position at this point in time, Bruce. So our next speaker is Dr. Barry Kisnasamy, who's going to deal with the topic of SARS-CoV-2, COVID-19 and occupational health. We focused on the broader sort of public health elements. We focused on the role of the NHLS, NICD. Dr. Tanusha Singh has brought us to the point of looking at the NIH's perspective and experience. And now we're going to ask Dr. Barry Kisnasamy to look at it from an occupational health lens, where he's placed at the National Department of Health, and where he chaired and convened the National Department of Health's COVID-19 OHS workstream. And so on that, we're going to be looking forward to his reflections on the emergency response to COVID-19 epidemic outbreak in South Africa, in line with the number of legislative frameworks, in particular the National Health Act. I hand over to you, Dr. Barry Kisnasamy. It's a pleasure having you on this webinar. Thanks.
Good morning, Ashraf, and thanks for inviting us. I just want to take a moment of silence, if it's possible, just to remember the colleagues in the health sector who have passed on or might be suffering the effects of long COVID, as well as workers in general. Well, apart from, you know, in general that have lost their lives to COVID. So could we have a moment of silence, and then I'll start my presentation.
Please proceed, Dr. Kisnasamy.
Okay, so at least we remembered those that have lost their lives in the front lines, especially of the COVID response, and together with the colleagues from NIO, did assist with some of the interventions and the workplace wellness programs and in other inputs. So I'm going to basically, let me just get my slides going. Ashraf, I take the slides are showing?
Yes, they are. You're on the overview slide. Thanks, Doc.
Yeah. So I'm going to quickly touch on the OHS workstream that dealt with the COVID-19 response in workplaces, touch briefly on governance, some of the activities we undertook, and then some recommendations. So the workstream came into being as part of the what's called the incident management team, which is the national COVID-19 response since early April 2020. Unfortunately, in the early stages of the IMT, COVID-19 response, they had completely forgotten about workers and workplaces and activities around it. So we did battle in the beginning to get a seat at the table. And I think that's one of the wider issues in pandemic preparedness, both nationally and internationally, that people often forget that this is an important component. And hopefully Ivan and colleagues at the International Labour Organization would be addressing these issues, that pandemic preparedness also has to look at this part of it. The second aspect, so that was the major governance structure dealing with the pandemic response. I did convene, as Tanusha Singh has pointed out, an early meeting in March, actually, to once I got notification within the Department of Health structures that there was the pandemic looming on our shores, noting the work in China at that stage, and the index case being reported in KwaZulu-Natal. We convened an early meeting, and I was grateful that the NIOH colleagues did turn up at the meeting at the NICD that we had in March. Now, the different governance structures that we work with are NEDLAC, and grateful that Lisa Seftel will be speaking later today, and some of the colleagues from the business sector. The JSOC, which is the Joint Oversight Committee set up between the Department of Health and Business for South Africa. Of course, within the National Department of Health, there are various structures, including the Technical NHC, which is the heads of departments of health in the provinces, and the National DG chairs that, and the National Health Council, which is chaired by the Minister of Health, and the MECs for Health and the Deputy Minister of Health, together with the local government and some other structures. Of course, we, as pointed out, we work with different structures that have made inputs to the OHS workstream, the NICD, the Medical Research Council, WHO and ILO. And very importantly, we also started at the early stage to make interventions through AUDA NEPAD in terms of both a SADC-wide process as well as an African Union process. We felt there were certain lessons that we had learned and put together, and could we share that with our counterparts on the continent. Now, the OHS committee itself was set up, which is made up of unions, private and public sectors, and professional societies, and really appreciate the leadership of Dr. Kalamono, who helped to pull the professional societies together as the convener, together with Graham Chin, and of course we and the various players that actually operated in the public and private sectors. Of note is a very interesting issue that the bulk of the delivery of occupational health services is actually in the private sector. And we have what are called employee wellness units in the public sector, apart from one or two provinces that actually have fully fledged occupational health chief directorates or directorates. Then the heavyweight and the heavy lifting was done by the OHS Technical Committee. Many of them are present in this webinar in terms of the academic occupational health departments and NIO, and including my colleagues from the National Department of Health at the MBOD, CCOD. So what did we deal with in terms of governance? We dealt with the workplace interventions in terms of the preventive aspects, in terms of transmission risk, and then the vaccination program. So we had two pillars: workplace prevention issues in COVID-19, in terms of preventing transmission risk, and if you have infected and affected workers, what do we do with them? And then the issues around the vaccination program. And of course, we also worked with multilateral agencies in terms of the interventions. We provided technical guidelines, and I'm not going to get into the details, but on personal protective equipment, HIRAs, hazard identification, risk exposures. We took on at a very early stage the support for the quarantine sites, and really acknowledge the role of colleagues like Dr. Muzi Zungu, who really came to the party in the early days when I was really battling to find human resources to assist us. These were quarantine sites set up by the National Department of Health, where South Africans were returning from abroad, and people will know that the airlines had mainly shut down, and we had to take on both the delivery of services as well as the preparedness of the quarantine sites so that they could be organized in terms of. So while there was the National Department of Public Works and Infrastructure involved and provincial departments, but we were quite involved in actually the service delivery, the risk assessments, and the site preparedness and monitoring of them. And Dr. Abada was also critical in terms of the coordination of the services with Aurum Innova. Technical guidelines on assessing workers with COVID-19. I'll give some examples later on. Appreciate the work of the occupational hygiene team led by Prof. Cass Badenhorst, who helped us with the ventilation guidelines. Did a lot of work on disinfection together with the infection control prevention colleagues within the National Department of Health and the academic units, particularly within the NHLS. And one of the big issues, of course, was the quality of sanitizers, the whole issue around fogging. We had these crazy notions on tunnels that could actually, sort out children, especially at schools, etc. So there was a major issues put in on disinfection and cleaning. And some of the work that Dr. Singh referred to was done by NIOH in terms of where we reached at a very early stage to say, is there quality assurance in terms of the process? Then support to NEDLAC and the Department of Employment and Labour on the directions with respect to COVID-19. Chair, I'm just checking, there's a hand raised. Is my voice coming through clearly?
Yes, it is. It's just that sometimes I think people want to ask a question, Doc, which we might not be able to handle now in terms of open microphones. We're going to encourage them to type their questions in the question answer box. Thanks.
Okay. So training has been covered. Again, in terms of leadership at a very early stage, we realized that training, this was a new pandemic. I mean, we've dealt with pandemics before, but this was a new, on a scale and that we had not experienced before, and getting to understand, and capacity building of both the occupational professionals, the capacity building of workers through trade unions, and various agencies. And I think Tanusha has done a great job in terms of the inputs. It was the National Institute for Occupational Health and the VITSAL Consortium with Segi Pillay that came to the party, support from the Health and Welfare CETA, and you've seen the website, training materials, call center, and a range of other issues that were done. Now, surveillance was a major issue that still affects us to date. I must say that it's useful to note that the OHS system has come to play. I mean, Prof. Nisha helped in terms of pulling this together, but I know that she also had changes in her career. So we do need to build on that workplace surveillance. One of the big problems, we don't have denominator data, and I'll reach out to that later on in terms of the issues. So we could never work out rates. We had purely numerator data, which did give us an indication, false enough, which were, there were workplace notifications. It did improve through the direction in NEDLAC through Department of Employment and Labour, where notifications were done to NIOH. So it was a directive to employers in the formal sector. And then later on with the TERS grant coming in terms of social relief to workers, there was a link in terms of the Unemployment Insurance Fund. One of the major issues, of course, was data sharing. I mean, we just, the hiding under POPI, personal information and data sharing. And I think those are issues that we'll have to pick up in another meeting on what went wrong. I think everybody's, tapping each other on the back on what went right. But we had a lot of dynamics in terms of what went wrong. And to date, I don't have a direct process about how do we intervene with the analysis of the information, collation of the reports, and then interventions in workplaces. Healthcare workers, again, major difficulties in terms of monitoring healthcare workers. Lots of different inputs from the DATCOV system, the PERSAL system, again, very major difficulties with sharing of information in terms of healthcare workers. Of course, the breakthrough was that the Department of Employment and Labour, and we must salute the Commissioner Mafata for making COVID-19 a compensable disease. But again, data was lacking in terms of reports from that. And maybe Lisa Seftel will pick that up in terms of, as we settle down a bit in terms of moving into the public health space and the Public Health, National Health Act, that we actually get these reports being presented probably at a structure like NEDLAC, both in terms of the OHSS, in terms of infected workers and compensable diseases that come out of the Department of Employment and Labor. So reports were unfortunately sadly lacking, and I battled to actually trawl through databases and websites, especially when you've got a busy day job as well. Thanks to Dr. Spo Kalamono and Dr. Muzi Zungu, we did a special audit of OHS COVID-19 response in health facilities, a sample of 750 health facilities. It left a lot to be desired, and at some other stage we'll have to pick up on that in terms of the process. And you could see the cries of the frontline workers and the trade unions in terms of the issues facing occupational health and safety. So while on this seminar plus minus 700, I would hazard a guess, and I don't know what the numbers are in terms of reach, in terms of public and private sectors, but what came through in reality was that 20% of workplaces in the formal sector in the country basically had occupational health services of any note whatsoever in terms of the country. So 80% of workers in the formal sector are not covered, and leave out this 5 million informal sector workers in terms of the inputs. Now, the challenge to us is, what is the National Institute of Occupational Health going to do in terms of delivering on this mandate of raising it together with our colleagues that have come together from the private sector, from the societies, etc. How do we increase, at least for the formal sector, to move that up completely? And you'll see from my work on the vaccination coverage, where there were large occupational health units ready to go, especially in the mining sector, they reached 70% vaccination. And of course, they have academic publications. So let me just start concluding then in terms of the vaccinations. So there was the preventive aspects, which dealt with a range of interventions in workplaces. And then there was a vaccination, which was part of then the intervention in workplaces when vaccines became available. So we rolled out the vaccination program, lots of policy debates initially in terms of targeting vaccinations by age bands, numbers of workers and sectors. Fortunately, we moved very fast in a red cap survey supported by WITS Health Consortium, Professor Warwick Sieve, and the team that helped us to develop a red cap survey, which was a rapid appraisal of a database of workers, because we needed the numbers of workers by age bands and by sectors, because of the limitation that we had on vaccines in the initial part of it. So as we know that health workers were rolled out first in terms of J&J, and then other workers in terms of the Pfizer vaccine that came into being and the multiple doses. And essentially, mining and large manufacturing, we reached vaccination rates of 70% vaccinated, even without a mandatory vaccination model. So with voluntary processes, they moved up. Some of the facilities moved up to even 95%. And that's something that we'll be picking together at some stage about what was positive and what was negative in terms of the vaccine rollout. Of course, training, sensitization, and communication was absolutely vital. And very important was the leadership of NEDLAC in terms of both the preventive aspects as well as the workplace vaccinations. So these are some of the updates that we used to get from provinces at our monthly, twice a month meetings that we used to convene, chaired by Dr. Rabada, and inputs from the different colleagues in the different provinces, the private sector. So we do appreciate that. I mean, we used to get attendances in the beginning up to 70 to 100, and then has fallen back to about 30 stable now. So we'll have to see what's the future of that committee. These were the guidelines on assessing a positive case and so that people had a way of dealing with, thanks to the academic colleagues, Prof. Rajan Naidu, Prof. Mohammed Jibai, who really, Dr. Muzi Zungu and Dr. Spo Kalamono and Dr. Graham Chin, who really came to the party in terms of the process of these COVID-19 guidelines, how to deal with a contact in the workplace, decontamination of the workplace, the training you've seen in terms of the distribution, the surveillance system and reporting, the data required in terms of the DEL direction, and reports that need to be done, infections, so we began to start tracking infections that was possible, but even with the data problems, recoveries, deaths, mortality, provincial breakdown figures in terms of numbers of health workers that we could track by per cell. These were the vaccination rates. Fortunately, we'd had this database in terms of inputs. We managed to tackle one part of the informal sector, which was the taxi industry. banking. So quite a few of the big manufacturing, banking, and this was the issue around the 20% were ready to go. And of course, these are as at November last year. So it's just an example of some of the reports that we were tracking at that stage in terms of this. And you can look at mining. I mean, it had already gone up by November to, a place like Goldfield, 71%, Anglo-American corporate, 68%. Of course, the numbers, this thing, but we do note that some of them have really come up in a big way. So the first issue was support and management support. Helped to conduct the orchestra and really appreciate the inputs. We had these reporting structures from provinces, and then twice a month with the private sector as well. PPE oversight and reporting was problematic. We got involved as well in helping with the private sector had set up a manufacturing circle, and we made some inputs in that. We worked with multiple structures in terms of government as well as NEDLAC. And then trade union involvement, active in the beginning, fell back after a while. And of course, fortunately, community and trade union involvement continues at NEDLAC level, but in some of the other structures, probably I think there were, also too many meetings, and they decided to give their efforts where they could. Business for South Africa was active virtually at all structures. The surveillance system for workers non-existent, so it's something that we'd have to look at as we go forward. You have a partial surveillance system for COVID-19, but we're looking at wider aspects which are being dealt with by the Department of Employment and Labor. So OHS, unfortunately, sadly lacking in the country, and COVID-19 showed the fracture lines in terms of the inputs. Appreciate the fact, though, that technically some interventions were made, and in terms of the 3 pillars, saving lives, saving livelihoods, and social distress interventions, I think we tried to do what we could in the OHS team, notwithstanding the multiple pressures on us in terms of also our day jobs. So acknowledge everybody's contributions, and thanks, Chair, for inviting us to make some inputs on the OHS interventions as part of the COVID-19 response. Over.
Thank you very much. That was Dr. Barry Kisnasamy, who heads the National Department of Health's COVID-19 OHS workstream, and there's been a long-standing, I think, relationship and working relationship with Dr. Kisnasamy around the issues of occupational health, and in particular, in this case, reflecting on the COVID-19 pandemic, what has happened, and you've seen some of the recommendations he's put there. So at this point, I'm going to ask, I'm just not sure if the next speaker is already in our, yes, I see there, Ms. Aggie Molilwa is online. I'm going to ask her to get ready, as well as Mr. David Msiza. These are 2 perspectives, one from the major National Department of Employment and Labor, where it is about monitoring, enforcement, and regulating our workplaces, and clearly the partner organization for the mining sector in terms of the Department of Mineral Resources. So we have first the Inspector General of the Department of Employment and Labor, and then we have the Chief Inspector of the Department of Mineral Resources and Energy. The topic that the 2 colleagues are going to be looking at and dealing with is specifically the COVID-19 impact on occupational health and safety, a reflection again on the South African workplace journey, emergency response to COVID-19 epidemic outbreak. Where are we, and the way forward, and particular recommendations that our 2 speakers want to offer us. So I am going to ask Ms. Aggie Molilwa just to prepare her slides and to check on her microphone. I'm not going to find that slide that I want to introduce you with much detail, giving your background and the expertise and skills you bring to your field and your role. Ms. Aggie, I'm handing over to you. Please proceed.
Thank you so much. Can you hear me?
Yes, yes. If you could just stay close to the microphone, that will be perfect.
All right, no, not a problem. Thanks you so much for having me, and also just for an opportunity to present our side of the story as the department. I'm going to try and share my slides. Please confirm if you can see. Can you see my slides?
Yes, we can see your slides. Maybe
Yes,
if you can just
if you
put
could
them
maximize
on.
it.
Yes.
Okay, no, that's fine. Thank you. Like I was saying, thanks for having me, and also just for the opportunity to share our side of the story. My slides, I've got about 35 slides, and I just came in at the tail end of the presentation that was being made. And I think some of the things that were being said resonate well and good with our experience as the department. Colleagues and ladies and gentlemen, you'll agree with me that nothing could have prepared us for a COVID era. So we were all taken aback, and we're caught with our proverbial pants down. And as you can see, I've got a number of areas that I'm going to touch, but I'm going to condense everything so that I stay within the 15 minutes that I've been allocated. Just in terms of background. Sorry, there's background noise. Can I go on?
Please put it on slideshow. It's not on slideshow.
Is it not on slideshow? Okay, let me try and do that. Can you?
Yeah,
is it fine now?
Yes.
Okay, thank you. Just in terms of the background, COVID-19 reared its head in the late 2019. We began to feel it as a country in 2020, the early part thereof. The pandemic, needless to say, touched a number of aspects in the world of work, and workplaces were trying to mitigate against the virus itself. And as a department, in particular, the branch itself, this affected our inspectors to a large degree. Most of our inspectors couldn't go out to do the normal work, as you'll recall, especially in the beginning, that most of the workplaces were closed. And the majority of our inspectors were not declared as essential. However, the OHS inspectors were declared as essential at that point in time. So they had an opportunity to go out to workplaces to conduct various inspections. And there were clearly the mother law or overarching law in terms of the Occupational Health and Safety Act is the one that was in operation, and therefore we're enforcing that. You'll recall that the country went into lockdown from the 27th of March. While there was a regulation in place in the form of the hazardous biological agents, a decision was taken to introduce stronger policy in relation to COVID-19 that responded directly to the pandemic, and hence what was put in place were the COVID-19 directions, and NEDLAC played a particular important role in that regard. Fortunately, during that time, our capacity as the inspectorate was also increased by 500 OHS inspectors that were added during that financial year. And on paper, however, in terms of recruitment, it took a bit of time. And the tally of OHS inspectors for the entire country before then was about 170, just over 170. So with the addition of the 500, the tally was then taken to over 600, which assisted us somewhat. But you know that before inspectors are ready to go out and really make an impact in the workplace, they need to be subjected to training, coaching, and so forth. We had a number of advocacy sessions, and mostly in the form of webinars that were conducted for external stakeholders. There was an increase in the demand of our services. And at that time, I'm going to be giving you details later on. We conducted more than 30,000 OHS inspectors just in the period of 2019 to 2020. As we continue with the presentation, you will see what the impact that you try to make. That is just a graphical illustration. I'm sure some of you will recognize some people in those pictures, just as the work that we do as the inspectorate and the type of branded cars that were also added in shortly before the pandemic. I just want to emphasize that in terms of the pillars of inspection enforcement services, it's premised on 3, which is advocacy, inspections, and enforcement. So when our inspectors go out to conduct inspections, we try and factor in these pillars to some degree. However, when we talk advocacy, we also talk to fully blown advocacy sessions such as conferences, seminars, which became webinars, and so on. And the inspection itself will be an activity of going out to test compliance levels, and enforcement will be an outcome of instances where there's non-compliance, what it will then kick in to make sure that there is a compliance. I spoke earlier on about the over 30,000 inspections that we did during the period of March 2020 to April 2021. Now, the stats that you see reflected there is a combination of both the public and a private sector. As you can see, the non-compliant levels were at 44%. And I need to point out that there was a variation and differences with regards to various provinces and then also private vis-a-vis the public sector. The public sector was sitting at, on average, at about 40 to 44% in terms of compliance levels, and the private sector was sitting at about 50 to 60% compliance levels. So that is showing you a breakdown also in terms of the provincial dynamics. As you can see now, this is just a graphical illustration of what I have spoken about. The highest non-compliance levels were in Mpumalanga, Limpopo, and KZN. And you can see the statistics there. This is also just showing you a further breakdown. I'll just go quickly through that. And, you know, during the period of COVID, I know that through our both anecdotal as well as administrative data, when it comes to compliance levels, particularly with occupational health and safety, we've always suffered, and we've always picked up that OHS is not necessarily a culture in various workplaces. Workplaces are fond of cutting corners, and if there's an opportunity to do that, they will really do that. So we found that with the coming in of sorry, I'm just trying to move my slides. With the onset of COVID, I see that they're moving backwards. I'm not sure why. Let me try that again. I don't know what is happening. It's supposed to be moving forward. Yeah. So this slide in particular is just trying to show a comparative analysis between inspections that we conducted in the financial year 2020 and to 2021 that I detailed earlier, and also April 2021 up to December 2021. So it's 2 financial years. We know that the current financial year has just closed last month. So our stats exclude the last quarter. And already can see the effect of having added more inspectors. So on a comparative analysis, you can see that we moved quite up with regards to the number of inspections that were conducted. However, when it comes to compliance levels, they were more or less the same. So we're not picking up an improvement in that area. This is just a graphical illustration that shows the 2 periods. And I just to pause a little bit and reflect on the majority of the non-compliance levels. Mostly they were found in the area of, you'll find that most workplaces didn't even have a risk assessment to start with. And once you don't have a risk assessment, I mean, it shows that you're not taking OHS seriously. So we picked that up. We picked up that when it comes to hierarchy of controls, the identification of potential risks and how to mitigate against that, which will seriously be linked into your risk assessment, was lacking. The challenges that we picked up is that some I've already mentioned, but the issue of working from home proved to be a challenge because not all areas had adequate network coverages. As a result, some of the work that we did in-house as the inspectorate suffered a little bit because we couldn't conclude our own work. Some of our inspectors were infected and or affected by COVID and had to either isolate from work or care for family members. And I also want to reflect on issues that, sometimes the things that we suffer are not easy to measure. Things like your mental health issues when people are working in isolation and so on. And when it comes to the fact that most workplaces were not prepared for COVID, it made our work even more difficult because in some instances, you'll find that because engineering controls are not in place, workplaces will be forced to close. So you'll find that in some instances we would have made a number of appointments as our inspectors, and you'll go there without prior notice. The doors are closed and there'll be disinfecting and so on and so forth. So we picked up those challenges. Also, I spoke about the enforcement wing earlier on. We picked up a backlog in terms of trying to push cases of non-compliance, particularly where notices would have expired. Normally, we'll give workplaces 60 days to comply, where just to correct their issues where we picked up non-compliance. However, during the COVID period, we even had to shorten the period further because we couldn't risk the lives of people. You can imagine if you give a workplace 60 days to comply with issuance of PPEs. I mean, it's things like masks and other things that will be related to PPEs, like your sanitizers and so on. So you can't afford to be too liberal in terms of the number of days that you would give. And ladies and gentlemen, you'll agree with me that when it comes to enforcing occupational health and safety in a home environment, it was a particular challenge because suddenly people are working from home, and you look at issues like ergonomics regulations, how suitable are home environments in terms of health and safety, things as basic as chairs, proper chairs to sit on, working hours, and so forth, and also policy gaps, because home environments are not necessarily viewed as workplaces. Therefore, you can't just willy-nilly be able to get into a home environment and try to enforce OHS. And so there was just glaring policy gaps. Like if a person was to get injured at home, then what? Would it be an injury at work? And I think some of the things we're still grappling with. We haven't necessarily wrapped our heads sufficiently around there to come up with policy dynamics that are going to assist us. And so COVID opened our eyes in more ways than one. So in addition to the administrative work that we did as a department, we also promulgated several policies. I've already spoken to the COVID direction, which emphasized obviously on just some of the administrative interventions such as the appointment of compliance officers, making sure that your workforce is trained, also looking at the hierarchy of controls, including engineering ones, things like I've spoken about at length risk assessments, ensuring that workstations are compliant. You'll recall that the issue of social distancing, the meters that were prescribed, adequate ventilation, and so on. So the COVID directions were particularly meant to do that. So the other part that we got in at a policy level was to introduce and publicize a construction COVID-related Let me go to the previous slide. We publicized construction COVID-related guidelines. Now, the construction guidelines were developed to address issues of compliance with COVID direction and other related regulations in the construction industry itself, given the fact that, industries are different. And when it comes to the construction industry, it's predominantly outdoors. However, that didn't mean that there shouldn't be observance with COVID guidelines and directions. And some of the things that we did under the COVID directions was to ensure that the construction guidelines ensure that employers are guided on how to comply with COVID regulations during all stages of construction work, from the project initiation up to the project closure. I'm just gonna really not touch in too much detail on the policy interventions. I don't think I've got enough time to do that. Some of the policy interventions that were brought forth, the whole area of hazardous biological agents. COVID-19, or rather the COVID virus itself, is a hazardous biological agent. So the promulgation of HBA had been drafted in such a manner that it provides the regulatory framework to respond to pandemics that may emerge in the workplace. The COVID pandemic also inclusive, also just forward-looking into other potential bacterial viruses of this nature. The regulations apply to all workplaces under the scope of the Department of Employment and Labor, whereby HBA is produced, processed, used, handled, stored, or transported. We also brought in amendment on the HBA. So the regulation also placed the onus on the employer to comprehensively instruct, inform, and train any employee at risk of being exposed or exposing others to HBAs with regards to the contents and scope of the regulations. I mean, this resonates also with what the OHS Act says, particularly in Section 8, where the onus is placed on the employer to make sure that the environment in which workers are exposed is both free of health and safety hazards, and also promotes the whole issue of making sure that the workers themselves are partakers in the whole space of making sure that compliance with OHS in particular is realized. So the next set of slides is also just giving more information on the HBA. I don't want to get into that. As I conclude, I think those sets of slides that I'm just quickly going through are just providing details with regards to HBA. And the reason the HBA is being lifted is that, like I said earlier on, I do need to emphasize this, that the HBA was precisely amended to make sure that it assists workplaces to be able to comply with the COVID-19 virus. And I want to also reflect on the ergonomics regulation during this time. We also had some interventions on the ergonomics regulation. These are applicable on the hybrid model that are being used in the new way of the work, as the cognitive aspects, as well as the changes in organizational policies have come to the forefront. Both the, I think there's something missing there. Both the cognitive and organizational aspects are one of the critical domains in the field of ergonomics. Basically, ergonomics, ladies and gentlemen, is talking to the concept of making sure that the workplace is adjusted to a person's health and safety needs rather than the other way around. And we know that when it comes to workplaces, we are fond of just standardizing things. just starting from tables and chairs that people sit at. They're just meant for average people rather than them being adjusted to individual needs. As the work environment itself has got to ensure that issues of ergonomics are taken into consideration. So what we've done during this period is also just to make sure that the ergonomics regulation is also adjusted and assist in the field of ensuring that workplaces are compliant. And as I conclude, during the COVID-19 pandemic, like I said, we conducted a number of inspections. I think all in all, if you're just to isolate the period itself, we conducted over 100,000 inspections. And sadly, the compliance levels remain painfully low. And if I was to share with you just in recent times, instead of us seeing an improvement in compliance with occupational health and safety, we seem to be picking up a decline. And the recent inspections that we conducted during particularly the latter quarter of this financial year, I mean, some provinces, the compliance level is with OHS is as low as 18%. And you find that different sectors are affected differently. And sadly, also, you find that also in public government departments, as well as the buildings themselves, the compliance levels are far from what is desirable. So needless to say that we promulgated a lot of policies during this time, like I said, and we also brought in various ways of beefing up our inspectorate capacity, not just in numbers, but also bringing in stakeholders. During this period, what we also did was to conduct inspections in a coordinated way. We'll have the Department of Health, in particular, we'll have police where necessary, and so on, because it made life easier, because we all had different areas that were looking at in terms of our mandate. However, in terms of the commonality, at the base of it was to make sure that there's improvement when it comes to issues of occupational health and safety. With that said, Chair, I thank you so much. And thanks once again.
Thank you very much. And that was the Inspector General of the Department of Employment and Labour, Ms. Aggie Moilwa, and dealing with the role of the Department of Employment and Labour, and you would have seen the many policy and regulatory aspects that had come to play as part of dealing with the emerging situation. We are now going to hear from the perspective of the Chief Inspector of the Department of Mineral Resources and Energy, and that's Mr. David Msiza. And he'll be also looking at the reflection of South African workplace journey, the emergency response to COVID-19 epidemic outbreak, where are we, and the way forward, and whatever recommendations might be very useful also for a crucial and critical sector, and that is particularly is the mining sector. Over to you, Mr. Msiza. If you could just share your slides and check on your microphone. And just a quick reminder to everybody, I see Ms. Aggie, if you could just go to the question and answer box there. I see there's specific questions for you with regard to issues of non-compliance and the role of the inspectorate and so on. If you could just look at some of the questions raised there for you. And then just a quick reminder, while we're waiting for the slides to be maximized, our OccuZone, that is the NIOH's newsletter, Occupational Health and Safety newsletter called OccuZone. That as a special edition this month, focusing on COVID-19, and it'll be coming out tomorrow. So just a reminder, a little quick flash for you that you must look out for it in your inbox. So I hand over to Mr. Msiza, who I mistakenly have called doctor, and he kindly called me before the webinar to remind me that I shouldn't be promoting him so quickly. He still has to do the thesis. And on that lighter note, I hand over to you, sir.
No, thank you, Program Director. In time, I'll be elevated to that level. Thank you very much. And a good day to all the the colleagues who are in attendance. I think on behalf of the department, I would like to say that it is an honor and a pleasure for us to participate in this webinar, and we gladly will share information. The presentation outline is as indicated on the slides there. I will introduce the presentation and indicate the timelines of all the interventions that we embarked upon as a department, and monitoring of COVID-19 compliance, and also looking at the cases and also the vaccination, and we'll conclude. It appears it's not moving down.
Yeah, you could try. There's usually these little very light gray arrows in the bottom left corner where your logo is. If you could just hover your mouse there, then you should see some little light arrows pop up there, bottom left corner where your.
Okay, there we go.
Okay,
no,
great.
thank you. In terms of introduction, I think the previous colleagues have touched on the various declarations of COVID-19, including by the World Health Organization, including by our state president, on the actions taken by the government. Now, our approach as the department is always of collaboration, whether it's in government, the different spheres of government, nationally, provincially, and also locally. So we've been working together as government on this particular matter, but not only as government, but also at the various stakeholders in the mining sector, the employers themselves in the mines, including the various organizations that represents the employers, more specifically Minerals Council of South Africa, SPASA, and the smaller mining organizations, organized labor as well, work together well with organized labor, including AMCU, NUM, Solidarity, and WASA, and the other organized labor that we've come together to deal with this particular matter. Now, in terms of the timelines, on the bottom left, after the various announcements were made, we gathered ourselves through an organization called the Mine Health and Safety Council, which is a tripartite organization which advises the minister on health and safety matters. In other words, we came together as organized labor, business and the state, and say, how can we respond to the various announcements, including the various guidelines that have been shared by the World Health Organization, the Department of Health, and also the NIOH, and also the Department of Employment and Labor. So we've looked at them, and then we came up initially on the 26th of March of what we call then the guiding principles on the prevention and management of COVID-19 in the South African mining sector. So in principle, the guiding principles were assisting the mining sector to comply with the respective guidelines that are referred to, but they were mainly risk-based. In other words, in terms of what we call the Mine Health and Safety Act, the employer is required to do risk assessments at the mine itself, based on the occupational hazards and risks that the workers might be exposed. But we've also said to them that in this case, they must look at the process differently. They must start from where the mine workers are coming from, and start from there, from the houses with the transport, to the change houses, all the way to underground and back to where the mine workers are working, so that they must make sure that we respond accordingly as the sector. And indeed, the sector came up with the protocols or procedures which were in line with that guiding principle. And our minister, secondly, also engaged continuously with the stakeholders to ensure that there's compliance with the respective pieces of legislation, which has been introduced through the Disaster Management Act. And we also, a minister, publicized some of the legislation that specifically are related to mining. Later on the 18th of May, we've agreed that we must come up with a guideline. A guideline basically is published in terms of Section 9 of the Mine Health and Safety Act that requires that the mining companies must come up with what we call the codes of practice, and then they implement them accordingly at the mine. So we've consulted extensively on those guidelines. We've actually workshop some of the parts of those guidelines on what we call the regional tripartite forums. We have across all the 9 provinces established regional tripartite forums where mine management, organized labor, and government officials come together to engage on health and safety issues of the mine. So we came together and make sure that we implement the guidelines themselves. Now, we are the regulators. We do engage with the respective stakeholders. We've engaged with COs, including organized labor, to come up with effective strategic interventions to mitigate and manage the impact of COVID-19 in the sector. As you know, the sector generally, the mines, they work in confined spaces. Our sector employs 450,000 people. So we've been encouraging the mines to be very vigilant on this particular matter. So we've continued doing our inspections and audits. In fact, we came up with our audit tool, which is based on the guidelines that I've referred to. Now, as an inspectorate, we are having plus or minus 150 inspectors that are part of the Department of Mineral Resources and Energy. And of those, for the period 2020-2021, there were about 8,030 inspections and audits that were done. And if you add up for 2021-2022, that's another 8,000, so about 16,000 of the inspections that were also done to ensure that there's compliance. Now, where there was non-compliance, the Mine Health and Safety Act, it gives us powers to issue what we call the Section 54 or Section 55 instructions. Section 54 instructions, basically, if an inspector goes to a mine and finds that there's unsafe practice or conditions at a particular mine, they can issue an instruction to halt the complete mine or part of that particular mine to ensure that appropriate measures are implemented to safeguard the lives of the mine workers. Section 55, basically, we issued just on issues that are serious, but not as extensive as those that we issued on Section 54. And you can see on the slide that there's been more Section 54 instructions and transgressions that were picked up and issued. Why we've taken that approach, because generally we issue more Section 55 instructions than Section 54. However, on COVID-19, we were saying to the mining sector, there must be complete vigilance. And hence we were taking these actions. Where we see that there's transgressions, we will take those actions. Now, some of the key areas that we picked up earlier of non-compliance is that the codes of practice will not be prepared in line with our respective guidelines that I've referred to. You know, some of the mining companies, for instance, will have 5 mines that fall under them, but what they will do, they just produce one code of practice for the entire mine, all the mines. The law requires that each and every mining operation must do their own risk assessments and then come up with a respective code of practice. So we've actually picked up that it was an issue. And also organized labor was not properly consulted in the development of this COPs and protocols, and we've said to them that it's very important that there must be collaboration. And the other thing that area that we've experienced as a challenge, especially at the beginning of the pandemic in 2020, was the issue of screening and testing. At that time, you know, the mines were doing a lot of screening, but they were not doing also a proper testing as well. So we've been also focusing on that. And another issue was the issue of vulnerable employees. Organized labor will come to us and say, look, some of the mines, they are using this particular issue to retrench mine workers, you know, and that has been a great issue for us. So hence we've engaged with the sector to say there are respective guidelines from the Department of Health, and we will require them to comply with those specific guidelines. And also, you know, with the occupational and medical practitioners were not properly also involved, and we've requested for that to happen. There were PPE challenges as well that we've also picked up in some of those of those mines. So these are some of the key areas that we picked up. Now, one of the things that we've worked out with the sector on is that We must collect information of the cases for the mining sector itself. We must share it amongst ourselves. We'll be working together with the Minerals Council and organized labor well. So on a daily basis, we could determine where are the cases they're like. So this slide basically shows the global statistics, including our South African stats, and also partly on mine. You can see at the bottom, on the bottom left of the slide, that the mining sector, the test rate in the sector was about 76.52%. That's, I think, is one of the things that we've been focusing on as a department to improve on as well. So and you also see that on the right-hand side, it shows the cases that have been reported by the sector and the recovery rate, which was beyond 98%. That's what you see that. Now, Dr. Berry also touched on the issue of vaccination. Yes, one of the key things that we have agreed upon as a sector, although that vaccination is not mandatory, is that at least we should put a target of beyond 80% of vaccination. Some of the mines have reached that. In fact, they've surpassed that. But overall, the sector went beyond 75%. But what we've said also as a department is that for those mines that have covered most of the employees, they must also assist the neighboring communities, which they gladly agreed to that, of which we are really appreciative too. The next slide shows the daily and total cases, the daily cases in blue, and the total cases in red. You can clearly see for the mining sector, the respective waves from the beginning of March 2020 up to date where we are as well. So I think it's one of the things that we've agreed we must monitor as a sector to make an impact if there are still challenges. As I conclude, it has indeed been an uphill battle to engage to deal with COVID-19. However, we will continue to collaborate with the sector as a department, because we believe that if we come together and work together, we will definitely make a huge impact. There is challenges in some of the mines with the vaccination rollout. We continuously work together with the sector to promote that. But lastly, because we are regulators, we continuously monitor compliance with this within the sector to make sure that we safeguard the lives of the mine workers and also the affected communities. Thank you for listening, and thank you, Program Director, for the opportunity.
Thank you very much. That was the Chief Inspector for the DMRE, Mr. David Msiza, and giving us the final slide there with regard to conclusions. There are some questions in the chat box that will be great for you to have a look at. And I want to just quickly ask the previous speakers if they just want to reflect on questions that they've asked. Is there any very urgent and pertinent questions that have come up in the chat, in the question and answer box, that you may have touched on before we proceed to the next part? There are some questions there about the new regulation from Bulelo Mteto, and I'm particularly directing this to Aggie.
You are muted, Ashraf.
Can you hear me?
Yes, can hear you now.
Thank you very much. Okay, so I just wanted to hear from Aggie about some of the questions there in the chat box. David, you probably will have a look at the chat box there as well. The questions that have been raised there. I see that some of the questions have already been answered as well by colleagues. I thought I saw Dr. Cass Badenhorst, Professor Badenhorst also answer some there. Prof, is there any particular question that was come up in the Q&A there that you may just want to quickly comment on? Prof. Badenhorst? Okay, I'm not sure. Can people hear me? Am I online?
There we go. Sorry,
Yes, we can
my
hear.
side, Ashraf. Can
Oh,
you hear
there we
me?
go. Yes, I see
Yeah.
you've been answering some of the questions there. Is there perhaps
It-
just one or two that has struck you?
It was a question around risk assessment, and risk assessment was highlighted by several speakers as a critical piece of work in this whole COVID response. And the question was whether risk assessment training is mandatory. To my knowledge, it's not mandatory yet. I think it's general practice across the industry and with larger employers to do actually do training on risk assessment, but I can't recall any specific mandatory requirement for employees to receive training on risk assessment specifically. But I will briefly touch on it in my presentation later on as well. Thanks, Ezra.
Then we'll do so. Yes, thank you very much. Okay, so
Can't hear you, Ashraf. You're muted.
oh, apologies. Yeah, I think our interruption of power here is playing a little bit with my my microphone switch here. So thank you very much to our two speakers, Ms. Aggie Moilwa, the Inspector General for the Department of Employment and Labour, and as well as Mr. David Msiza, the Chief Inspector for the Department of Mineral Resources. You would have heard from them as well what they saw to be the major achievements and what are some of the gaps that needs to be addressed, and particular recommendations. We hope to consolidate those sort of points made and ideas towards the end of this particular webinar. Okay, so right, so the
Sorry, Ashraf.
next, yes, please go ahead.
Yes, please. If you allow me about a minute or two, just to talk to one pertinent question that I
Go
thought I
ahead.
should ask. Thank you so much. There was a question regarding what happens to those that contravene prescripts of the Occupational Health and Safety Act. Now, 100% of non-compliant workplaces are issued out with notices. So mostly it will be contravention notices that will make up about 90% of the notices, and in most instances will give those workplaces about 60 days to comply. And then about 10% will be your prohibition notices. In instances where we foresee that there's immediate danger to human life, we'll then issue out a prohibition notice, either as a part or complete prohibition. And then just also to indicate that in instances that when we make a follow-up inspection and find that there still is no compliance, then we refer those cases for prosecution. However, those are very small percentages, around 1 or 2%. I thought I should add that. Thank you for the time.
Thank you very much. You're most welcome. Okay, so before I move over to a quick ergonomic break, I just want to share with you a quick slide as part of our honoring of the presenters that have contributed to the 99 and now the 100th COVID-19 webinar brought to you by the NIOH. And I just quickly want to find my my actual document in order to share with you. Yeah, I think I found it. Right. So I'm just quickly going to share the slide with you as a quick overview of there we go. So I hope, colleagues, you can see that this is page number 65 in the compendium. I've posted the link to the website for the compendium, and I've been reminded by our comms and marketing colleagues that this particular compendium has been placed on the, I think, homepage of our website, which makes it much easier to access. And just to remind you that our website is 0 rated. So this is just the quick list of, I'm not going to read the names, but in honor of those who are still in the building, there are a few people who were registrars or might have moved on to other organizations within the broader occupational health and safety family. So this particular list that I'm going to share with you next are the external speakers. And I just want to pause for a few seconds on each of these pages, and you can glance through the names of the contributors there, from Professor Dirk Brouwer at the top, down to Ms. Yvonne Ofosu Kwake, Muzi Ndlovu just above her from the Department of Basic Education. And you'll see that there's a whole host of people with different specialities, occupational medicine practitioners, occupational medicine specialists.
Yeah.
Apologies, I hear another voice. Okay, so yeah, and then you know, there's the colleagues from the different academic institutions, and then there are those from the different apologies, the different professional bodies, who are either dealing with medicine or occupational health, the nursing practitioners, the hygienist, the environmental health, etc. And then, you know, NIOH in particular, I want to also just make mention of, who also have their members as well as their leadership participate very actively in the webinars. The second page starts with Dr. Maureen Mpata from the Compensation Fund, and that highlights for me the contributors that we've had from the different state institutions, government departments, regulators, monitors and enforcement of the laws. And you just heard from two of those speakers in the two key fields of occupational health and safety, the mining and non-mining sectors. You will see that it includes in the list organizations from NGOs, tripartite bodies like NEDLAC, the scientific structures like the CSIR, etc., listed there, including the local government body. And then towards the bottom, you'll find quite a number of people from the private sector, who's contributed in their capacity as key people in their workplaces dealing with COVID-19 from an occupational health and safety point of view. And then finally, the final page there, we will see some of the legal people that was mentioned by Dr. Spoor in her own introduction at the beginning, and some of the labor colleagues that have contributed. And today, again, we have a colleague from the Federation that's joining us. And there, again, towards the end, you will see quite a list of people who are consultants, who are supporting employers and employees in the different workplaces. And one of those speakers was, in fact, somebody who just spoke a few moments ago, Professor Cas Bardenos, who represents SIO in this particular webinar. And then finally, just to read the last point at the bottom, the NIOH remains grateful to all partners and stakeholders for their vital collaboration and support in ensuring that workplaces were well equipped to handle the pandemic as it evolved. Through this support, we meaningfully contributed to the emergency workplace response against COVID-19. We aim to build upon these relationships going forward and learn from one another in order to champion worker health and safety in South Africa and beyond. So that is my brief stop quickly in honoring all of the speakers that have contributed. And I'm going to ask us just to take a quick short break, and we will be back in approximately that will be 12:13. So please take a short break. I've unfortunately can't use my ergonomic slides as the program has slightly changed and they might be a bit confusing, the content of the slides, but I'll play for a few minutes the pre-webinar and post-webinar slides. This will just give us a quick leg stretch and for us to do the quick stop maybe in the bathroom and so on. So we'll be back in 4 minutes. Thank you. Okay, welcome back, everybody. We are now going to look at the list of our stakeholder organizations, and that's the list as we would have started with NEPAD, SASOM, SASHON, SION, NEDLAC, Business and Labor. We are going to ask the NEDLAC speaker to speak first, and that's Ms. Lisa Seftel. She has another urgent appointment that she's got to meet, and we've agreed to accommodate her to start first. So if I could ask Ms. Lisa Seftel just to open her microphone and indicate if she will be sharing her slides, or if the slides need to be shared from my side.
Hi, Ashraf. I seem not to be able to show my video, and it says host disabled participant screening. So I'm happy to share my.
Now
if
we
you can let
ask,
me share.
we can ask our colleague Glenn in the IT department just to assist with that, because I think it's a basic setting that needs to be activated for you.
Okay, but I'm easy. If you want to share, it's also okay.
Okay, Glenn, if you could just activate Lisa's access to that feature. I hope I'm not sharing still. No, I'm not.
Yeah. Yes.
It's not okay. Maybe Ashraf, if you've got to just share, because otherwise we're just delaying things.
Okay. So let me just see if I can quickly find your slides. One moment. I'm in a folder here.
And the host has also stopped my video, but you don't have to see my face. Do you want me to start?
Okay, one moment, because I just need to quickly. Okay, Lisa, I think I found it. One moment. Right. Okay, I'm opening it now, and I'll be sharing it in a second. Okay. So that's sharing, and if you could just tell me if you're seeing the.
I'm seeing it, but it's not in slideshow.
Yes. Okay. And how's that now?
On my screen, it's still not in slideshow.
Okay. It's popping up. One moment. I think I'll have to reshare this.
Okay, Ashraf, do you want me to? Okay, can I start while you reshare?
Proceed, thanks. Yeah.
Okay, thank you very much, Ashraf, for inviting NEDLAC to this event, and also congratulations on the NIOH for your centenary. And you know, I think you've put together a very impressive presentation and very comprehensive. And I really will. And I see also that my colleagues, Matthew Parks, and I think Cas Kavadi is also speaking later. So in a sense, what has been also said, you know, some things have already been said by Barry and Agi and so on. So I will just try and provide a brief presentation on what the role NEDLAC has played in response to the COVID pandemic. I have put here what is the role of NEDLAC. which I think is familiar to most people, but is really to facilitate engagement and negotiation between government, organized business, labor, and communities on key socioeconomic issues. And over the last 2 years, there's been a very active NEDLAC rapid response team, which has lobbied, negotiated, provided feedback, implemented, partnered, and exercised oversight. And I think the significant issue is that it has been done with a high degree of consensus between what sometimes people say are partners who have a low level of trust. And on the right-hand side, there are the focuses that we have been focusing on, including the issue of health and safety in the workplace. If you can go to the next slide. Ashraf, if you can do the next slide.
Can you see the slide move?
No, the slide hasn't moved on my side, but I will keep going. My next slide really talks to what has been the approach of the social partners, and they've been guided by a number of principles which have been mentioned by other speakers: data and science, inclusivity, consultativeness, timelessness and being proactive, and certainty and predictability. And as well as acknowledging the limited fiscal space to provide relief when the economy closed down. Then the important measures which the social partners have really worked on has been ramping up vaccinations, and I think others have mentioned that very active role, particularly of business, as well as in enabling vaccinations, and then all the social partners in promoting vaccinations. And I see COSATU issued another press statement yesterday, mobilizing for vaccination. There has been a lot of debate within NEDLAC about vaccine mandates, entry restrictions, and vaccine certificates, some of which have emerged positively, others which are still in contention or which have not been successful. Promoting and enforcing non-pharmaceutical interventions, a lot of discussion about the size of gatherings and improving the management of large gatherings, particularly because of the impact of the event sector, and limiting restrictions that impact on the economy, and then providing relief. The next slide really tries to evaluate the achievements of the NEDLAC social partners collectively in terms of certain categories. I'm not sure if that slide is now, okay, that slide is showing, great. So obviously, you know, on the workplace, Aggie also there was an OHS direction, and there were a number of amendments which led us to opening up the workplace safely, and that's where there was this requirement for a plan. You did hear from Aggie that while it was there and it provided direction, there hasn't been a lot of compliance, and that also relates to issues that others have spoken about training and so on. The surveillance information management system, I did put a red here, unfortunately, Dr. Singh, because not many employers participated, even though it was a requirement of the amended OHS direction. And I think Barry also talked a little bit about this. The training, and a lot of this was done through and with the NIOH and the partners. And, you know, again, I think I put it yellow because while it was successful where it was taken up, as you heard from Aggie, it wasn't always taken up. And similarly, the enforcement by the inspectors. On the vaccination campaign, I think from a social partner side, there was much more success, lobbying, support, resources, partnership, and risk mitigation. And eventually, there is a robust system of issuing vaccination certificates by the NIOH. If you can go to the next slide. This really talks to other areas. A lot of attention was placed in NEDLAC on tourism and hospitality. A lot of efforts made and engagement around liquor and whether it was appropriate to have a liquor ban because of the impact on job losses and company closures. I think some lobbying did work, but in the end, we were not able to reach a tripartite agreement or multi-party agreement on how to address the liquor issues. Similarly, dispensations for interprovincial and national travel, a lot of engagement, not always successfully. And then similarly about inputs into regulations for consistency and implementability. On events and gatherings, we worked extensively with the event sector, theatres, or other sports sector to propose a dispensation that would see a safe return to spectators and audiences. I think that is still being cooked, and we hope that when we see the final NIOH regulations, that there is a dispensation which allows spectators and audiences. On relief, there was lobbying and oversight for the social relief discretion grant. There was shaping, oversight, and operational support for the UIF COVID tours. There was a lot of lobbying, and I'm sure Matthew may talk about it more, for an effective loan guarantee scheme, which didn't work. And there was, I think, successful work done to do no harm provisions for informal traders. If you can go to the next slide, which reflects the lessons, and reflections. And this isn't necessarily from myself, but really of the social partners. And I think that there's an acknowledgement by the social partners that if it wasn't for the collective efforts of them, through the issues of relief, vaccination, collaborating on regulations to safely open up the economy would have been not as effective. However, there have been challenges which we believe limited the effectiveness of the COVID response. I think we all know about the setbacks in the delivery of vaccinations, limited the ability of vaccinations, particularly to prevent the devastating third wave, which was a Delta wave. And I think it's also contributed to the ongoing low levels of vaccination and, the issue of public confidence. I think Prof. Melisani put it diplomatically that not always MAC was listened to because there are other concerns. In NEDLAC, often there was frustration that the best information, that data and science was not always used, which could have mitigated the negative impact on, for example, the liquor and event sectors. Often interventions were not as timely as they could have been. And the last issue really is again about the vaccine issues, that our collective capacity to communicate has not been as effective. And a lot of people have tried really hard, but we see this in the low vaccination numbers. But I think the other challenge is that responding to COVID involves a process of learning and unlearning as the COVID virus has evolved and our scientific understanding is enhanced. And really, it's a tribute to all of us to manage this learning and unlearning process. And it has been hard to take the public along with us. My last slide is really hot off the press, Ashraf, if you can go to it, which is what is our current approach to ending the state of disaster? And we have debated this for about over 5 weeks, and we were very lucky that the NIOH extended their timeline. So we have submitted this yesterday to the NIOH. And we have not sought, as the social partners, although some might have done so individually, to comment in detail on the COVID regulations, but rather to articulate, could I say, an alternative response based on the fact that we are no longer managing a pandemic, but managing an endemic disease while being alert for a new wave and having regulatory measures that can be triggered if necessary. We need to move away from enforcement through criminal sanctions to codes of good practice and guidelines. And I think there was a question raised in the chat about what's the difference, and really a code is a guideline. It cannot be enforced through a criminal sanction. Preventing transmission of the virus is less important than preventing severe disease and death, which would place pressure on the health system and pose a serious public health risk. And this is really a commentary on whether or not COVID should be a notifiable disease as such, or the corona, SARS, whatever. And then that one needs to also no longer focus only on COVID, but improving public health in general. And that the reason why we may continue to have mask wearing and hand washing is not only for COVID, but for TB and other respiratory and communicable diseases. So the social partners have suggested to the Department of Health that the regular dispensation to replace the state of disaster should include, firstly, a bespoke COVID-19 Department of Health regulation, which acknowledges the changing role of the virus, includes preventive measures justified by science, and has a trigger mechanism to enable the minister to bring into force more measures in the event of a resurgence. So unlike it in general, setting out what needs to happen, the more restrictive approach, only if there is a trigger mechanism based on science. Then for workplaces, you heard from Aggie about what the DL has done. Workplaces, including those open to the public, so including events and stadiums and malls and political gatherings, because they all happen in a workplace, should be regulated by the NIOH Act, the Biological Hazard Agents Regulation, and the recently published LRA Code of Good Practice on managing COVID in the workplace. And that, the Department of Health has argued correctly that there's a lot of lessons to be learned from COVID. And yes, that they should go into amending DOH regulations on ports and notifiable diseases and environmental health, but this should be put on a longer term trajectory. Ashraf, that is my presentation. Thanks.
Thank you very much, Lisa, for doing that and for the slides. I just need to unshare that. Okay. Unfortunately, the load shedding has caused a bit of chaos here on my desktop. Okay, so the next contributor that we go to, I'm also just monitoring when Dr. Ivan Ivanov is back online. I don't see him yet. He's Mr. Norman Koza, who's going to be representing OHIDA NEPAD in this particular stakeholder session. If you could open your microphone and share your slides, Norman.
Thank you, Ashraf. Let me try to share my slides.
And a reminder to people, I see that these, while Norman is sorting out his slides, Helen Hosmond and Ayabonga Nayakaza, please, your hands raising is not going to be able to be responded to. We've got too many people in the session to do that. Please type your question in the question and answer box, and the presenters will be looking at it there. Thank you. Are you managing, Norman?
Yes, I think I do. Finally,
Okay.
I'm sure you can see it now.
Yes, if you could maximize it. Thanks.
Thank you very much, Ashraf, and thank you to everyone. I think my work actually here is just to say congratulations to NIOH for reaching the Centenary webinars, and then also to just amplify the work of the NIOH actually since with them, because I think a Centenary actually is not a true reflective of what NIOH has done, and especially when it comes to the regional work that we're doing as well. But perhaps before I go to what NIOH has done in the regional perspective, let me just remind our colleagues who are not sure who African Union Development Agents, NEPAD, is. I think we are a technical body of the African Union, established in 2001 by the then, President Thabo Mbeki, actually, who was the chair of the African Union at that time. And the aim for it was for poverty alleviation, promotion of economic growth, and also sustainable development. But recently in 2018, actually, by then we were NEPAD program of the African Union, but now we're known as African Union Development. And the mandate is for us is really in the national level, actually, to strengthen capacity of the African Union member states and also to advance the knowledge in that area. The second one is to coordinate and execute priority regional and continental projects, and especially what we call Agenda 26.3, which was championed by our current, Minister of Corporate Governance, Nkosazana Zuma, who was leading that work as well. But also the third one, we are looking at serving the continent actually as a technical body of every area. Hence, we are coming in this area of occupational and safety, and also working with different departments including Department of Employment, Labor, Mines, and also,
Norman, have you moved your slides already? Apologies for interrupting you. On which slide are you now?
I think it's the third one, if I'm not mistaken.
On my screen, I'm still seeing the first slide.
Yeah, I'm not sure. Let me go back. Let me try to reshare, stop and reshare. For my site, it's moving. Can you see the third slide?
Yes, if you could maximize it, thanks. And you can proceed.
Can you see anything moving now?
Not on my side. Maybe the attendees can see it moving. You're on the third slide now with the colorful arrows.
Yes.
Yeah, please proceed. No, it hasn't moved to the fourth one. But if you're on that slide, please proceed. Thanks.
Okay, thank you very much. And I think finally on our mandate when it comes to globally is to undertake resource mobilization so that we can fund participation of the experts from different countries. As I said, that NIOH actually participated in our many webinars that we've done in the African continent actually. So that's how we get our funds to move forward. But on the non-occupational health and safety areas of some of the interventions that we are doing within the African Union Development Agency, we're looking at Africa Medicines Agency, which is the buzzword right now where we are establishing this Africa Medicines Agency. We have what we call Pharmaceutical Manufacturing Plan for Africa, which looks at even developing the vaccines within the African continent as well. But also, I think everyone might know the African continental free trade areas where we are looking at, integrating Africa. But when it comes to occupational health and safety areas, the interventions that were done with so many stakeholders, including Dr. Bear was here as well, who was leading in this AU expert group on COVID-19 workplace interventions, where we had two subgroups on that area. One was working on the training, which was a training subgroup headed by Professor Moses Zungu from NIOH, and then the other one was looking at the guidelines, which was headed by Dr. Moyo from Zimbabwe. So in those areas, when you look at the guidelines as well, that's where we came up with the AU COVID-19 at Workplace Guidance in Africa, which was published in the African Union a platform as well as Africa CDC. And then also within AUDA NEPAD, with the work of NIOH and colleagues from South Africa as well, we looked at AUDA white paper on situation in 5 key areas, on COVID-19 situation in 5 key areas, which included strengthening health systems, food systems, skills development, and employment, education, and national planning and data systems, looking at that area. But in that guideline, we, as subcommittee, we looked specifically on sector-specific occupational health and safety guidelines, where we looked at the clinical management, healthcare workers, mining, retail and food, education, and institutions, and also generic risk assessment, where we worked with different colleagues in that area.
Apologies, Norman, for interrupting. Are you on slide 4 or 5?
I think I'm on slide.
Because we still see slide 3.
Yeah, I'm not sure what's happening. From my side, it's moving, and this is what I'm sharing. I'm not sure whether IT colleagues can help. I sent you the presentation. I'm not sure whether you can reflect it from your side. Because from my side, everything is perfect, and it's moving.
So Norman, can you unshare on your side?
Yes, I did.
Okay, I'm gonna share from my side, because there's some comments in the chat box saying that the slides aren't moving. Okay, so the question is, can people see the slides?
I can see it from my side.
Okay, I'm just going to do the following. I'm just going to, one moment. Okay, so Norman, just tell me on which slide are you now?
You can go to slide 5. Unfortunately, colleagues have missed. I was targeting 5 minutes.
Yeah, okay. So go
Because-
ahead, or you're on this one?
Yes, so I just finished this one where I was talking about the AU subcommittee, and then I'm coming to training subcommittee, which was headed by Dr. Muzi. And these are the trainings that were done that yielded up to 2,178, trainings that were done in different topics. As you can see, the topics are there and the dates when the trainings were done. And I think most of the colleagues were there in these trainings as well. So can you move to the next slide? So this is the impact actually. The training covered almost 31 African countries. As I've mentioned, that said, when you look at the heat map, actually, I think most of the colleagues actually are coming from South Africa, and then we've got a slightly blue in the rest of the continent where people were coming from, but also we had colleagues from Australia and other Asia and China and stuff like that who attended those trainings. So really the impact of NIOH actually cannot be restricted to what you've done only within within South Africa actually. But when you look at the slides actually, it shows exactly how impactful NIOH was, because some of this training were done by NIOH. Next slide. So when you look at the outcome and impact of the trainings that were done, because we also had to move and do other training, we did more than 520 officials from Lesotho and Malawi as well, where we trained, the whole industry actually, whether it was police, military, whatever, and stuff like that, we did those training. The outcome actually, we received, 20 workplace risk assessment, reports coming from these countries. And also we had actually to also follow up in those areas where we took some of the experts to go to Lesotho and also mentor these colleagues in Lesotho and Malawi as well in terms of risk assessment. And the results of that also, recently we have seen statistics coming from the mining industries. And in most of our countries, actually, it is not what is happening in South Africa where you've got statistics coming from, the health sector, the different provinces actually. But now, because of those trainings, actually, we've seen that coming from those countries. So really, I think my emphasis actually was to say that NIOH has gone beyond, the South African boundaries of borders actually into African countries, and we are thankful to NIOH for the trainings that have done. I think that will be my last slide, if I'm not mistaken. Ashraf. Thank you very much.
Thanks to you. Thank you very much. And that was Norman Koza on behalf of AUDA, NEPAD, on your experience. I'm now going to ask our next speaker, and that's Professor Dan Cox on behalf of the South African Society of Occupational Medicine, to make his input. We are slightly over time, and we will be bumping into a next session, but if we can proceed and perhaps see if we can gain on some time. So Prof. Dan Cox, if you could share your slides and open your microphone.
Ashraf, good afternoon. You have to enable me to share, please.
So you don't have the right to share. Okay.
Yeah, not presently.
I'm going to ask Glenn if he can assist with that. I hope that this load shedding incidents we've had, I think 2 in a short space of time here, have not affected our systems. Glenn, could you please just activate Prof. Cox's ability to share slides?
All right, Ashraf, I'll change him now.
Okay, and then just colleagues, for those who are raising their hands, sometimes they do it by accident. I'm going to lower your hands, Nolotando, Masiza, Ayabonga, Nayakaza, and Roseanne Motswani has added hers. If you're experimenting with a hand raising function, this is not the time to do so. Okay, so can Prof. Cox share?
I'm still disabled. I'm still disabled, Ashraf.
Okay, Glenn?
Ashraf, to save time, I think let us start from your side, please. Will you carry on with slides?
Okay, one moment. I'll just have to find it then.
Huh?
Okay, you emailed it to me, right? That's not in this folder. One moment. Did the SASOM office email it to me, Prof?
No, we're trying from the office side also. Hello? Hello?
Can you hear me, Prof?
No, still.
Okay, I can't find your presentation, Prof.
Share, okay, there I'm clicking on share on this side. Let's see what's happening.
I can see
It
I
says
can see a
participants
screen.
can see my screen.
Yeah, I can see a desktop. I think it's probably your desktop that I see.
Yeah, but I cannot.
So
I don't
if
know.
you open the slide, you're clearly sharing at the moment. It's just that you need to open your slideshow.
But just close all this additionals. Is it visible now?
Yes,
Hello?
perfect. Please proceed. Yes. I can see your first
Afternoon.
slide.
Okay, right. Let's carry on. My video don't want to open, so I'm talking anonymously. Ashraf, Nayo, thank you for the invitation. It's really appreciated and an honor for SASOM to be part of this webinar. Our experience was that SASOM has the need to change in the confirmation of the changing world of COVID-19 and electronic communication. This is because the society from 48 has been operational within the ambit of the South African Medical Association, the Health Professions Council, the International Commission of Occupational Health, and so forth. But we are, as per definition, independent practitioners. Therefore, we as a group has started in 2020 with statements of the group. Remember, it's opinion. It started with the Thoracic Society, medical records, COVID healthcare risk waste, COVID occupational diseases legal update and reviewed, medical examinations, reporting duties to the NIOH. The position statement follow up later in the year with the screening as such of the pulmonary lung functions. And then the position of the employer in the mining sphere. In 2020, we held then also webinars. The previous was all written documents on the website and in the Journal of Occupational Health South Africa. Then we had virtual training sessions for our doctors and the interested people on mental health, the normal ethic constraints, legal and ethical impacts, cardiometabolic risk factors, spirometry updates, legal impacts of COVID-19, on the occupational medical practitioner, and then your chronic lung disease. Then we came to 2021. Through the whole time, we have, with the assistance of the South African Thoracic Society, published a guideline on spirometry. Because it was not part of the normal pre-employment or routine medical examinations, and the whole system changed with a new guideline. Then also we contributed to the paper in the International Journal of the Labour Organization. We had position statements on the COVID-19 vaccination in employment. And then with all the arguments going on, we asked one of our members, Dr. Lapere, to just publish a group viewpoint on vaccination in employment. And that was done in 2021 as a group SASOM statement. Training in 2021 for our members was also quite prominent. The introduction of quality assurance and quality control in spirometry. Preparing and conducting a spirometry test. Remember, it's going now back to normal, more or less, in the 2022. Evaluation of test results, interpretation, reporting, and record keeping. And then, because confidentiality in the health sphere, the Papaya Act and the Papaya Act, POPI Act, was also issues that we have to train or educate our practitioners, especially in relation to the Health Professions Council of South Africa rules. Then we have also a training on health surveillance and the services for healthcare workers. And then the Papaya Act, where everybody needs information and wants it. There is a certain restriction or an ethics, legal framework we have to work within. With all this said, during this time, we have sent out over 200 electronic information as such identities to our members. And it created a total new administrative burden within the society. Its additional responsibilities, the sources was from everywhere and anywhere, and then we have to decide, as you see the list down there, what is needed in our viewpoint for the doctors to be done. Especially with the TB and COVID information from 23 November 2020 till date was a very prominent topic among the medical profession and as such in the employment situation, especially with our own country legal framework. All of this happened because we interface with NIOH, SASOM, SIO, MMPA, and SASTM. We received numerous questions, and then we requested NIOH to have a webinar where all these questions was asked in the beginning of the vaccination process. We were also involved with the Department of Employment and Labour with the development of the hazardous biological agent regulations. And as Dr. Tsasami stated, we were also involved with the forum, the occupational safety workstream, and then we heavily, or day by day, week by week, we were involved internationally, communicating with the International Commission on Occupational Health and the International Occupational Medicine Society Collaborative. Publications this year, in 2022, because of all the confidentiality, the society decided then to publish the opinion of the group in the OSHA journal about information given that is statutory requested. We had also a position statement on the restarting of spirometry. The Thoracic Society say, yes, go on. And then everybody say how and when. So this is all published for everybody's notification and reading within the OSHA journal. In conclusion, I re-emphasize that the occupational medical practitioner is an independent practitioner that has to comply with different ethical and legal statutes and rules within South Africa. We are the society and group that knows what's going on and have the know-how. And that is why we were involved in continuous communication all over the 2 years that this whole COVID-19 and electronic communication system happened. That is why our recommendation is keep communication among health service providers as a priority need in future. Thank you very much.
Thank you. That was Professor Dan Cox on behalf of SASOM. I'm immediately going to hand over to Mr. Niz Mini, who's going to be presenting on behalf of SASON, that is SASOHN, the Occupational Health Nursing Practitioners. If you could unshare from your side, Prof, and then we'll proceed with the input and experience from the nursing practitioners from an occupational health point of view. Okay. There are some questions in the question answer box. I saw one also for Prof. Mlisana. And if the other speakers have already spoken, also just have a look there. I see that Dr. Cass is also answering. If you could maximize your slideshow, or as they say, go to presenter mode. I think you muted Ms. Mini.
Good day, colleagues, and thank you for the opportunity to present, especially on this milestone of the National Institute of Occupational Health. I just want to confirm if my presentation is showing on your side, Ashraf. I'm trying to share.
It's not. Oh, there we go. Okay, so now it's popped up, and you just need to put it into the. There we go. Please proceed. Thank you.
Thank you so much for this wonderful opportunity. And I would also like to thank NIOH, and especially from SASON's side, for being so proactive and assisting all medical professionals and employers for the information that was so informative, useful, and provided much guidance that we needed during the pandemic. So we are also grateful for the partnerships that we have created thus far, and we look forward to further ongoing engagements. So my presentation will focus on the occupational health nurse practitioner's perspective during the COVID-19 pandemic. Next slide. Sorry, Ashraf, I'm trying to
okay, so your slide's not moving.
My slides are actually not moving. I'm trying to just move to the next one. And let me just try again from my side.
Are you resharing?
I'm trying to reshare again, and I think maybe the problem could be that we're putting it into present. Are you able to see on your side?
Yeah, we can see the slides now. You're on slide 1, but we can also see the smaller slides on the left, so it's not in full screen mode.
Okay, let's try it again. Now,
there you go.
Perfect.
Yeah.
Okay. So
perfect, and it's moving. Thanks.
Okay. All right. Sorry for that, colleagues. So what we thought we would just share with our colleagues is that in terms of SASHON, firstly, you know, SASHON really appreciates, the NIOH training division for the prompt ongoing weekly Zoom webinars that you have been busy with. We found that this created, the opportunity. It was embraced by our members as kind of their lifeline, because it almost gave them the latest knowledge. It updated them on the practice, and that was really and truly thankful. So we'd really like to say thank you on that. We'd also like to share to say that in the year 2020, when the pandemic struck, it was actually the year of the nurse and the midwife, according to the World Health Organization. And because we could not actually have those celebrations, it was then extended to 2021. The year 2020 also marked an important milestone for SASHON because it was 40 years in existence. In terms of the impact on the occupational health nurse practitioner, we've experienced a few of these problems, and these were challenges that we've had to encounter. So one of it being that we've had this increased workload. It means that the occupational health nurse practitioner work now longer shifts. So whereas previously they would come on site maybe from 7 to 4, suddenly they were coming in at 5:30 in the morning to assist with screening. They had to cover through all the shifts, and they would actually be the last ones to even go off at night. And then they worked over weekends through the nights, and they had to address many of the concerns, the questions that came about. They had to, receive employees' COVID-19 results. They've often had to offer the health education that went with it. Employers were on us, asking the do's, the don'ts. And we just like to bring to the attention as well that all these occupational health nurse practitioners, they work independently, and most often there's only one on site, and that in comparison to how many employees there is. The second challenge was, the PPE control and the level of prevention. There was this lack of standardized PPE. We questioned the quality of the PPE for the occupational health nurse practitioners at their various workplaces. And at some places, there was actually the non-availability at times, which then resulted in unacceptable increase of exposure to the biological hazard of level 3 virus. We then saw, a job loss and insecurity amongst our occupational health nurses. And this was because, occupational health services, on some of the work sites, we're still generally not accepted by most companies as our safety component, which was more essential. And then we found that a number of our members, as much as they overextended themselves, the first departments or services that, had to go when the time of restructuring or, the company then decided, to discontinue was the occupational health service because they were not core business for most of these companies. And we then saw about 20% of our SASHON members who had lost their jobs, and a majority of us still face this insecurity as businesses are still trying to recover during this ongoing pandemic strain, especially with the economy. We also saw, the psychological distress, the mental ill health, the exhaustion, and including the moral injuries. But coupled with this, we seem to have noticed that there was this lack of emotional support structures. We did not have the debriefing sessions. Occupational health nurse practitioners had lost their colleagues, and they had this no work-life balance. So coupled with this was also the anxiety, the panic, the fear of even contracting this virus and spreading it to their families. And roughly just to say that SASHON has about 1,200 members across the country. And this makes up at least 10 regions across the country. And we had tried to come in the space and try to be more proactive and start being there for one another, and therefore initiated like careless groups, hybrid meetings and WhatsApp groups, just so that practitioners could actually then start to talk about their feelings, share information of what each one was doing, because the pandemic created a whole new scenario of what do we do? How do we do it? How do we go about doing it? And it then led on to the lack or the absence of the proper coordination from national structures, where it had to include the occupational health nurse practitioner. And we are saying that, SASHON and SASOM must be included in national health related decisions. Because I think it's only right to be fair and equitable practices for all occupational health nurse practitioners, including healthcare workers. And that must be, in terms of our occupational health surveillance programs for the healthcare worker especially, as well as vaccination programs, because it has to be for the occupational health nurse practitioner, as well as for what vaccination she is to do. And here we felt that, in terms of the isolation processes, especially at the workplace, when an employee came into contact with the COVID-19 positive employee, the occupational health nurse practitioner, as much as she's also an employee at the workplace, the standards were different, the rules became different. And we are saying that maybe the rules just need to be more fair, and it needs to be the same across the board, and so that it's applicable to all of us, because we are the employee as well. In terms of lack of recognition by some employers who continued, that our members experienced, a lot of members felt that, occupational health practitioners felt that there wasn't that thank you, or probably an allowance or the voucher or a bonus for the overtime that was worked during this time. And if you would look, the basic conditions of employment, if an employee works overtime or past the hours that they're supposed to, they are reimbursed. But this was not done for the occupational health nurse practitioner. So instead, more was of her time, her effort, all of that was given during this pandemic. And we have kept to that of, being that professional person. But sadly, in terms of being reimbursed for some of these services, that was not actually done. The impact then on the employer and the employees, we found that there was a lack of knowledge in terms of management, or, in terms of health-related issues, especially during the pandemic. So those that were fortunate who had access to online occupational health services, they relied on the occupational health nurse practitioner for all of this information, such as for screening, for disinfection of the office spaces, the development of prevention programs to reduce the spread of the virus. And suddenly the occupational health nurse practitioner became almost like a medical expert in the field, or an advocate, for what had to happen at the workplace. And then we started raising the questions, but what about the small to medium businesses who didn't have this occupational health clinic? What did they have to rely on, or who did they have to go and get their information from? And once again, this ratio of having one occupational health nurse practitioner on the site to many employees, it became much of a concern, because if that occupational health nurse practitioner actually contracted the virus or became ill, then that clinic had to be closed down during this critical period, which left that there was no healthcare services that could be rendered in that time. And then we found that the completion of the management of documentation, employers were actually unsure of what information had to be collected, or who the responsible person had to be, to complete these documents, until we, had the appointed COVID compliance officers. At the same time, confidential information such as the comorbidities was now being disclosed to non-medical personnel who actually lacked the understanding of what was expected. And in terms of papaya, that was also being disregarded. The impact, again, it went on to the disbelief of the COVID-19 pandemic and the vaccinations. So occupational health nurse practitioners had to persevere in reasoning and explaining why, because there were still employees and, certain managers, for instance, who didn't believe that there still was a pandemic or that people should get vaccinated. So we had to try by all means and try and persevere and say, it is a pandemic. This is what is being experienced, and try to do as much health education as we could. With regards to the COVID case management, the submissions became an issue for some members, as employers, often felt that employees could have contracted the COVID-19 vaccine, the virus, from any place or any other person, and not necessarily at the workplace. So what that then led to is, where we had to have these investigation task teams, where it would then comprise of your occupational health nurse practitioner, your occupational medicine practitioner, the employee, and their supervisor. Together, that team then would investigate and try and see, what was it that led to or made us believe that this person contracted, the virus in the workplace. In terms of the COVID-19 guidelines or the policies, members reported that although, the documents were distributed, it was apparent that some of these documents were not even read because they were too lengthy or they did not understand it. And once again, the communication breakdown, because it did not even filter down to employees themselves. So some recommendations even were difficult to reasonably be able to comply by the employer, because some, included almost an expense, such as, getting the equipment that was needed for testing, for screening, etc. So therefore, our recommendations for future planning of pandemics, which is very important. I think we all had a lot to learn from this pandemic. And going forward, I think it's also important and necessary, to see what our challenges were and to try and work on it so that we can overcome this. So Sashan is saying, please, and we must be included in discussions or initiatives that involve the workplace and health and safety policies, code of good practice or frameworks, etc. We do have the knowledge, we have the expertise of the workplace and occupational health. During the pandemic, the nurses, we were much needed, and we've generously assisted with information and the implementation thereof. Therefore, it's critical and necessary to participate at stakeholder forums, especially with the Department of Education, of Employment and Labor, and the National Department of Health, because we became that group also that did not get vaccinated. When we looked at healthcare workers, the occupational health nurse was not part of these groupings. And therefore, we had to appeal, and say, please, we are nurses. Our patients are our employees. Therefore, it's important that you do consult with us so that you could see what are some of our challenges. In terms of policies and procedures regarding the mental health and well-being of the healthcare worker, this needs to be addressed and prioritized as a matter of urgency. The cracks were there before, and now with the pandemic, coming on, I think it's just made it much bigger, much broader, and it's more visible now to be seen. So in long term, we need to make this priority. We need to also start prioritizing our health, especially with legislative frameworks, and probably create annexures for high-risk occupations and vulnerable groups of the workplace, especially for nurses, because this part seems to be omitted or not really clearly visible. There is also a shortage of nurses for the foreseeable future, that is both nationally and globally. The training of nurses for advanced disciplines need to be prioritized, including the ratio of an occupational health nurse to how many in terms of the number of employees that could be allocated. And then lastly, telehealth consultations. These were initiated by the occupational health nurse practitioner during the pandemic, but it should now become part of the norms. And going forward, this will allow us to reduce all our exposures and also allow for more flexible hours, and it will also ensure then there was adequate rest periods. Therefore, from my side and on behalf of Session, we would like to say that the training department of NIOH, we thank you for your COVID-19 series during 2020, as well as Session's members for all the inputs and feedback. Thank you.
Thank you very much. That was Ms. Denise Mini on behalf of SASON. I'm going to immediately ask Professor Cas Bardanos to enter into the fray and to just start the slide presentation from his side on behalf of the Southern African Institute for Occupational Hygiene. Prof. Bardanos.
Thank you. Can you see the slides?
Yes, please. We can see it. Please proceed. Thanks. And it's
Thank
moving.
you. Thank you. So members from SIOH represented the occupational hygiene discipline on the National Department of Health-led COVID-19 occupational health outbreak response team, referred to as OSH COVID-19 team, as Dr. Barry alluded before. A grouping of SIOH occupational hygienists led the initial workplace risk assessments at the beginning of the COVID-19 pandemic, specifically focusing on government laboratory facilities, hospital, quarantine facilities, etc., when very little was known around transmission and control measures. The SIOH also worked closely with the Department of Health in the development of the COVID-19 risk assessment guideline and risk assessment templates, which up till today forms quite such a critical, fundamental foundation of the workplace response to COVID. Members of SIOH also contributed to and participate in the launch of the hazardous biological agents regulations of the Department of Employment and Labour. SIOH also played a key supportive role post level 5 lockdown with regards to undertaking risk assessment at airports, fitness industry, theatre centres, etc. Okay. SIOH assisted in the training and awareness of COVID-19 and its prevention by participating in the COVID-related webinars from early 2020 to date, in conjunction with NIOH, SIOH, Department of Employment and Labour, and Workplace Health Without Borders. SIOH also published a number of position papers regarding the spread potential and social distancing of the virus, effectiveness of sanitizing sprays at building entrances, etc. As alluded to before by Dr. Barry, the Department of Health COVID building ventilation in non-healthcare settings guideline was produced by SIOH, and SIOH also held a dedicated webinar on ventilation as a control remedy for COVID-19. Since the start of the pandemic, SIOH effectively communicated all available and new communication guidelines, etc., on COVID-19 from the World Health Organization, ILO, NICD, etc., to all the SIOH members and stakeholders. So I just want to reflect some reflections specifically around risk assessments and controls when it gets to COVID. A lot's already been said around risk assessments. It is probably one of those very hot topics in discussion around risk assessments. We actually seen a lot of publications around COVID-19 workplace risk assessments in discussions around voluntary and mandatory vaccinations. And as one of the previous speakers alluded to, there's still a lot of unanswered questions when it gets to risk assessments, specifically when it gets to the workplace. So what's the objectives of the risk assessments? It's to identify and assess the potential risk of SARS-CoV-2 transmission in the workplace. But not just assessing the potential risk, also to identify control measures or the absence thereof, or opportunities to strengthen controls, and assess the effectiveness in ensuring that controls are in place to ensure the health and safety of employees in the workplace whilst at work, where the possibility of transmission of COVID exists, that this is prevented or measures are in place to minimize exposure, and also for employees to take reasonable care for the health and safety of themselves and that of other persons or colleagues who may be affected by their failure to do so. As vaccines become available, the risk assessments were extended to identify specific jobs, tasks, or activities that will require vaccination as a control for access to the workplace. In other words, where our other controls were not sufficient enough to protect employees, risk assessment identified those specific tasks or individuals or jobs that would require vaccination as a control. Okay. Through the work with the Department of Health and through Dr. Barre's team, we developed the COVID-19 risk assessment guidelines. And we actually identified 3 levels of risk assessment. And this was sort of a bit of a first time around that I think risk assessment was unpacked in this version or this way. There was a level of risk assessment for the workers. So we've developed a risk assessment that the shop floor employee can actually pick up, and did a simple risk assessment on his or her personal risk. You know, what are, considering where he or she is working, considering the activities, considering the workplace, a simple tool to assess the individual to assess whether it's safe for him or her to continue working there. And it's a simple yes/no format, as you can see there, for the employee to assess his or her own risk. Now, if you consider other forms of risk assessment or occupational health, workplace risk assessments, that is not generally an approach taken before. Then you've also developed guidelines for health and safety practitioners, for those colleagues that are more comfortable and have the skills in terms of risk assessment. So we've developed a guideline and templates around or facilitating risk assessments undertaken by the health and safety practitioner. And then also the highest level guideline, or most comprehensive guideline, is for the employer to undertake risk assessments. So these templates were then included in the guideline that was issued and are in use still today. We then also focus on the control, and apologies for the font on this slide. It's not intention to actually read it. It's just sort of an introduction to the next slide. One of the areas, again, I think if you reflect on occupational health and safety practitioner practices in general, everybody is quite comfortable around identifying the risks. You know, what is not that general practice out there is how to actually manage the controls. And I think COVID provided a pivot for health and safety practitioners to really understand, you know, what are those controls that need to be in place, and how do we actually keep on managing those controls to ensure that the workplace remains safe for colleagues to work in the presence of COVID-19. And there's several versions of how you can do it. Most companies adopted their current risk management methodologies and use tools like the bow tie analysis to understand, you know, what are those controls that would prevent transmission in the workplace, or what are those controls that, if we can't prevent transmission in the workplace, to control the consequences. And a number of industries, specifically the mining industry, has actually ended up with diagrams like this. You know, so this really is an example of a specific company's approach to managing COVID-19 in the workplace, where they've identified 10 key controls to manage work through their risk assessment to manage the pandemic in the workplace. And these controls were then implemented and managed actively. And it actually ranged from empowering employees to self-monitor their health and well-being, stay home when they do have symptoms, how do they report it, a very important component of educating and communication, screening and testing, that would involve, temperature screening, PCR testing, etc. Sanitary cordon, especially in the early days of pandemic, to actually close workplaces for external visitors and so forth, so make sure that we know who actually enters and exits the workplaces, social distancing, hygiene, cleaning and ventilation, de-densification of workplaces, respiratory protection, contact tracing and vaccination. And by employing the thinking around managing the controls as part of the response, actually, I think really gave employers something to actively manage the risk in the workplace. There's also lessons to learn, and I call a slide the COVID-19 pivot for occupational hygiene. Firstly, biological hazards in the workplace. I think many occupational hygienists and probably many occupational health practitioners were sort of caught off guard by the pandemic and by biological hazards in the workplace in general. If you consider what we are actually presenting to our occupational hygienists in their training modules, biological hazards is one of those topics that received very little coverage in the past. Much more time is spent on the more classic workplace health risks in terms of dust and noise and those things, whilst biological hazards probably didn't receive that much attention. So I think one of the key lessons for SIO and occupational hygiene is to go back to our training providers, go back to our course materials, make sure that we cover biological hazards in the workplace appropriately. Lessons learned around hazard identification and risk assessment. I think, again, if you consider pre-COVID risk assessments, it was very much based around identifying the hazards and monitor the hazards, as opposed to identifying controls and managing controls actively. I think, as mentioned earlier, I think if you look at pre-COVID risk assessments, workplace health risk assessments, when it got to biological hazards, were probably very light touched. So urge all hygienists to go back and make sure that when we do our health risk assessments, we make sure we apply efficient attention to potential biological hazards in the workplace. I spoke about control, design, monitoring, and management. One of the previous speakers did touch on respiratory protection as well. And again, I think all of us experienced the level of confusion that was out there in the beginning around which respirators to use, who should be using it, how do we maintain these respirators, what are the do's and the don'ts. I can just remember the initial confusion around N95 respirators and N95 versus FFP2 respirators and FFP3 respirators and who should get what and so forth. And again, I think we were caught slightly off guard around the management of respiratory protection. Now, again, there's a lot's been said about the type of protection out there, the protection of cloth masks and so forth. But I think in general, it highlights a gap for me in the local standards that we apply around respiratory protection. I know there was a number of incidents where respiratory protection was imported and we didn't have necessary test facilities and available test facilities to test these masks. So they ended up on the shop floor and a number of them had to have been withdrawn. So again, I think it highlights an area where we need to pay more attention in terms of how do we select our respiratory protection, or how do we firstly test and certify it, how do we select it then, and then it becomes around the application and maintenance. So it's one thing to make sure somebody's got a mask, but there's a whole management system needs to go around to make sure the individual knows how to use that mask correctly, how to maintain that mask, how to fit that mask properly. And in the workplace, I think we've all seen enough examples to come to a conclusion that we haven't done enough work around educating employees around proper fitment and testing of masks and maintenance of masks. COVID-19 also highlighted the point around vulnerable workers and how do we deal with vulnerable workers in the workplace. I think something that's been omitted from previous risk assessment process, risk management processes. Yes, we work with exposure limits and so forth, but that exposure limits necessarily don't account for vulnerable employees. And how do we make sure our risk assessment facilitate vulnerable employee in the workplace? A lot of lessons around collaboration, whether it's collaboration interdiscipline, collaboration outside of the occupational health discipline, collaboration between employers, employees, and state departments. I think all of us really had a good lesson the last 2 years around how we can collaborate much more effectively in terms of communication. Technology applications, we've all went through quite a steep learning curve on how to apply technology in our day-to-day lives, whether it's virtual meetings and other similar tools. Again, I think the occupational health as a discipline are slightly behind the technology curve. And I think COVID highlighted that to us again, is that there's a lot of opportunities for us to work more effectively with technology tools out there. The one thing that SIO did take away from the pandemic, and it's something that our executive board is working quite hard on, is through the work and through the COVID response and through a number of engagement, we've actually realized that occupational hygienists as a profession is not deemed to be part of the healthcare workers profession. And we had a number of discussions with various government departments, because this had an impact on how SIO responded. Because initially, when we as hygienists had to go out during level 5 lockdown to assist with risk assessment and so forth, occupational hygiene was not deemed to be essential workers. And it took a bit of effort and intervention from government officials to actually get our hygienists out there legally in the field to do these risk assessments. So up to now, we've not been successful in getting recognition for our occupational hygienists as healthcare workers and essential workers. And it seems to be that from a number of discussions, they are being left out. And it is a limiting factor in terms of ability for SIO members and occupational hygienists to execute their tasks. But it is something that our executive board will take forward and continue to engage with the various state departments and professional bodies out there. Ashrat, I think that's my slide. Thank you very much.
Thank you very much for that. And that was Professor Cas Bardonos on behalf of SIO, giving us an occupational hygiene perspective and in terms of the experiences. I noticed that Dr. Ivan Ivanov is with us, and I'm going to ask Matthew Parks and Dr. Chris Ibrahim if it's okay with them just to give Dr. Ivanov an opportunity to do his presentation. He's under some sort of time pressures on his side, and we did schedule him to start at 1:30. Just a quick response. Matthew, Christy, is that okay with you?
Yeah, it's fine by me, thanks.
That's fine. I do need to go at 2 p.m.
At 2 p.m.
Yes, I do need to go then.
Okay, so maybe we should just ask you to quickly do yours, Christy.
Okay.
Before we move to Dr. Ivanov. Thank you very much. Please just proceed. If we could stick to the sort of 8 minutes section there. Thanks, Christy. Go ahead.
Okay, I'll try and be quick. Can everyone see my screen?
Yes, and it's maximized. Thanks. Please proceed.
Okay. I hope these slides will change. Yeah, okay. Hi, everyone. My name is Christy Braham. So I'm the Workers' Health Coordinator at WeGo, Women in Informal Employment, Globalizing and Organizing. Thank you very much for creating space for us to join you today. Just a quick background, very quick background. So WeGo is a global network of researchers, development practitioners, and workers in the informal economy. We work across the world, and we do have quite a few team members across South Africa. And when we talk about informal workers, we're talking about those working as reclaimers, waste pickers, street vendors, market vendors in the spaza shops, domestic workers, also home-based workers as well. This is just a map showing the proportion of workers in informal employment across the world. And at the bottom, you can see there's an orange circle which represents South Africa. And actually, informal workers represents 24% of the workforce in South Africa. So, speaking on informality and OHS. So, workers in informal employment do remain pretty exposed, but still largely unprotected in the workplace. And that was true before the pandemic and continues to be true now. Now, workers in informal employment are mostly uncovered by occupational health and safety laws and frameworks, including in South Africa. Now, this is because when you're informally employed, that the employment relationship is outside of the more standard formal employment relationship. When you work in urban public spaces like a marketplace or in a landfill, these places are not fully regulated, so not necessarily covered by the OHS laws. It's outside of the formal workspace, as I've mentioned. And of course, you know, your access to health and safety provisions can be determined by the location of your workplace and therefore your occupation. So it can vary because, of course, informal work is very, very, very varied. So this means actually that workers who are informally employed are often forced to become self-reliant in managing OHS. And this is extra difficult because many workers in informal employment also face long-term income insecurity as well. So I just want to quickly talk a little bit about what we've been doing at WeGo. So from the very beginning of the pandemic, we have been running a study, a global study, which was looking at the impact of COVID-19 on workers in the informal economy across 12 cities. And one of those cities is Durban. So this study was done in 2 waves. The first wave was between April and July 2020 and June and October 2021. This study involved both a survey and in-depth interviews with around 2,000 workers, and 200 of those were in Durban. And this is just a screenshot of some of the publications. If you look on our website, and if you also look at the reference section at the end of this presentation, you'll find links to all of these publications if you're interested in having a look and having a read. These are just the study locations. Okay, so I just want to give a few insights about the Durban data. So I'm talking mostly about the most recent wave. So this data that I'm going to talk about represents the situation as of last summer, so summer 2021. And according to our data, more than 30% of street vendors and reclaimers reported having a positive COVID-19 test at some point during the pandemic. And then leading on to that, some pointers here. So there was a really high use of PPE, whether that's masks, gloves, et cetera. But even though workers in informal employment were using PPE very well, they actually had to supply it themselves for the most part. Many workers relied on local informal worker organizations who were giving that mutual aid. So it didn't necessarily come from government sources or private companies or charities. Workers really had to use their own savings, their own funds to fund their own protection, essentially. And of course, this leaves workers very exposed and unprotected. And so it's no surprise that almost all the workers that we surveyed in Durban reported having been exposed to COVID-19, knowingly exposed to COVID-19 in the workplace. In terms of other occupational health risks during the pandemic, around half of all these workers reported working longer days and having to lift heavier items compared to earlier in the pandemic. And this was represented across the two phases of data collection. Workers also have experienced really poor access to water in the workplace. So 85% of reclaimers and waste pickers in their collection sites, and 86% of street vendors, market vendors, spaza shop workers reported having no access to water. And unfortunately, this was true early in the pandemic. It's also been true before the start of the pandemic. But I think the definitive message is that in general, there's been very little to no improvements in working conditions in the last few years for workers in informal employment. So that was our study, which was bringing out the Durban highlights. I just wanted to also share something else that WeGo was doing in the very beginning of the pandemic. So around April 2020, so yeah, the very early stages, WeGo started to put together guidelines for street and market vendors and spaza shop workers to stay safe during the early stages of the pandemic. To do this, we worked in consultation with academics from UKZN and Cape Town. We worked with informal worker organizations as well. And we produced these posters which were available in multiple languages, as you can see here. We also disseminated via WhatsApp so that the informal worker organizations, most of whom are located in and around the Durban area, could disseminate this amongst their members. Again, also available in multiple different languages. And there was also a poster about lockdown health guidelines. So that's something that we did earlier on, and it proved to be really useful, and we got very good feedback from the memberships in South Africa. And just a quick conclusion, as I know we're really short on time. Our reflections are that we really do need to push for more inclusive public health strategies, which actively includes workers in informal employment. So this relates not just to testing, quarantine, vaccination. It's about messaging. It's about provision of PPE, but also wider social protection initiatives. So we're talking about things like cash grants and other mechanisms for financial protection, which go hand in hand with public health strategies, especially during a pandemic. And of course, organizations of informal workers need to be really well supported. They need to be resourced, and we need to listen to them in terms of OHS issues. and they are very, very key to engaging with local authorities. And there's some references there for everyone who accesses these presentations later. And thank you very much for listening.
Thank you very much for that. Dr. Ivanov, if you're ready, we've just slotted you in before we go to the Labour speaker. And then, as agreed, we will then go over to Matthew Parks as soon as you're done. Dr. Ivanov, over to you. There's great expectations to hear your contribution, because earlier on already there was also references made to the World Health Organization. Your slide is maximized. Please proceed. Thanks.
Thank you. Thank you very much, Ashraf, and thanks a lot for being flexible and accommodating my availability. It is one of the effects of the COVID pandemic that we have so many webinars and different engagement that it is always difficult to handle. And we'll see what will be the effects of that. I hope they will be positive and there will be no negative effects. Well, good afternoon, everybody. Pleasure to be with you. I want to share with you some epidemiological perspectives and lessons learned for health in the work from this pandemic. Now, first, I want to highlight to you that we are still in a period of intensive transmission of the virus. And though the numbers are declining, that does not reflect the truth, because some countries are lifting the testing, changing their testing requirements, and that results in a lower number of cases detected. But the truth is that in that intensive transmission, we can see further variants, including recombinants emerging. So there are different scenarios for the development of the COVID pandemic, and we shall continue to be cautious with the measures for prevention of the transmission of the virus. As you can see here on the top, these are the global trends. On the bottom, there are the African trends. They are pretty similar in terms of cases and number of cases and waves. Now, vaccines are also another track that WHO monitors, because our target is to vaccinate by the end of this year at least 70% of the world's population. But we see, as you can see also from this map, Africa has a major deficiencies in terms of vaccinating its people. Very few people in some of the African countries, less than 20%, are vaccinated. And this is a matter of concern because of the emergence of new variants and new recombinants. Also, the businesses were affected everywhere by the public health and social measures that are different in terms of how severe they are or less severe. In this map, the darker color, the darker green, means more severe, and light green means less severe public health and social measures regarding businesses. This includes business closures, includes teleworking arrangements, includes keeping only essential workers. So they are different measures in different countries. And the effect of business closures also goes beyond stopping the transmission of COVID, but also the emerging other risk factors, such as, for example, teleworking, that I will cover later. The transmission of SARS-CoV-2 has occurred in a wide range of workplaces. Last year, we issued, together with the International Labour Organization, a joint policy brief on COVID-19 at work. And it has shown, the evidence shows that outside of health facilities, COVID outbreaks are reported in workplaces which have close person-to-person contact, where there is inadequate ventilation, common eating areas, shared work accommodation, and shared travel to and from work. And almost all workplaces have been affected, but more often service and sales workers, workers in education, hospitality workers, construction, domestic workers, meat processing factory workers. There have been a lot of outbreaks in this setting, and transportation workers, and in general, occupations that allow for remote work have shown a lower risk of infection. And you can see here on this slide that the factors that determine the transmission of SARS-CoV-2 at the workplace are the occupation, the work environment, factors outside of work, for example, social gatherings among workers outside of work or at the workplace, and socioeconomic, socio-demographic characteristics. The health workers have been heavily affected at the onset of the pandemic, as shown here on this graph for the world. At the onset, the rate of infection among health workers was quite higher than in the general population. And now in the recent stage of the pandemic, the rates of infections among health workers are following the patterns in the general population. Though still these data have to be interpreted with caution because only 146 countries are reporting overall cases and only 67 countries are reporting the number of deaths among health workers. So it is still difficult for WHO to have a complete picture of the impact of COVID-19 on health workers, though we're trying to do some estimates and looking into the underlying causes. Here are the data about health worker infections in the African region, the sub-Saharan African primarily, and follows the general patterns as for the world. At the onset of the infection, there was a high rate of cases among health workers. And now in the recent stages of the pandemic, the pattern among health workers follows the pattern in the general population. That means that measures have been taken, personal protective equipment is available, infection prevention control measures have been taken and they are working. At the beginning of the pandemic, with our colleagues in ILO and the collaborating centers for occupational health, we did a survey of almost 5,000 health workers worldwide. And we asked the questions about risks in the work environment, risks in the work organization, whether they are acceptable, to what extent they're acceptable or negligible. And we ask also questions about preventive measures, specifically measures for infection prevention and control, and other occupational health and safety measures. As you can see here from this table, there is particularly the risks in the work environment and work organization are considered to be mostly unacceptable. And for the African region, I have highlighted here the data for the African region, and that reflects the general neglect of occupational health and safety pre-pandemic. Health workers, occupational health and safety was never a priority in the healthcare facilities. As also you can see the factor for occupational health and safety measures is higher than compared to the score for the factor of infection prevention and control, which shows that there has been a progress on infection prevention and control, but other occupational health and safety measures are lacking behind. There are multiple factors that are related to how COVID-19 pandemic affected health and care workers. This is on one hand, the availability and distribution of different resources, vaccines, repurposing, search capacity for augmenting the number of health workers, and many health workers also were absent from work because of COVID. Then the working conditions were affected by the lack of personal protective equipment. We have seen many labor strikes, unfortunately, quarantine and self-isolation, which also reduced the number of health workers available for treatment, temporary staff contracts, lack of incentives, insurance. We have seen, unfortunately, cases of violence and harassment that have increased during this tough time, lack of psychological support that resulted in anxiety, depression, insomnia, emotional burnout among health workers, and lack of COVID-19 vaccination. The health of health workers was affected by infections. There were, of course, unfortunately, deaths, high levels of stress, burnout, other mental disorders, and many health workers also experienced stigmatization and discrimination, and their social well-being was affected by the fact that they have to also take care of their family members and children. The pandemic has demonstrated that health is wealth, and that is not a slogan, that is a conclusion that the World of Work Dialogue held in 2021 reached. A lot of stakeholders discussed what is the implication of COVID-19 pandemic for health in the world of work. And some of the recommendations of this dialogue that emerge is first that there is a big need to collaborate for results, and that there is enormous need to ensure better private-public collaboration in health emergency. These are lessons learned also for the future, that we need to build and maintain trusted partnerships outside of crisis for quick activation during crisis. National governments are encouraged to engage the private sector as a key partner in health emergency and response and planning. And there is a need to leverage cross-sector synergies and opportunities for greater impacts. Also, we need to communicate better. And when I say we, I mean everybody, all actors in the world of work, employers, workers, specialists, need to communicate better in a crisis. Information sharing, social dialogue, leadership during health emergency is extremely important. Therefore, WHO is running this dialogue on health in the world of work in order to empower different stakeholders and encourage them to invest in communication capacities, to empower trusted internal communications at the workplace, and to adapt to changing communication needs by connecting biomedical science with social and behavioral science, how to change human behavior, which has been the driving factor of this pandemic. Also, there is enormous need to change the future today. When we talk about COVID recovery, it starts today. We have to get prepared. We have to get prepared to ensure sustainability, to be at the core of businesses, and how businesses contribute to a healthy society, economy, and the world. The workers are the most valuable asset of any business or organization, and businesses have to ensure the procurement of services, respect and protect human and labor rights, build tripartite partnership collaborations placed here between the informal sector and the sector. And that's why I would like to argue about the collaboration between all groups of workers and all groups of businesses, and to leverage emerging opportunities through innovations, focus on health, adapt to the next normal, and enhance resilience. This is not going to be the last pandemic, likely. So WHO is preparing a pandemic treaty that will evolve over the years. The employers have an important role because we see them as custodians of health, and they can be very powerful protecting health, enabling health at the workplace through implementing the international labor standards on occupational safety and health, through leveraging the existing conventions and protocols, and accept, endorse, and contribute to universal access to occupational health. We also need to work toward forward-facing risk assessments for pandemics and new ways of working. For example, how occupational health services will be working in the new world, and to develop occupational health and safety guidelines for digital and remote work, and demonstrate the mutual benefit of health to the economy. We have been working over 2 years, more than already 2 years, we have been working, many of us primarily teleworking. And as this has shown how it can stimulate collaboration, how it can allows me to sit now in Geneva and talk to you in South Africa. It is an enormous development, and this has changed the way we work, the way we live even. WHO and ILO have done a review of literature of the impact of teleworking on health, and we came to the conclusion that when organized and carried out properly, telework can be beneficial for physical and mental health, and also contribute to social well-being. However, when it is not consensual, when it is imposed, when it is not well planned, like what we did in February, March 2020, running out of the offices, carrying a laptop or whatever we could, telework can be harmful for health and well-being. Homes are not designed for working, there is inadequate IT support, and that results in musculoskeletal disorders, back pains, eye strain injuries, physical isolation, work overload, difficulties in managing work-private life balance, and at the end, mental health problems and unhealthy behaviors, unfortunately. Therefore, to adapt to this new reality of teleworking, hybrid working, we need a comprehensive set of measures to provide a healthy and safe work environment, including adequate organization of work. And there is not exactly rules and that much of evidence how the new world of work will be organized and what are the good practices in managing teleworking and hybrid working arrangements. The technology is still evolving, the work organization is still evolving, and the situations in different enterprises are very different. Therefore, enterprises which employ teleworkers need to develop programs to promote healthy and safe telework, to combine the measures for human resource management, the IT solutions, and occupational health and safety measures. And occupational health and safety services should be enabled to provide ergonomic, mental, and psychosocial support, also using the same way of delivery as the telework through digital services. And of course, workers, they work from their home, they are the masters of their life, and therefore they should be part of the solutions, and there should be a strong collaboration with workers. And here on the right side of the slide, you have the links also to the teleworking WHO and ILO brief. And last week, WHO also released the open WHO online course on healthy and safe telework that you're more than welcome to disseminate and take. Of course, we'll share the presentation so you can benefit of the slides and the links to these slides. Now, when we move to talking about COVID recovery and the lessons from COVID, as I said, health workers were disproportionately affected because occupational health and safety for health workers in healthcare facilities in the health sector was never a priority. It was always sitting in the back seat. It was always sitting in the corner, if it existed at all. What we have seen from previous epidemics like the Ebola outbreak in West Africa, there was a lot of talk about health and safety of health workers during the epidemic. But when the epidemic was declared over, the attention to the health and safety of health workers quickly disappeared, and there were no measures for enhancing the protections for health and safety of health workers during the recovery from the Ebola. We are very much afraid that without significant advocacy, without proper measures, that the same thing will happen after the COVID. Many countries have developed emergency regulations and standards for health workers, for protection of health workers during COVID. But when the epidemic is over, these standards, they need to be adapted, and they need to continue to improve the working conditions of health workers. That's why WHO and ILO were rushing to issue a guide on how to develop and implement occupational health and safety programs for health workers, and how to implement them in a sustainable way, in an everyday way, so they do not depend on the availability of project funds. They do not depend on the public attention or lack of attention to health and safety of health workers. Even the working conditions of health workers now were part of the presidential debate in France. We are facing presidential elections this Sunday. The protection of health and safety of health workers should become part and parcel of the management of healthcare at all levels, and even in discussions with private sector, with other companies, extractive industries, they always amazed how come in the health sector, which is one of the most hazardous sectors, the safety is not given a priority. For the extractive industry, it's given that the safety should be a priority of the business, but not in healthcare. Though one of the main principles in healthcare is first, do no harm, primum non nocere. Do not harm the patients, do not harm the workers. Therefore, all health workers should have access to competent occupational health services. And when I say competent, I mean services, occupational health services that are adapted to the specific needs of the health sector, which understand what is healthcare, how healthcare is delivered, and which can argue and which can convince the chief physicians, the heads of the medical wards, the hospital directors, the management, everybody in a health facility, that measures have to be taken. There are also need to establish good synergies between occupational health and safety and quality and safety of care, which also includes patient safety, infection prevention and control, and the strategies for health workforce development, which I have shown you that they have affected enormously the availability and of health workers, and the shortage of health workers is a major determinant of the poor working conditions in the health sector. Of course, we need research norm standards to protect health workers. There's a lot of attention to infection, but actually unsafe patient handling resulting in back injury is very, very debilitating condition. Violence and harassment resulting anxiety, depression, post-traumatic stress disorder. Health workers are leaving the sector because of low back pain or because of being victims to violence and harassment. Psychosocial risks and work-related mental disorders are also important to tackle. In this year, WHO will issue special guidance on mental health work, which also includes mental health of health and emergency workers. I want to highlight that even before the pandemic, there was already a emerging global commitment toward paying more attention to health and safety at work. At the high-level meeting on universal health coverage that was held in the United Nations General Assembly in 2019, the heads of state and government and representatives of states and government committed to a number of measures to universal health coverage, which is reflected in the resolution of the General Assembly 74/2019. And they committed also to scale up efforts to promote healthier and safer workplaces and to improve access to occupational health services, noting that more than 2 million people die every year from preventable occupational diseases and injuries. And occupational health services are essential services for enterprises that are open. They are not, they may not be health care workers, they're not providing clinical care, but they are essential services. And the previous speaker mentioned that occupational hygiene was not considered essential. We have seen also in several countries, occupational health services were not classified as essential services, which means a failure to justify occupational health services. The countries which have realized how important is occupational health to keep their working population working either at work or at home or in hybrid, but being healthy and being able to work, they have also seen a good progress, and their occupational health services were always considered as essential services. Also, they committed to take necessary steps at the country level to protect health workers from violence, attacks, harassment, discriminatory practices, to improve working conditions in the health sector, and to ensure health workers' physical and mental health and well-being. So WHO is working with a number of international partners, among them the African Union and the ILO, and they have a global network of collaborating centers. So we are taking stock of these lessons learned from COVID, and we have decided that one of the contribution of WHO will be to provide a global framework for healthier, safer, and more resilient workplaces by explaining first what we mean by healthy, what we mean by safe, what we mean by resilient, and also providing some guidance on how we can improve the prevention and control of high priority occupational risks, how to enable healthier behaviors and health literacy at the workplace, how to scale up the coverage of occupational health services and link them better to primary health care, and how workplace resilience can be built in public health emergencies. WHO also will continue to stimulate the development and implementation of occupational health and safety programs for health workers. We are aware of the program in South Africa and its development and the ambitions around the health and safety of health workers in South Africa. And all African countries are also following that path, Tanzania, Togo, Gambia, Kenya, just to mention a few, but many other countries are interested. And we have an emerging project with the African Union Development Agency to with the different economic communities in Africa about health and safety of health workers and the need to develop policies and standards, subnational and health district actions, and health facility programs. And I'd like to express my appreciation to the National Institute of Occupational Health, which is a WHO collaborating center for occupational health for many years. And I want to say how impressed I am by the convening power of the National Institute of Occupational Health, which is witnessed by the number of attendees in this webinar. Therefore, we'll continue to work with collaborating centers toward improving research and improving the evidence for action. Everywhere we dig in occupational health in order to prepare some evidence-based recommendations, we always strive to get the evidence right. Never we find sufficient evidence, good quality evidence that is useful, can be used for development of public health guidelines. We also need to work together to build capacities, to provide technical assistance to countries, and to raise awareness and communication. Many people don't even know what occupational health is and what occupational health can offer. So we need to even change the words, as one Chinese proverb says, if the business is bad, paint the store. So we need a new paradigm of occupational health. And you can see the emerging WHO projects in our website that has been recently revamped. And we appreciate the collaboration again and looking forward to the future. Thank you very much. Over.
Thank you very much, Dr. Ivan Ivanov, dealing with the perspective of the World Health Organization and providing that input for us. Much appreciated. It is a time that we did allocate for Professor Salim Abdul Karim, but I'm going to ask Professor Abdul Karim if he could just allow Matthew, let me just get this right, Matthew Parks, an opportunity just to take for 8 minutes to present. Professor Abdul Karim, is that fine with you? You are muted.
Sure, that's fine. Thank you.
Thank you very much for that. So I now introduce to you the last of the group of panelists, the stakeholder speakers. And this speaker, particularly from labor, a very essential component of the world of work, as well as a stakeholder and a role player within the world of occupational health and safety and protecting everyone within the workplace. I now invite Matthew Parks as a labor speaker, particularly as a COSATU representative, to just, I see his videos open, to open his microphone and to share his slides. Please proceed, Matthew.
No, thanks, Chair. Yeah, no, thanks for having us. Apologies, I feel slightly ashamed. I don't have slides. I thought I was just, given the time constraints, just speak to the issues.
Please proceed.
So my apologies for that. No, look, thanks for having us as COSATU. I mean, this has been an important and an interesting journey for us for the past 2.5 years. I think we've learned a lot of lessons from it. And I think it's been unprecedented territory for all of us. So from government side, from labor side, from business, from civil society. I think it's been a learning experience for all of us. I remember when we first kind of met, March 2020, February 2020, preparing for the lockdown, I think we all thought it would be a 2-week, 4-week period. We kind of were sent home, and then lo and behold, it became 2.5 years plus. And I think, look, I think there's been very positive lessons learned from it. I think the fact that we had countless meetings at NEDLAC, Lisa was here speaking earlier. At some stage in NEDLAC, we were meeting as government, as business and labor and community 5-6 times a day. We were meeting 7 days a week till late at night due to the multiplicity of issues. And I think some of the very positive things about it was in quite a short space of time, we were able to respond collectively as government and as social partners. 2, that we were able to find each other on very complex issues very, very quickly. I think, without exaggerating, on 99% of the issues, we were on the same page as each other. And sure, there'll be differences at time, which is necessary. But I think in most issues, we found each other very quickly. And I think that really has laid a positive foundation as we kind of pick up the pieces and seek to rebuild South Africa afterwards on an economic front, on a health front, etc. That we have very kind of strong understandings of each other and very kind of strong synergies on many, many issues. I think it's been a huge change from how relations were previously between, the parties, government, etc. Look, having said, Chair, I mean, as COSATU and even other trade union federations, FEDUSA, NACTU, and others outside and so forth, we have very diverse views inside organized labor. So in COSATU itself, we have unions which organize nurses, doctors, paramedics, health workers. We have workers who organize on the farms, the retail sector. We have public servants, we have teachers. So the interests are not the same. We've had at times try to juggle them. So our health nurses, for example, health workers were keen when we banned tobacco and alcohol for the first period. Later on, we had to actually lift the ban on those industries because 1, it wasn't working, but 2, also there was threatening jobs in those value chains. That actually created a lot of kind of conflict and contradictions at times from health workers who are feeling the brunt of overwhelmed emergency rooms versus farm workers and retail workers who depend upon selling liquor or alcohol, etc., for their jobs. And of course, for the taxes which pay the same nurses at the same time. I mean, I think we learned a lot, and I think we got a fair amount of gray hairs too, trying to deal with the multiplicity of technical issues too. On the UIF COVID-19 TERS, where we managed to, after a lot of kind of heated discussions, release 63 billion rand to help 5.5 million workers, was a huge source of kind of solidarity that workers could bring to the party because the UIF has workers' contributions and employers' contributions. But we also learned, I think, how weak the capacity of the state is. In the beginning of the lockdown, the hotline for the UIF was a landline, not an 0800 number. It would take you about an hour if you were lucky to get through. It had about 8 staff members. But at the same time, we're able to kind of get support from business, from other government departments to try to reinforce the UIF capacity. We had unions which organized in the bargaining councils trying to make sure employers applied for the UIF to help give money into the companies to help make sure workers are paid. So there was a really kind of a strong social comeback spirit, I think. I think we put aside a lot of our differences. I think we're able to work quite closely together around economic and social relief measures as well, from tax rebates, measures to support the hospitality sector, and so forth. I think it's similar. We had a same kind of a common sense, consensus approach. Most of our health and safety interventions, be it the non-pharmaceutical interventions, wearing the masks, sanitizing, making sure that our trains or taxis, as much as they can be, try to be safe workplaces or safe spots. Similar kind of approach at the workplace too, and I think that really bodes well. We had a lot of work together as organized labor and business and government at an industry value chain around how to make sure that the masks we wear are locally produced masks. Can we produce locally masks, the plastic masks, the gloves, the sanitizing, the plastic shields, etc. I think those really were useful interactions, and it was actually quite impressive how managed a lot of interventions could be unfolded quite quickly to rev up local procurement, which can help create jobs and so forth. And again, it really creates positive experience and lessons as we seek to rebuild the economy. I think, Chair, and these kind of also lay the positive kind of foundation for the master plans as we look at how to ramp up local procurement across the economy. We did have some heated moments on the vaccine front, on many fronts. We were quite perplexed in the beginning why it took so long to get the vaccines through. I think we were less than impressed with government, to be honest, in the beginning. But I think to give government credit, when it got into the swing of things, it moved with great speed, working with the private sector to roll out the vaccines, to set up the sites, about 4,000, to get the vaccines in play and so forth. And I think we must give them credit for that. I think that's the reason why we had a minimal fourth wave and hopefully a minimal fifth wave in a few months or few weeks. Chair, I think where we did underestimate, and I think we will take our blame as Labour to an extent, the amount of vaccine hesitancy, the amount of anti-vaxxer sentiment out there in society, even amongst our own membership. We never expected it. I remember talking with Lisa from NEDLAC before, and I was dismissive that we would have problems of convincing people to vaccinate. And lo and behold, we got a very rude wake-up call. So I think we've underestimated those kind of things. I think we underestimated the amount of fake news and impact upon social hesitancy. And that's something I think none of us really has the full answers to. If I can kind of look at the way forward, Chair, because I think as previous speakers spoke is about the new normal, because COVID won't disappear, it'll be managed as an epidemic. And of course, there'll be future pandemics. And of course, we've got pre-existing epidemics as well. So I think for us, number one is about the value of health workers, to invest in them, to make sure they're properly paid, that we have sufficient nurses and doctors on site, that we address the shortages of these skilled professions, that we look at feeding in through the colleges, the universities, that we have a constant replenishment of the staff. But also, how do we help to retain these staff? Because at the same time, we have a shortage of these skills. And other countries are busy kind of recruiting our staff. How do we make sure our healthcare infrastructure is up to speed, up to scratch, that we don't have pregnant women sleeping in hospital corridors? So of course, it also means speaking to accelerating or building the foundation for national health insurance, but a quality health insurance, not a suspect one. But I think also, Chair's about the issues around public education. So some of our unions really did fantastic work in the clothing industry, amongst teachers, mine workers, police officers, to mobilize workers to vaccinate, to address their concerns. But I don't think we've done enough as unions. I don't think we've done enough as a society at large. And if we're so hesitant about these vaccines in the midst of a global pandemic, are we really sure that everybody's vaccinating their children for other diseases, for measles, for mumps, for cholera, for polio, etc.? Or do we just take it for granted and we've been coasting along? I suspect it'll be a combination. Sure, there's a lot of work we need to do about workplace health and safety requirements. The Occupational Health and Safety Act is quite clear, and employers are obliged to make sure that workers have a safe working space to go to. Yet if some of us are not keen on embracing medication, embracing vaccines, we need to see how to address these issues. Because yes, we've got a lot of flack from workers who don't want to vaccinate, who say we're imposing upon their constitutional rights. Okay, sure. But we also get a lot of flack from workers who are saying, look, I have vaccinated. I've got hypertension, comorbidities, diabetes, whatever. And my life now is now at risk because other workers are not vaccinated. So there are being those kind of tensions which we need to try to manage in a constructive way, which brings people with us. Chair, I think maybe just the last few things is that there are lessons we need to learn as well from the Competition Commission, where I think they did good work. I think it was late last year, memory serves me right, around the pricing for vaccine tests and trying to deal with some of the monopolistic behavior, the extortionist behavior by some companies. So how can we try to deal with that? Because you look at the broader healthcare value chain, the prices that healthcare providers charge for basic essential medical equipment, medication, it's unbelievable. I was shocked, Chair, that a prosthesis for a leg can cost 200,000 Rand, and that medical aids will refuse to cover those costs. So I think we need to have those kind of discussions. And I think, yeah, in a broader discussion, but what do we mean by healthcare? And what do we mean by vaccination? And what do we mean by healthy society? Because clearly we don't have the same views, yet all of us need to move forward, and we should be moving forward on principles which are inclusive, which are progressive, which are based upon solidarity, and which are based upon giving real solidarity to the most vulnerable and the elderly and the sick, not upon us as individuals. But I think lastly, Chair, is that I think these kind of discussions are useful because, yeah, these pandemics won't disappear. There'll be future pandemics. And I think they're real useful lessons for us how to manage it going forward in terms of infrastructure, in terms of society-wide responses. But I think also what is our responsibility as individuals, because government can do so much, healthcare can do so much, but also myself as a parent or myself as a worker, I've got certain responsibilities and I should also be playing my role. So yeah, so let me stop there, Chair, and apologies for not putting it into a PowerPoint. But yeah, hopefully we've added some value to the discussion. Thanks very much, Chair.
Well, thank you, Matthew. I'll leave you to the audience and the attendees because they've all been asking for the presentations of those speakers that are done. But thank you for your contributions, for bringing your perspective and the perspective of your constituency as diverse and as you've indicated they are. I'm now going to immediately go over to Professor Salim Abdul Karim, who is joining us from New York. And it's just, I think, after breakfast for him there. It's early morning, and we've scheduled him for the convenient time around 2-ish today on our side. So Professor Abdul Karim is going to speak about SARS-CoV-2, COVID-19, and epidemiological and global perspective, background broadly, the science, the epidemiological journey, milestones, interventions, achievements, and the way forward. I hand over to you, Prof.
Thank you very much, Ashraf. It's a great pleasure and an honor to be with you at your conference today. What I would like to do in the time that I have available in your program, I'd like to touch on 3 aspects of COVID-19. I thought it would be useful to just go through some of the epidemiological data about what this epidemic is about, and then touch on vaccines and the way forward. So I'll start off with a global picture. I'll explain why the concern about variants. I'll touch on the evolution of variants, and then look at the issues around vaccines and what are the lessons we can take to the future. So this is the global situation. And it's quite striking, actually, when you think about how the Omicron wave has dwarfed the 3 previous global waves, in that Omicron spread so fast and so widely that, every day, pretty much in January, we were seeing record numbers of new cases globally. And what we've seen at a global level is that as the cases of Omicron came down, we had a second little blip, which we saw in South Africa about 5 weeks before we saw it globally, which is the second blip due to BA2, which is a subvariant of Omicron. But as we saw in South Africa, the BA2 just causes a little blip and then it continues to decline. And we know that with this particular disease that we are dealing with a viral infection that leads to an immune response that literally affects the body from head to toe. I mean, every aspect of your individual health systems, whether it's the endocrine system or it's the circulatory system or the neurological system, all are impacted. And that's because of the very nature of this virus, that as this virus replicates, that the immune responses overshoot the viral infection itself and can start causing microclotting and a whole range of different diseases. For example, the ACE2 receptor is present in the pancreas. And so you can end up with a situation where COVID-19 attacks those pancreatic cells and can lead to diabetes as a result. So you can see we're dealing here not with something that just causes a bit of flu, a bit of cough and a bit of pneumonia now and then. This is a disease that affects the entire body. And what we have seen as a result is in a proportion of individuals that they get a very severe form of this disease that leads to death. And globally, we have about 6 million reported deaths, or just over that. But if you look at an analysis of what the excess deaths are, it's a better indication of what we are dealing with at a global level. Excess deaths are, you take historically, what are the numbers of deaths you expect each week in the year, in each of the 52 weeks, and you look at in 2020 and 2021, how many deaths actually occurred. And that difference gives you an impression of the excess deaths. And most of the excess deaths are likely due to COVID-19, not all. So the excess deaths indicate that there's probably closer to about 20 million deaths globally from COVID-19. That's just an estimate. But to give you some idea of how serious that is, in the entire HIV pandemic of what now close to 40 years, it's estimated that we've had about 45 million deaths. So that just gives you some idea that comparatively speaking, in 2 years, COVID-19 has already caused almost half as many deaths as 40 years of HIV. So we are certainly not dealing with a mild disease that you can just quietly ignore. And we also know that it's a disease that doesn't just have an acute presentation. With this disease, we see that after a period of 3 months, which is what we use to define long COVID, that up to a year later, about 10 to 20% of patients are still complaining of features of COVID. And particularly, they complain about fatigue, and they can't concentrate. In my clinic, the patients call it, it's like a brain fog. They feel dysfunctional, and they have difficulty, doing complex tasks, for example. And this long COVID is really, the full extent of it is still to hit us. Because remember, most of the infections we've had in the world occurred due to Delta and to Omicron. So both those infections are just about a year ago. So, well, Omicron is still with us, but Delta is not even a year. Delta started in around September last year. In India about April, but in most of the world in around September. So you're really talking about that there's a tsunami of long COVID that we are going to see in our occupational health clinics. We're going to see that among the staff who are going to complain. We're going to see it in our hospitals, everywhere. This tsunami of long COVID that's going to follow the waves that we've already had of Delta and Omicron infection. So this is the full extent of this we are still to see. So given the extent of the clinical burden, what are we most concerned about at this point? And that is variants. Now, why are we concerned about variants? Well, in this diagram, I'm showing you the first wave in India, Brazil, and South Africa. And you can see in each of these countries, there was a first wave that was pretty bad. In fact, in India, it was so mild that the politicians in India were saying they'd conquered this virus. So they don't know what everybody's complaining about. There's no real problem with this coronavirus in India. Well, we see very quickly how variants have changed the game. The Delta variant caused what was a really awful second wave in India. I don't know if you recall those pictures on our television screens of patients dying in the hospital car parks because there's not enough beds, there's not enough oxygen in India. In Brazil, the Gamma variant caused an awful second wave. And in South Africa, the Beta wave drove our the Beta variant drove our second wave, and the Delta variant drove our third wave. So what we are seeing is that variants are causing new waves of infection. And in this, we have seen how the variants are evolving, and they've been labeled based on the Greek alphabet, alpha, beta, gamma, delta, omicron. And the next one should be called pi, capital letter P, small letter I, which is the next letter in the Greek alphabet. So if you look at each of these variants, what we are particularly concerned about is the spike protein. So if you think about the virus looks like a sort of partially deflated soccer ball. And sticking out of it are little like mushroom-like, little like mushroom things and those are called the spike proteins. They divide into three parts in the mushroom. And these spike proteins are critical because that's the part of the virus that attaches to the human cells. Remember, bats have thousands of coronaviruses, and we don't care about their coronaviruses because they can't infect humans. But it's when a bat coronavirus acquires the ability to infect humans, and in SARS-CoV-2, it was able to do so because of a critical change in the spike protein. That ability means that the spike protein is absolutely important because that's what changes a harmless coronavirus into a deadly one. So if you look at the mutations, what you can see is that we've been steadily increasing the mutations over time. And Omicron really changed everything and our understanding of this virus, because Omicron in total has over 50 mutations. And there are almost 30 just in the spike protein. And you can see that here, how each of these little purple dots is a change that has occurred in the spike protein of Omicron. So this virus is almost like a chameleon. It keeps changing itself. And the way it's changing itself, it now camouflages itself, and our past infection immunity and to some extent our vaccine immunity isn't able to neutralize this new virus. And so that's what we have been seeing. And that over the course of the entire global epidemic, we saw the initial ancestral strain. So that was this original strain here in the blue. That's what came out of Wuhan. But it didn't last very long. Very quickly in Europe, the virus had a mutation into what we call D614G. And that's the variant that spread throughout the world. And in fact, that's what we had in South Africa, because the virus in South Africa came from Italy. The D614G was the first variant that we knew, but it only had one change. But what we saw quickly thereafter was a whole series of viruses of variants. And you can see how alpha literally pushed D614G aside. But then along comes Delta, and Delta just wipes all the other variants out. And now we're seeing how Omicron is now wiping Delta out. Now, I'll come back to this issue because when a new variant comes in, it has to dominate in order to really survive and spread. And I'll come back to how it does so at the end of my talk. So let's look at the effect of these evolving variants on our most important protection mechanism, and that's vaccines. So let me summarize it in explaining that there are 5 benefits to COVID-19 vaccines. 4 of those 5 are benefits to the person actually vaccinated. So that's to the vaccinee. Those are what we call individual benefits. And what are those benefits? Well, a person who is vaccinated has fewer asymptomatic infections. And we now know this, and I'll present some of the data on that in a minute. But it also decreases the number of clinically apparent infections. So those are clinical infections where a patient is feeling sick and goes for a test. But almost all of the vaccines do really well in preventing severe infections, hospitalizations, and deaths. And so you have to think about vaccines don't just prevent infection. They prevent asymptomatic infection, they prevent clinical infection, they prevent severe infection, they prevent hospitalization, and they prevent death. And importantly, there's now emerging evidence that vaccines also prevent long COVID. So those are the 4 individual benefits. There's a really critically important community benefit, and I'll touch on that with some of the evidence, and that is that a vaccinated person reduces the attack rate in their close contacts, and I'll touch on how that occurs. But it's important to recognize that each of these 5 benefits vary in relation to these 4 characteristics. And that's the type of vaccines. So for example, mRNA vaccines do better at preventing asymptomatic infections than protein vaccines. We see, for example, time since vaccine. We know that if you go 6 months after you've been vaccinated, you have very low antibodies. And so some of these protections start waning. The third is the variant, and I'll touch on how variants impact the benefits of vaccines. And finally, immunosuppression, that those individuals who, for example, have cancer or who are undergoing transplants, they have immunosuppression and they don't get the full benefits of all of the vaccines. So let's deal with these 5 benefits. So let's deal with the first benefit, asymptomatic infections. In the original trial of the Pfizer vaccine, it was shown quite clearly that not only did the vaccine reduce clinical illness, but it reduced asymptomatic infections by 66%. So it's not that clinical infections are now becoming asymptomatic, it's that there are no infections occurring. In other words, the asymptomatic infections are also declining. And we saw, of course, this huge benefit of 95% fewer clinically mild infections. And if you look on the right-hand side, I've just pulled together data on how the Pfizer vaccine does in relation to the different variants that we have. So we know that the original D614G variant, when the vaccine was tested in the US, the vaccine was highly efficacious against D614G. It was 95% protection. However, in a study from Qatar, looking at the beta variant, they found that the efficacy of the Pfizer vaccine dropped from 95% to 75% against the beta variant. Still has protection, but the virus is now learning how to avoid parts of the vaccine immunity. And so that's why we see a drop from 95% to 75%. By the way, a 75% efficacious vaccine is still pretty good. It's still preventing 3 out of 4 infections. Against the Delta variant, the Pfizer vaccine does pretty well, as shown in the UK, where it prevents about 88% of infections. But it was against Omicron that we really started getting concerned. That against Omicron, if you'd been recently vaccinated, in other words, in the last month, the protection was still pretty good at 67%. In other words, the Pfizer vaccine prevents about 2 out of 3 Omicron infections, provided you were vaccinated recently. If you were vaccinated 6 months ago, as was the case in many countries, they had received their 2 doses quite a while back before Omicron came. What we found is that there's very little protection. Once the antibody levels wane, we saw very little protection. And so that's what led to these boosters, that if you take a Pfizer booster or or any mRNA booster, for example, you could take even the Moderna vaccine, but if you take an mRNA booster, it brings the efficacy of the Pfizer vaccine back up to 75%. And so that was this whole rush. Let's get everybody on a booster so that they are protected. But the booster was needed only in individuals who were at least 3 to 4 months since their last dose of vaccine. So what do we know? Just summarizing this, the vaccine we know prevents asymptomatic infection, prevents mild infection, and even across the different variants, although there's variability, it's still pretty good in preventing mild infections. But let's look at severe infections. And here there are so many studies. I just summarized one of the many studies, one of the biggest studies, actually. This was a study done in New York State by colleagues of mine here. And what they showed is that the 2 doses of Pfizer vaccine do pretty well in preventing severe illness and hospitalization. At 95%, and then even at 4 months later at 89%, and they've now got data going out to 1 year, and it's still well over 80%. So vaccines do quite well in preventing severe. It doesn't matter which vaccine, and doesn't matter how long ago you were vaccinated, these vaccines do pretty well in preventing severe infection and hospitalization. It's this diagram on the right-hand side that really tells 1,000 words. I mean, if a picture could speak, this one speaks volumes. So if you look at, this is in the USA, that if you look at individuals who have received their 3 doses of vaccine, and you compare the death rate in that group with the unvaccinated individuals, it's stark. In other words, unvaccinated people are 78 times more likely to die from COVID-19 than people who have received a booster dose. So that's just giving you some idea of the enormity of the benefit that comes from vaccines in terms of reducing deaths. I mentioned that there's some emerging evidence. This is an early study from Israel that looks at long COVID, and what they showed is a reduction of 54 to 64% in the 4 common symptoms of long COVID. That's fatigue, headache, weakness, and so on. So it's very early data, but there's now a second study that's also just been published that confirms this. So we'll wait to see more evidence, but it certainly suggests at this point that taking 2 doses of the Pfizer vaccine reduces your risk of long COVID. So the individual benefits that I've presented evidence for is that vaccines reduce asymptomatic infections, mild infections, severe infections, deaths, and long COVID. But it's really in the area of community benefits that the vaccines really perform exceedingly well. So here is a study published in the journal Science. It's an amazingly brilliant study. They looked at parents who've been vaccinated and parents who were not vaccinated. And they looked at the risk of infection in their children. And these are children who obviously were not vaccinated because the vaccines weren't approved for those age groups. And what they showed is that if the parents were vaccinated and got infected, remember, you still get infected in a proportion of vaccinated individuals because the vaccines are not 100% effective. So what they showed was that a parent who'd been vaccinated and got infected compared to a parent who was unvaccinated and got infected, that the vaccinated parents reduced the risk of spreading the virus to their children by 72%. Now, that is really important, because now that's telling us that individuals who are not vaccinated have an indirect benefit from individuals who are vaccinated. So being vaccinated is not only your own benefit, you are providing a benefit to the community. But it was in this study, published in the New England Journal of Medicine, that really nailed this problem. And what they did was they followed about almost 150,000 contacts of patients who were vaccinated or unvaccinated and who were positive by PCR. And what they showed is that if the person who got infected had 2 doses of the Pfizer, that there was a 68% reduction in the contacts of that individual. So you get infected, you've been vaccinated, but you got infected. The risk that you spread it to others is 68% lower. In other words, you will only infect 1/3 as many people. And what they did, interestingly, is that they divided the contacts in terms of people who lived in the same house, people who just visited them in their home, or people who were with the infected person at an event like a meeting, or people who worked with them, or who studied with them, who were in a university or school setting. And what they showed is that the 68% benefit goes across the board, that they showed that there was protection. If a person had 2 doses of the Pfizer, they reduced the risk of spreading the virus to their fellow people in their own workplace. How does that work? Why is it that vaccinated people reduce the risk of spreading the virus to others? Well, it does so in the following way. It does so through 2 mechanisms. In this paper in Nature Medicine, they showed that this vaccine that says BNT162b2, that's the complicated name for the Pfizer vaccine. But here they showed that individuals who got infected after being vaccinated compared to individuals who got infected and who were not vaccinated, they showed that vaccinated people had a much lower viral load. In fact, they showed it's about 10-fold lower. So they have less virus, and that's the viral load in their nose and the back of their throat. So the amount of virus that they bring up when they're speaking or when they're coughing or anything like that, they are putting out much less virus. But also in this study from Singapore, what they showed is that individuals who'd been vaccinated, they are infectious for a much shorter period. So people who are vaccinated are infectious for a shorter period, and the amount of virus that they put out is much less. And so that's why fewer people they interact with will get infected, right? So being vaccinated provides not only an individual benefit, but also a community benefit. So let me end off with some lessons for the future. What can we expect next? So you are very familiar with this diagram. It shows our 4 waves. The original first wave with the D614G variant, the second wave due to the beta variant, the third wave due to Delta, and the most recent due to Omicron. And what you can see in the first 3 waves, well, actually you can see across the board that we have a very cyclical epidemic. And you can, it's so consistent, the gap between the waves, that it enables us to predict when the next wave is going to occur, because it's pretty much 3 months between each of the waves. And if you look at each of the first 3 waves, the variants were getting worse. So if you look at the beta wave, not only were there more infections, there were more hospitalizations, and there were more deaths due to the beta variant. And if you look at the Delta variant, again, there were even more cases, even more hospitalizations, and even more deaths. So that has been the steady trend at a global level, that each new variant has been worse than the previous ones. Omicron has changed that. Omicron, instead of being more severe, has become less severe. And the way it became less severe is that some of the mutations enabled it to spread faster, but it doesn't infect the cells in the lungs very efficiently. In fact, it's about 10 times less efficient than the Delta variant in infecting the lung cells. So it doesn't cause severe disease to the same extent. But if you look at these trends, what can we say about these trends? Well, the first is that if you look at when we ended the Omicron wave and you look for 3 months later, that basically translates to the 8th of May. So we can expect somewhere in early May that we are likely to see a new wave. And that new wave is just based on the past trends. So if the past trends continue, we can expect that we are likely to see a new wave. But if we're going to see a new wave, it's most likely going to come from a new variant. And the reason for that is that a lot of people have already been infected with Omicron, and Omicron is pretty good at generating immunity to itself and to our other variants. So we are likely to see a new variant. We don't know what it looks like yet because it hasn't been discovered yet. We are waiting to see what the new discoveries will show us in terms of what pi might look like. But that's what we are expecting. I know we'd all like to think it's not going to happen. In fact, after Delta, many people said, oh, the virus can't get any worse than Delta. Well, it did with Omicron. Well, now we just have to wait and see if there's going to be a 5th wave. It's very likely there'll be a 5th wave. It's very likely there'll be a new variant and what that variant looks like. It should be pointed out that that new variant, pi, is very likely to be able to spread faster. If it can't spread faster, it'll have difficulty to overcome Omicron. It'll also have some level of immune escape. So we can expect that especially people with past infection are going to get infected with this new variant. And even people who are vaccinated, we're going to see more breakthrough infections. So that's to be expected, because if the new variant pi can't break through immunity, it won't be able to spread. It'll never become pi. But what we don't know, is the next variant going to be mild like Omicron, or is it going to be severe like Delta? And that is Hobson's choice. That's purely a matter of chance. We can't predict if the next wave is going to be more or less severe. So let me end off with just giving you some impressions of what pi might look like. I've already touched on this, and this comes from a paper published in Cell, where they looked at enhanced transmissibility with some immune escape. And so we will expect pi will spread faster, so the cases will go up faster. We can expect that there'll be more immune escape, but we can't really tell about its severity. So let me end off with a key lesson that we learned in HIV. And I've been working on HIV for over 35 years. So what is that key lesson I've learned from HIV that we can take forward in COVID-19? And that's the importance of mutual interdependence. That's the importance of shared responsibility. And I'll just quote you from a book published by UNAIDS. The book is entitled How AIDS Changed Everything. And in that book, it says the AIDS movement demonstrates that with a shared vision, a shared responsibility, and through global solidarity, we can change the course of history. And we have done so. We can provide antiretroviral in the most remote village in Africa, and we can do so consistently. So that's what we've been able to achieve in the AIDS movement. It took a long time to get there, but we were able to achieve it because of global solidarity, because of PEPFAR, because of the Global Fund, because people came to make this our shared responsibility. We all need to help to try and bring HIV under control. And that shared responsibility is also evident in COVID-19 in countries where the overriding philosophy is about caring for fellow citizens. Those countries tend to do well. In societies where they're just focused on me and me first, and I don't care about others, they tend to do badly in COVID-19. And this comes from several analyses that have been done. And it just reminds us that in a pandemic, we are fundamentally dependent on each other. And so no one is safe until everyone is safe. Thank you very much.
Thank you very much, Professor Salim Abdul Karim. Thank you for accommodating us also and shifting the time to join us. I'm going to now go over to the two very patient gentlemen, Professor Muhammad Jibe and Professor Rajan Naidu. I'm going to encourage you also to look, Professor Abdul Karim, at the chat box and at the question and answer box for questions that may have been put to you there. So I'm moving over to the UCT and UKZN duo, Professor Jibe and Professor Naidu, on the recommendations for future epidemic and strengthening occupational health systems resilience. What can be done? Over to you, gentlemen. I see the slides, but I don't hear. I'm not sure if you're muted still. Mohammed?
Hi, Ashraf. Thank you. Can you see my slides?
Yes, if you could maximize it, and I can hear you clearly. Thank you.
Can you see it now?
Yes, please proceed.
Thank you very much, and thank you for inviting us to do this presentation on recommendations for future epidemics and strengthening the occupational health system resilience. So what we are going to focus on is what is an occupational health system, just insight into the triad in terms of hazardous infectious agents. Very importantly, the relationship between occupation, socioeconomic status, and COVID-19, looking at some of the recognizable strengths of the occupational health system, the shortcomings of our response, and then focusing on recommendations for strengthening resilience of the system and identifying areas for future research. So at the outset, it's very important to understand what an occupational health system is. An occupational health system comprises various components. By far the most important and the sentinel component is the workplace. And as we are all aware, this is governed by the tripartite trade union, employer representatives, and government in terms of ensuring a healthy and safe workplace environment. Very importantly are the major government players in relation to occupational health and safety, as we've heard earlier on today, including the Ministry of or the Department of Employment and Labor, Department of Health, as well as educational institutions in relation to promoting occupational health and safety. And we also have an important component, as we are celebrating today, is a National Institute for Occupational Health. You're probably wondering why I'm using Bergen here. This was just to illustrate to you the various components of a system and to assist to what extent these various components are working in harmony to promote occupational health and safety. And we've heard a lot today about COVID, and Prof. Salim Karim has very eloquently captured for us one of the important components of this triad in relation to the virus. Equally important is the workplace environment, and thirdly, human behavior. And it is the intersection of these three components which results in increasing or decreasing the probability of transmission, infection, disease, and more severe consequences. So within that context, the workplace environment is but one component of the scenario in which COVID, as we have experienced and heard today, has been responsible for COVID transmission. However, it is very evident and clear from all our experiences that workers and working people come from an environment in which their living conditions, as well as their own demographic characteristics, as well as their health status, work in a way to either increase or decrease their risk of becoming infected. And as has been illustrated, while we saw to a large extent the experience around health workers, to a very limited extent have we seen the impact on non-health workers and what that has done in relation to both transmission of infection as well as the impacts that this has had on their health. And it is very important for us to understand this in order to move forward in terms of developing strategies for prevention and intervention. So what were the recognizable strengths of our occupational health system that contributed to where we are currently? And I'm not going to go through this in detail, as Lisa has very eloquently communicated the role of NEDLAC in bringing together the various stakeholders in government, employers, as well as unions, together with occupational health and safety support in terms of legal and academic support, in terms of addressing the issues in a coherent way. We've also heard from Barry around the occupational health stream in relation to the development of guidelines and the risk assessment tools that Cass has spoken about, which gave effect to these directives. We have also heard the experience of workplace-based occupational health services in dealing with the pandemic at a very local level. And then we've heard a lot about the online training and capacity building initiatives that were developed in response to COVID. And finally, we also had the development of a nascent online occupational health surveillance system aimed at COVID-19, which has the potential to provide dynamic reporting from workplaces if these were adequately resourced. So unlike others, I'm going to reflect a little bit on our shortcomings. And I believe that this is important in relation to understanding our successes, but also understanding our challenges going forward. And if we look, for example, at the national and provincial responses to the pandemic, what was very evident in the formative stages of the pandemic was our inability to respond rapidly as the pandemic unfolded. And one of the big reasons for this has been the fragmented way in which we approached the pandemic. As other speakers have mentioned, the exclusion of occupational health from the broader public health response at both national and provincial levels, and the adoption of a narrow infection prevention control approach did did much to contribute towards this lack of effectiveness. As I've indicated, there was a fragmented response of various stakeholders initially in government, in that we had approaches from the health sector, from the mining sector, from the non-mining sector, from the compensation authorities, and it was only later on when we tried to galvanize and combine them, their heads together and develop a more coherent response, were we able to work more efficiently. What has also been illustrated very clearly in one of the other presentations has been the limited focus on small-scale enterprises and the informal sector. And finally, there's also been alluded to the poor, one of the big aspects relates to enforcement of the legal provisions. And what was encountered is that we have underdeveloped capacity amongst our inspectorate to enforce the preventive aspects of hazardous biological agents. In as much as we have much more experience with regard to chemical hazards and physical hazards, the capacity for biological agents is limited. And then we also had the challenge of the delayed vaccine rollout to workers in high-risk economic sectors that also contributed towards the high disease burden that was experienced in the workforce. Then looking more at the workplace level, what COVID illustrated as has illustrated many deficiencies has been the decreased capacity of workplaces to respond. And by far, as others have mentioned, the poor level of occupational health service provision. Some studies estimate this to be less than 15% of all workplaces have got some form of occupational health service. And the underdeveloped occupational health services that have been delivered has contributed also to our suboptimal response. And this has been evident in the pandemic in the early days with regard to the poor level of risk assessments being done, as well as the following of non-evidence-based practices such as temperature screening and fogging, as has been mentioned by other speakers. The other important aspect has been the lack of capacity by workplaces to implement the COVID measures as outlined in the directives. And we've heard from the Department of Employment and Labor, the poor level of compliance with regard to the directives that were promulgated. Thirdly, the level of occupational health and safety training and capacity development was also suboptimal. Some studies showed that only about 50% of health workers received appropriate training in the early part of the epidemic, and only about 50% of them were confident about their overall knowledge of COVID-19. And this explains then the decreased capacity and agency that workers had in order to protect themselves. And by far, one of the biggest limitations has been the lack of a surveillance system to monitor the pandemic in relation to the South African workplaces. What we found in the early part of the epidemic, resorting to manual data capturing systems in workplaces in terms of symptom monitoring and reporting. The inadequate surveillance has been a major drawback in relation to the ability of our workplaces to respond to the pandemic. As you've heard earlier, only 3% of registered businesses were part of the occupational health and safety surveillance system. And this represented only about 12% of formal sector employees, meaning that for over 80% of workers, we had no insight as to what the patterns and trends of infection were. And as has already been alluded to, the poor sharing of surveillance data by official agencies in South Africa dealing with communicable diseases and the non-capturing of occupational aspects in relation to COVID hampered our ability to respond timelessly and to develop interventions that were lasting and that were more effective. And finally, as a result of that, we were unable to have a real-time insight into patterns of infection, morbidity, and mortality across economic sectors and occupational groups. And this resulted in our inability to develop appropriate interventions. I'm now going to hand over to Prof. Naidu, who will share with you the rest of our thoughts in relation to this. Thanks. Over to you.
Thank you, Mohammed, and thank you to the organizers of this very important webinar for inviting us to talk. So I think we're coming to the end of the day, and I think it's important now to sort of assimilate all the information that's been provided. These summaries, very useful summaries that Mohammed has just undertaken with regards to what were the successes and what were the shortcomings, because I think what we need to do is to use this experience over the last 2.5 years to prepare ourselves for what may come in the future, or even in the short term for the fourth wave, like Prof. Abdul Karim just mentioned. So when we start to think about recommendations, it's important to think about these at different levels. I have suggested here, for example, we think of them at national level interventions, and then workplace interventions. And I think quite a few speakers have drilled down to the workplace interventions over the course of the day-to-day, showing what we've achieved and what further needs to be done. But when we start to think about the national interventions, one of the key aspects that we need to focus on, and I think we've been speaking about this for several decades now, is how do we strengthen the fragmented and de-linked occupational health system that Mohammed alluded to earlier. We have multiple legislation, multiple enforcement agencies. We have the Department of Health, which is supposed to provide a more protective and preventative function. But to a large extent, these agencies don't talk to each other on an ongoing basis. So what we really need to look at is how do we develop a proactive framework for a comprehensive response. We were able to, under the auspices of the Department of Health, Occupational Health Directorate with Dr. Kisnasamy, form a technical structures which were able to respond to this. But we need something that is more sustainable and more proactive. So some agencies that can start to talk about how we identify and we prepare for the next major epidemic, next major sets of outbreaks. Mohammed spoke a lot about the surveillance and data, and we found this to be quite an important shortcoming, and we need to look at ways in which we can address this. I'm going to tackle some of these in turn, in detail, but just to speak about the workplace intervention, we know that the world of work has changed. Working from home has brought its new challenges, and to a large extent, we've not addressed that. How do we do this? What are the sorts of tools that we need to identify to understand risk, particularly in workplaces which don't have access to technical input, such as occupational hygienists? We need to focus extensively on how we improve ventilation, because this is obviously a key intervention for protecting ourselves against the virus. And then, of course, at a personal level, it is vaccination. Identifying measures and training methods so that we protect workers, particularly in settings where there is a low perception of risk. We need to look at ways in which we're going to expand occupational health services, and whether we start to talk about making changes to legislation and whether these now need to become mandatory. And then how do we support the marginalized workers, particularly in the small and medium enterprises and in the informal sector. I'm trying to change my slides. Okay. So when we speak about a new framework for occupational health, as we said, we currently exist in a situation where we have extremely fragmented system. We need to think about, should we look at something that is more integrated, focused, but importantly, an independent entity. We have several international examples of this, and we know that these tend to work well in most settings. And the question that we should be asking ourselves, does the National Institute, as it is currently modeled, or do we have a new National Institute within the National Institute of the National Public Health Institute of South Africa, with the NIOH having some revised mandates to be able to respond to pandemics and to other outbreaks that we see in the workplace? Mohammed mentioned about occupational health surveillance systems. Until we started to speak about the occupational health surveillance system that was developed specifically for the epidemic, we didn't have anything meaningful in this country. There are several examples internationally that are able to shape how governments, workplaces, and workers themselves can respond to emerging epidemics. And I think we have now got to look at how this works in the South African context. The occupational health surveillance system that was set up basically made use of, or basically was able to serve the health system in understanding which were the different sectors that are likely to be affected. However, this surveillance system was not as broadly adopted by workplaces in the private sector as we had hoped for. And this then starts to speak to our ability to predict where the problems are likely to be and where problems are likely to emerge. The question now becomes, what do we do with this vast or very important resource that has been established? How do we transform this to be able to continue to collect data, continue to provide a surveillance tool for workplaces in the country? And clearly, we've put in the infrastructure. We now need to look at how this becomes useful for us going forward. The third very important component that Mohammed alluded to as being an important shortcoming was data and the use of data for identifying our responses in different workplaces. What was clear that there were a number of different sources of data available in the country. I list some of them there, but what was more telling was that we failed really to integrate these different data sources for us to understand what is taking place in different workplaces, in different work sectors, and how do we intervene and put into place interventions that could improve the health of workers. If we, as we've been speaking about for the most of the day today, agree that work is an important driver in the transmission of infectious diseases, then we need to collect appropriate work data. And to some extent, we have been collecting that data, but because of our inability to integrate this data, we failed really to understand where are the places that we put in the appropriate interventions. So going forward, we certainly need to look at integration, and then we need to start to speak about what is the custodial arrangements that we have in terms of management of this data and accessing this information. If you look at in international settings, and I use here the example of Sweden, where they're very quickly able to respond to these epidemics because of the large number of databases that they have available and the fact that these databases are integrated. So for example, they're very easily able to use an infectious diseases database and link this to employment data and then determine which are the workplaces or which types of workplaces are being most affected by a particular epidemic. And we need to get to that stage where we can manage this. And this can be this will probably have to be the responsibility of the new Public Health Institute. So finally, in closing, we also want to focus on areas of future research. What we've seen emerging, and Prof. Abdul Karim has provided us with vast amount of data from international settings, but the area for work and understanding the impact of COVID-19 in the workplace is still very limited, both internationally, but particularly in South Africa. And the workplace dynamics in South Africa is largely different from what we see in the established economies of the world, and therefore it's very important that we undertake research in these settings. Tanusha alluded to some of the work that's already been undertaken by the NIOH, but we've got to identify the themes and the areas where we need further information. And obviously, it's the health systems in occupational health that we need to focus on. But we're also going to understand, are there particular occupations where workers are at greater risk for infection? And these may be, for example, the informal sector, in workplaces where workers are forced to work in close contact amongst themselves and with the public. We then like to hypothesize that there are certain occupations which may be at increased risk for the most severe outcomes, just by the very nature of the exposures that workers face in these settings. We know, for example, in our experience with HIV, that minors have a far greater risk for developing TB if they're exposed to silica and are HIV positive. So could the similar sort of scenarios play out with COVID-19, where if workers are exposed to these sorts of agents, they're more likely to have severe outcomes. In other words, not just becoming infected, but if they become infected, then they're almost likely to develop the more severe outcomes. And these could also, we've seen today how COVID-19 is very much an immunological disease. It triggers off a whole range of immunological reactions. We know workers are largely exposed to allergens in different working environments. Most of these are not documented. So is it possible that workers exposed to these allergens are going to be at greater risk? We know as well that people exposed or workers exposed to metals are at greater risk for developing pneumococcal pneumonias. And could this then also be a risk for them developing more severe forms of pneumonias as a result of exposure to COVID-19? Prof. Abdul Karim spoke a lot about long COVID, and we need to know how long COVID is going to influence recovery and fitness to work, and how we as occupational health practitioners are able to address workers. Do we speak about medical boarding? Do we speak about changed working environments? For what periods of time? How long do we make sure that we keep these workers at work? So a range of questions need to be addressed when we start to look at the concepts of these delayed recovery syndromes. And then, of course, the value of vaccination, particularly in the vulnerable worker. So we know that we're not going to have 100% protection for infection from vaccination, but what role does vaccination play in a vulnerable worker? And how do we make sure that we bring back vulnerable workers back into the working environment, but making sure that we protect them from having the more adverse outcomes of the infection. And then, of course, when we look at our ability to control the exposure to the virus, ventilation is a critical component for this. And the question is, what types of ventilation and how do we implement this in the different workplaces that we have? Because obviously not every workplace is going to be able to have the resources to provide the highest levels of ventilation that we'd like to see, but we need to have some modifications for those workplaces that are less resourced. And with that, thank you very much for once again, and congratulations to the NIOH for achieving this milestone webinar. Thank you.
Thank you very much, Professor Naidu. Thank you very much, Professor Jibai. I'm going to ask the panelists of speakers if there are any comments they want to make. You've now heard the presentation based on the observations, the experience, the shortcomings, and the recommendations that's been put. So I just want to open the floor for any of the current two speakers, as well as the other speakers on the platform, if they want to perhaps ask any clarification, make a particular comment or observation before we move on to our next aspect, which is just before closure. You can just open your microphone if you need to. If not, then we can pause with regard to this and ask, what do you see as, and I'm asking all the speakers, and I'm asking the NIOH and NHLS speakers as well, would be the sort of next step and the kind of road forward with regard to what I guess recommendations emerge out of this particular webinar, and how the conversations can in fact be taken forward. Okay, I don't see any takers.
So Ashraf,
yes, go ahead, Roger.
I think for me, I think what we need to do is, quite obviously, we've all been consumed by responding to the emergencies that we've had. And if we're going to expect a fifth wave, like Prof. Abdul Karim indicated, then we're probably going to be swamped once again. But I think we need to take a step back and then start to bring together the lessons we've learned. And I think this webinar has played a critical role in addressing that, and then decide what our next steps are in putting into place the interventions that are necessary to better prepare us going forward in time.
Thanks, Prof. Naidu. So because my sense is we've gathered today quite a significant range of stakeholders and contributors, and obviously those who can contribute to the ultimate aim of our webinar today, and that is the strengthening of the occupational health resilience for national emergency epidemic responses as it impacts on our workplaces as experienced with COVID-19. Okay, well, look, it is afternoon and the energy levels are probably low. We still have a significant number of attendees in attendance. At this point, I'm going to just leave that question as an open-ended question to all of our speakers, presenters, and panelists, and the leadership of the NIOH, how best to knit together the various elements of the conversation we've had today. So thank you very much, Professor Muhammad Jibai and Professor Rajan Naidu. Thank you very much for sticking throughout all of the presentations and putting together and sharing the recommendations with us. It is very much appreciated. I can imagine how the leadership of the NIOH is already thinking through the process we've undergone today and the nature of the recommendations that has been shared. Okay, so just before we close, there's two things we need to do, and one of it is to ask a colleague of mine, Dr. Ola, who's responsible for the IT infrastructure, the IT support, the thing that makes these Zoom sessions work, his colleagues and staff that makes these Zoom sessions, I think, valuable connections between those who present and share information and put challenging questions there, and our audience who webinar after webinar return to, I think, interesting conversations and interesting information being shared in essence for them to be able to be better at what we need to do around occupational health and occupational safety in the workplace with the TAETSATA. And on that note, I welcome Ola. He's going to quickly share with us a tool that the NIH has been working on and is refining and will be putting to the test in the very, very near future. One of the participants in the chat box asked, I've heard you talk about this particular, course. Where's more information? I just answered to say more information is coming soon. Because you are part of this webinar and you're part of the mailing list, you will be receiving more information about. Ola, are you ready to just share with us briefly what is in the baking, in the cooking there within? Oh, there you go. Your microphone is open. Please proceed.
Good afternoon, colleagues. Thank you for giving me the opportunity. Good afternoon, everyone. My name is Olaleko Samuel. So I think much has been said before. I just want to quickly show us what we've been doing behind the scene with the e-learning platform that was developed by the NIOH IT team. So, and I want to say a very big thank you to Dr. Spo, Angel, the head of information services at NIOH, and also Ashraf, who made this a huge success. There are a lot of people behind the scene, but because of the time, I will not be able to mention them. So as you can see, if you want to check up the site should be live in the next 2 weeks, but we have completed everything. We are just busy doing proper quality assurance for the NIOH so that we give you, we give the South African public the best when it comes to e-learning in terms of occupational health. So this is when you get into the site. When you want to log into the site, you just go to elearning.nioh.ac.za. elearning.nioh.ac.za. So when you get to the site, this is what you will see that you will land on. So those are the menus on top, and on that basis you can get to the course. We have different courses for now. These are some of the courses that we have put up on the platform. Some of the courses are not going to. Some are going to be free. Some are not going to be free as we move along. So most of the webinar courses training are going to be uploaded as part of the training for people who want to check on the site. The site itself, when you go through the training on the site, depending on what type of training is, if that training has a CPD point and certificate, a certificate will be automatically issued to you if you fulfill the requirement to attend that particular training. Please note that certificate will only be given if you fulfill the requirement to attend that training. I cannot tell you the requirement of a particular training, but more information will be provided on that particular training. So these are also the courses. You can also search the courses based on a price. You can search based on the price. When you get to the course, these are basically what you see. You can preview the course. When you preview the course, when you click on preview the course, you are taken to where the course is. The course description gives you on the description you have introduction. These are going to be varied. The reason is because it depends on each training facilitator on what they want to put on their training. So what you will have on prescription for this particular training might be different from what we'll have as description for this particular training. So please take note of that you might not be seeing the video, the same thing. Well, under that, you could see that we have curriculum. If the trainer wants to give announcement to all the participants, you see we have announcement up here. If after you've completed the training, you can review the training and give a feedback on some of the things that you like us to incorporate in the training platform, and some of the things that you would like us to take away. So that takes you to the curriculum, and once you click on the curriculum, all the contents are there. So once you click on each of the content, and then watch the video of the training. Yes, so if to say you click on this, for instance, you'll be presented with the video of that particular topic. And then by the side here, you will see other topics that you can also navigate through. And then, so after that, you can review, you can put a review for the training. And on the website, basically, we have also different links. On the courses, just what I've demoed to you. These are basically some resources when it comes to OHS that you can download freely. Information about the certification, you'll find it on this link. About us, definitely you want to know more about NIOH and training, and you want to contact Ashraf and his team, because they are basically in charge of this fully, so that if you have any question, you can contact them. And if you want to subscribe to the mailing list of this training, so that when new training comes out, you can receive the information, you can get it. And so that is basically it about the site. Once again, the site is on elearning.nioh.ac.za. But please give us at least 2 weeks before the site finally goes live publicly. But the site is already being used within the NIOH, NHLS, and NICD. Thank you. Over to you, Ashraf.
Thank you very much, Ola, for that. So also, in addition to that, there is the special edition of the OccuZone newsletter of the NIH. It will be focusing particularly on COVID-19. And my understanding is that that would be coming hot off the press tomorrow. So look at your inboxes, your email inboxes, regarding the availability of the OccuZone newsletter. And then finally, just to say thank you to all of our speakers. On behalf of the NHLS, Professor Eric Buch, Professor Koleka Mlisana, and on behalf of the NIOH, Dr. Spoor Galamono and Dr. Tanusha Singh, and then to get a national perspective with regard to the OHS workstream, Dr. Barry Kisnasamy, and that was followed by Ms. Aggie Malloy and Mr. David Msiza from the regulatory and enforcement and monitoring point of view. And then our multiple stakeholders. We've had Mr. Norman Koz on behalf of NEPAD, Professor Don Cox on behalf of SASOM, Ms. Denise Mini on behalf of SASON, Professor Cass Bardenas on behalf of SIO, Miss Lisa Seftal on behalf of NEDLAC, Mr. Cass Kuvadia couldn't join us today on behalf of business, Mr. Matthew Parks on behalf of Labour, and with a bit of swapping there, Ms. Dr. Christy Braham on behalf of WIGO. We've had the input by Dr. Ivan Ivanov. We've had the input by Professor Salim Abdul Karim, and then sort of at the end, tying it all together, looking at the strengths, the weaknesses, the shortcomings, the gaps, and coming up with certain recommendations was Professor Mamajibe and Professor Rajan Naidu. Thank you very much also to my colleague, Dr. Ola. I'm going to, while I'm talking, just quickly play that final slides that my colleagues managed to put together for the thank you, the honor roll. And unfortunately, not everybody could make available their photographs and bio sketches in time for all of it to be included, but will undertake to complete this particular exercise. So if I could just quickly find it, I think I found it. Yeah, I think it's this one. One moment. Do I have the right one? I think I do, yes. So I'm going to quickly start this whilst I'm just reading the final words of thanks. And it'll pop up in a moment. Okay, so thank you. Notes from my side, as all the speakers, to you, the attendees and the participants, to the NHLS, the mother body of the NIH, of which we're a division, the NIH leadership as led by Dr. Spoor and our office, as well as the sterling help there of her personal assistant, Maria, the OO team. I mean, it's quite clear that the group led by Dr. Tanusha Singh and now by Dr. Graham Chin has an integral and important role to play within the role of the NIHS in terms of the emergency response to pandemics and the lessons learned, the capacity built, and the energy and strengths discovered along the last 2 years. With regard to training, to the award subcommittee, this is the subcommittee where my colleague Angel Mzanele leads, and we have the head of occupational hygiene, Ms. Jeanette Mangani, and we have the current acting head of occupational medicine, Dr. Mpumi Ndaba, and myself serving on that subcommittee. Thank you for all of your hard work, colleagues. It is very much appreciated and has culminated in today's webinar. And then the IT team, there's 2 colleagues there, Tabani, and especially today, Glenn has been carrying the load for us and hosting this webinar today. Thank you very much, colleagues. You do a lot of things in the background. People don't always see it because all the problems you solve and the experience for the attendees is relatively smooth. Today, we've had quite a few gremlins, including the power shutdown, but we've managed. And to the communications and marketing team led by my colleague Shanaz, thank you for all of your hard work. That compendium that we've shared with our audience today is the outcome of the hard work, where you've captured the hard work of the broader team. And then to the information service and training team led by my colleague Angel. And there's a number of colleagues, they are mentioned in the compendium. Please go see the compendium on our website, and you can download a PDF version as well, which I've also posted on the chat group. And a reminder, so again, the OccuZone will be available tomorrow. Look out for it. And so thank you, everybody. I think my software is not wanting to play an MP4 here today, but we will place the video also on the website. Thanking all of our speakers. 158 of them have contributed, and a lot of them were also even in today's webinar over the last 2 years to the achievement of the 99 and today the 100th COVID-19 webinar. And with that note, I say thank you to all of you for joining us today and for staying for such a long webinar. And I think the content, the contributions from the broad range of people have certainly been worthwhile. On that point, I say thank you to everybody. Goodbye and see you on our next webinar.